Good morning. Welcome everybody. My great honor to open today this special event, the first ever International Cardio-Oncology Summit organized by Polish oncologists. Thank you very much for this opportunity. Everything became possible because our director decided to organize such amazing event. Thank you, my director. And I remember the day, that was the last day of May. So we organized this meeting during last 3 months. And I can confirm that almost 300 people registered for this event, mainly from outside of Poland. And this is a great pleasure and great honor for us. And today we will discuss about cardio-oncology, the new discipline which is growing very quickly, is developing very quickly. And we had the pleasure to have a special guest from Poland, from European Society of Cardiology, from International Cardio-Oncology Society. And I would like to show you our patrons. As you can see, many amazing patrons. The first one is the Minister of Health in Poland and International Cardio-Oncology Society, of course, Multinational Association of Supportive Care and Cancer, British Embassy in Poland, some universities, Warsaw University, Medical University in Łódź, Medical University in Poznań, Institute of Hematology, National Institute of Cardiology, and Polish Union of Oncology, Polish Oncological Society, Polish Society of Clinical Oncology, Polish Cardiac Society, and many others, Polish Lipid Society, etc., and Via Medica, publisher of the few eminent Polish journals like Oncology in Clinical Practice. So I'm very proud, and I would like to invite my director, Professor Beata Jagielska. Everything, as you could hear, everything was possible thanks to this person, medical oncologist, director of this institute.
Ladies and gentlemen, distinguished guests, it's my great pleasure and honor to welcome you to Summit on Cardio-Oncology Excellence 2025 here in Warsaw at Maria Skłodowska-Curie, National Research Institute of Oncology. Today's summit gathers outstanding experts and leaders from around the world to address one of the most pressing challenges in modern medicine, the intersection of cardiology and oncology. This meeting is not only an opportunity to exchange knowledge and experience, but also a platform to build international collaboration that will directly benefit our patients. I would like to express my gratitude to all speakers, partners, and participants for joining us and for your dedication to advancing excellence to this vital field. I wish you inspiring discussion and fruitful outcomes. Welcome to Warsaw. Welcome to Summit on Cardio-Oncology Excellence 2025.
Thank you very much for the first speech during this Congress. My pleasure to welcome and invite my colleague, my friend, Agnieszka Gorgon-Komul, Polish Senator of Polish Republic. Thank you for your coming.
Thank you very much. It's a great honor for me to be with you today in the Warsaw. Dear friends, medicine has made miracles. Cancer, once of death sentence, is now more and more often chronic disease. Therapies that were once only dreams are now part of everyday practice. But we also know another truth. Victory over cancer can sometimes come at the cost of the heart. The treatment that gives hope can also take away the strength to live. And that is why we are here. Because the patient cannot choose. They cannot choose between fighting cancer and protecting the heart. They cannot choose one victory at the price of another defeat. Cardio-Oncology is the answer. It's a bridge between two worlds. It's a promise that science and practice go hand in hand. The oncologist and the cardiologist stand side by side. Yes, there are many challenges. Yes, health systems are under pressure. Yes, progress doesn't happen by itself. But this is exactly why we are here. In this room are the best. The best scientists, hearts. If not us, then who? If not now, then when? Because if we act together, if we share our knowledge, if we have the courage to change the standards, then the patient will gain more than a therapy. They will gain life, they will gain a future, they will gain hope. This is our mission, this is our duty, this is our time. Thank you very much.
Great honor to have together with us our Polish senator of the Republic of Poland. This is very important for us. Thank you. And the next, my friend and colleague, we know for last 25 years, I think, maybe more, Professor Krzysztof Filipiak, the new director of the Center of Postgraduate Medical Education in Poland. Thank you for coming.
Ladies and gentlemen, distinguished guests, dear colleagues, dear Sebastian, it's a great pleasure to welcome you in this unique event and this international symposium, and I'm really very excited that I can be here with you. And when I was thinking why I'm excited with this summit and this convention, I came to the conclusion that it's because of three reasons at least. So firstly, I think cardio-oncology is very important. Yeah, we cardiologists, Sebastian is cardiologist, Ms. Senator Agnieszka is a cardiologist, I'm a cardiologist. We know that cardio-oncology is really very important. We see more and more patients every day in our ambulatory, in our clinic practice, patients coming with different cardio-oncological problems. So in fact, it's really quite important, and I think we really manage, we will manage to solve a lot of patients' problems in this field. Secondly, I think it's quite important because we now are aware that cardio-oncology should be a very important part of curriculum of specializations of cardiology, oncology. I'm looking at the National Consultant in Oncology, so we are planning to input cardio-oncology obligatory courses in a new form of specialization. And I'm really very happy that in this institution, I'm in Center of Postgraduate Medical Education, the first department of cardio-oncology was created some years ago together with the Institute of Hematology. The head of this department, you know, is a leader of Polish cardio-oncology, Sebastian. So I think it was a very good start for cardio-oncology development in Poland, just to create such a department and just to say that it's a very, very important field of area of oncology. And thirdly, let me be a little bit personal. I'm very proud of this young gentleman. I'm saying young because I know him from childhood, 30 years ago. I don't know if you know that Sebastian was firstly interested in general cardiology. He was interested in sport cardiology. He was one of the pioneers in Poland in ergospirometry, for example. Then he switched to cardio-oncology, and now he's a leading person in cardio-oncology in Poland. For sure, you know that he's the only Polish co-author of European Society of Cardiology guidelines on cardio-oncology. He's also a co-author of the new European Society of Cardiology guidelines on mental health in cardiovascular diseases. I haven't been talking to Sebastian on this case, but I've read these guidelines and I've seen a chapter about mental health problems in cardio-oncological patients. So I think he contributed, I suppose he contributed a lot to this chapter. So you really have a great expert. We really have a great expert here, and that's another thing to be excited to be in this symposium organized by Sebastian. On behalf of my institution, I'm in the Center of Postgraduate Medical Education. I just would like to greet everybody, to send greetings, to welcome you in Warsaw, especially those ones from the lecturers who came here from abroad. As you know, we are living not in a quite peaceful times. We are coming to a country which is bordering with Ukraine. Ukraine is fighting with Russian aggression all the time. But on the other hand, please remember that Poland is really very rapidly developing countries. We recently joined G20. So from this point of view, we are one of 20 most powerful economic countries in the world. So please enjoy not only this symposium, but please enjoy being in Poland, being in Warsaw. Please find some time to sightseeing Warsaw, and I think it will be a great time for you here. Thank you once again. Thank you, Sebastian.
Great pleasure. Thank you, Krzysztof. Everything was possible thanks to your support. We know many years, so thank you once again. And my great pleasure to invite the next special guest, the rector, new rector of the Medical University in Warsaw. And we discuss about postgraduate education. Now some words about undergraduate education in cardio-oncology.
Madam Director, Madam Senator, distinguished guests, esteemed lecturers, ladies and gentlemen, I would like to begin by expressing my heartfelt gratitude to the organizers for the kind invitation to take part in this conference on the rapidly evolving field of cardio-oncology. And I'm deeply honored to address you at the opening of this important, interesting and unique event. I take this opportunity to comment on the National Research Institute of Oncology in Poland, not only for initiating this conference, but also for its or yours addressing the staff of the institute, continued efforts and dedication to advancing oncological science, practice, and education. Your commitment to organizing high-quality meetings and conferences, such as ongoing summit on cardio-oncology, as well as recently held annual Maria Skłodowska-Curie Symposium on Cancer Research and Care, as well as your engagement in postgraduate training play a vital role in shaping the future of oncology, and not only Polish oncology, but also internationally. I'm also very pleased to highlight the excellent and growing collaboration between the Medical University of Warsaw and the National Research Institute of Oncology. This partnership includes both the undergraduate education and joint scientific research. I'm confident that this fruitful collaboration will further expand in the coming years, bringing new opportunities for both institutions. In this context, I would like to extend an open invitation for further collaboration. As a comprehensive academic medical center, I mean our university, we encompass virtually all clinical specialties. This creates a strong foundation for a number of interdisciplinary project initiatives, similar to cardio-oncology, addressing the complex needs of modern oncology through a truly integrated approach. As a practicing clinician, I fully realize how important it is to bring together specialists from different fields to work together. And this is really what happens on a daily basis at our university. So let me close by wishing you an inspiring and impactful and fully successful conference. Thank you.
Thank you very much. And now I know that special guest is connected with us from France, the president of Multinational Association of Supportive Care in Cancer. We enjoy this meeting at the Cancer Center. So, Florian, can you hear us?
Absolutely, I can hear you. Sorry not to be with you in presence, but I'm happy to participate to the meeting. Maybe can I start? So dear colleagues, dear friends, and dear Sebastian. So my name is Florian Scottet. I'm medical oncologist at Gustave Roussy Cancer Center in France, close to Paris. And I'm the current president of the Multinational Association of Supportive Care in Cancer. Can you hear me?
Yes, of course.
Okay, so it's a huge privilege to participate to the introduction of the Cardio-Oncology Excellence Meeting supported by the International Cardio-Oncology Society and the Supportive Care Group of the Polish Society of Clinical Oncology, our MASC Polish affiliate. Cancer and cardiac diseases are regularly combined for several reasons. The first one is that both are moving from fatal diseases to chronic diseases. Then patients and healthcare professionals have to deal with them daily in the long term. Many patients have an history of cardiac disease. Many patients will present cardiac disease during their cancer. Many patients will face cardiac complications related to cancer or its treatments during and after their cancer journey. Because all drugs, but also new anti-cancer drugs, can have specific tropism to the heart, the collaboration between specialists is today essential to the quality of cancer care. It is obvious that cardio-oncology is a huge part of supportive care, and I warmly thank Sebastian for his dedication to cardiology, cancer management, supportive care, and patients. The collaboration between MASC and ICOS has been hugely allowed by your involvement. We need international collaboration, integration, as it has been said previously. We need skills and everyone engagement to fight cancer, to support patients and their caregivers during and after the disease. We need to work together closely. It's the reason why I feel proud and happy to participate to the introduction of your meeting. And I wish a successful meeting. Enjoy this time. And your next step will be to join the MASC meeting, the meeting in Melbourne, Australia, in June 2026, June 25 to 27. Thank you so much, Sebastian, again, for your kind invitation, as usual.
Thank you, Mr. President. Thank you, Florian. You are our friend. So I believe that cardio-oncology is the special part of supportive care in cancer because we can improve quality of life and we can prolong the survival. So thank you for your nice words. And at the end of the opening ceremony, I would like to thank everyone for coming. And my private opinion, for last 20 years I have been working for cardio-oncology. and I didn't believe that it will be a time when we will host some special guests from Europe, from the USA and Canada, because Susan is born in Canada, and Susan built the first Canadian Cardio-Oncology network, and after that time she moved to the USA, to the Duke University earlier, and after that you enjoy the Mayo Clinic, so University of Rochester. And great honor to collaborate with International Cardio-Oncology Society, with the Council of Cardio-Oncology at European Society of Cardiology, and many other specific societies. And I'm proud that we include our oncological, hematological, and cardiac societies from Poland. It's my proud and my pleasure. Thank you for coming. And it's time to open the scientific part of the Congress. We will hear the experts from different places around the world. The first session will chart my best friends, my next director from the Institute of Hematology, Professor Eva Lech-Maranda, will support us from hematological side. Please lead this session together with my friend, Professor Maciej Krzakowski, the most important people in Polish hematology and oncology, national consultant in hematology and national consultant in clinical oncology. So you understand, we believe cardio-oncology is very important. The floor is yours.
Thank you, Sebastian. It's a great pleasure for us to welcome you today. My name is Eva Lech-Maranda, and together with my co-chairman, Professor Maciej Krzakowski, we are delighted to lead the first session of today's meeting. And the first lecturer will be Professor Beata Jagielska, who is the director of the National Skłodowska-Curie Maria Skłodowska-Curie National Cancer Institute in Poland, and she is a leader in the development of cardio-oncology in Poland as well. And Professor Jagielska will present the inaugural lecture. Dear Professor, floor is yours.
Just short technical remark. We've got a lot of time because we are a bit ahead of time, so the questions will be after all presentations.
Thank you very much, ladies and gentlemen. Today is a special day for us. The first summit on Cardio-Oncology Excellence 2025 is taking exactly 100 years after the cornerstone was laid for Radium Institute, fulfilling dreams of our patron. Oh, it's a problem, please. My presentation. So, a minute. Oh, it's okay. So, the history of our institute, it started from 2035. And the next very important date, 2032, there was official opening our institute, and after the Second World War, the institute reopening in January 1945. 1951, the most important date, 2 branches, Krakow and Gliwice, was added to the main localization in Warsaw. 1977, a new building was opened on Roentgena Street, where we are today. Currently, our institute realizes our activities in 3 localization. We employ 5,800 employees. We realize many benefits. 1,100 hospitalization, 470,000 outpatient visit, 134,000 pathological examination, 14,000 genetic tests, 10,000 surgical procedures, 11,000 radiotherapy procedures, and over 100,000 chemotherapy sessions and drug programs treatments. Our institute is very active in many fields, for example, primary, secondary prevention, national oncology strategy, national oncology network, personalized and precision medicine, and of course, cardio-oncology. Here is the largest cardio-oncology department in Poland in the cancer centers, but before we established this, we asked a very important question: what is the cardiotoxicity? Is the result of oncology treatment or is the result of comorbid disease? Maybe the both. But the next very important question is cardiotoxicity related to effects of the single drugs or the specific regimens. It's no doubt that essential to know how individual drugs affect the heart and what is the synergistic effect is. This is the specific regimens. And this is my favorite slides. Why? Because this slide illustrates exactly that happens the cardiomyocyte as a result of the action of anthracycline, first lady of oncology and powerful oxidant. But the most important, that the slide shows that they truly need cardiologists in our daily practice. Of course, we cannot forget the negative impact for treatment, for supportive treatment, because this supportive care can lead to fluid retention, QT prolongation, or increased blood pressure. And what is oncologist's perspective for cardiotoxicity? Of course, knowledge of the systemic treatment. The next, knowledge of negative impact of supportive treatment on cardiotoxicity, comorbidities, and opportunity to obtain support from a cardio-oncologist, because cancer patients compete for access to a consultation with patients without cancer. And I think that is the problem not only in Poland, but in other countries. Other focus on cancer treatment efficacy, balancing oncological outcomes with cardiac safety, monitoring long-term side effect. Cardiologists, the most important point is definition of heart damage and assessment of the degree of heart damage. Considering the toxicity scale used by oncologists, it is essential to understand when, what, and which scale should be used. This is very important because sometimes a specific adverse event is grade 2 according to the CTC scale, this is oncological scale, but for example grade 3 according to the cardio-oncology scale. So it's completely different situation. And another very important point, cardiological intervention in aspect of patient survival. It's no doubt that oncologists should inform cardiologists of intention of the treatment. Completely different situation is for the patient is the intention of radical treatment, completely different in palliative, or for the patient in terminal situation. Collaboration. Of this, the most important is development of cardio-oncology as specialized field. Of course, we need cardiologists, but first of all, cardio-oncologists. For us, cardio-oncologists is this specialized which can speak in the same language together. And some words about our cardiology department. It was established in December 2012. Now is the part of the Clinic of the Breast Cancer and Reconstructive Surgery. Coordinator of this department is the Dr. Sławomir Jacek. Thank you, Sławek. You are together with us. And some numbers from 2013 to 2024. Hospitalization, 2,413. Unique patient in this department, 2,275. Interdepartment cardiology consultation, 6,869. Echocardiographic examination, the most popular test for us, 54,215. And consultation for outpatients, so 33,513. It's really the huge number of consultations. And in the end, for us, very good information, the success of my team, because our department, cardiological department, was qualified to the National Cardiology Network in the Mazovia Voivodeship for the first level cardiology care. Thank you, Sławek, thank you all your team. For us, it's a very great success because Cardio-Oncology department is in the cardiological network. Thank you very much.
Thank you, Professor Jagielska, for excellent presentation, and we cordially invite you to take a seat next to us, because as Professor Krzakowski said, the discussion will be at the end of this session.
Okay, now I have pleasure to invite Dr. Suzanne Dent, born and bred in Canada, graduated from the very famous McMaster University. At the moment, she's director of the Cardio-Oncology program at the University of Rochester. The floor is yours, please.
Thank you. Thank you for the organizing committee for inviting me, especially for Sebastian. I have known Sebastian for a very long time, and just to put things into perspective, I am Canadian. I formed the Canadian Cardio-Oncology Network and held meetings in Ottawa, Canada for a number of years. That was in 2011. So I've been in this space for a long time, and it's just great to see how cardio-oncology has grown globally. So I was asked to speak about achievements in cardio-oncology care, a perspective from the president of ICOS, and these are my disclosures. I think the first thing to recognize is the burden of cancer and cardiovascular disease. So in 2022, it was estimated there were approximately 20 million new cases of cancer globally. And at the same time, you can see in that year, there were 20 million deaths due to cardiovascular disease. And importantly, for many patients, unfortunately, who survive their cancer, they will go on to die of cardiovascular disease, which may have been due to pre-existing risk factors and or the complications related to their cancer therapy. What's really amazing, I think, to see in the world of oncology is the number of new drugs that are in the pipeline to improve oncology outcomes. And as you'll notice in this graph, we've moved away from the traditional cytotoxic chemotherapy drugs such as doxorubicin, the platinums, and so on, to much more targeted therapies as we have a better understanding of some of the pathways that are aberrant in cancer development. You can see here in 2023, there were over 2,000 clinical trials in cancer, which is just astonishing. And importantly, 125 novel substances in the past 5 years that are currently under investigation. And on the right, you'll just see some of the countries that have been heavily involved in these trials. So for the cardiologists in the room, the cardio-oncologists, just wait. You think it's busy now? Just look at those drugs. So you're going to actually be busier as we have more and more of these drugs coming into the clinic. And importantly, the advances in oncology care has led to improvement in survivorship. So you can see here, these are the statistics from the United States showing the increasing number of survivors that we are expected to see in the next several years. And globally, there are over 53 million cancer survivors worldwide. And it's not just those individuals that survive or are cured from their cancer, but increasingly, we are seeing individuals living with advanced cancer. So these are statistics from 2018 in the United States, but at that time there was about 640,000 individuals living with advanced cancer. And what we're observing now is that those individuals will have the opportunity to go through multiple lines of systemic therapy. So it's people cured of cancer that are important, but we can't forget about those people who are living with cancer and their cardiovascular health. Of course, as you saw earlier, there are a number of different cancer therapies that lead to cardiovascular toxicity. And so this is just to remind us, it's not just anthracyclines, it's just not heart failure, but many of our cancer therapies can lead to things such as myocarditis with immune checkpoint inhibitors, valvular heart disease, hypertension, and a whole myriad of cardiovascular issues from different therapies. And this will continue to grow as new cancer therapies become available. And what's important about understanding this is that any of these can lead to early termination or cessation of cancer therapy that may be curative, but importantly, again, in those with advanced disease may be life-sustaining. And so more often than I would like to see, I've been referred patients who were on curative or life-prolonging therapy that have had their therapy stopped prematurely because of concerns of cardiovascular toxicity. So how do we work together to overcome that? Well, we work together by forming partnerships. And so this is sort of a picture I've shown many times, but I think it's important to understand the many oncology and cardiology organizations out there that promote the collaboration of these two entities to form strong cardio-oncology partnerships, including, of course, the International Cardio-Oncology Society. So what have we achieved in cardio-oncology care over the last time, at least decades or time I've been involved with that? Well, I think it's a roadmap, and this is obviously evolving, but what we have seen over the last several years is more basic science being done around looking at mechanisms of cardiovascular toxicity as newer drugs come into the pipeline. We have now seen a better understanding or come together on looking at cardiovascular toxicity definitions. So how do we define it? Risk prediction. What are some of the strategies for early diagnosis? And then how do we prevent it and treat cardiovascular toxicity if it occurs? So I'm just going to highlight a few of these areas, and certainly I can't cover it all, and you'll be hearing more about this throughout the day from different presenters. So I think this is just one concept that's really important. I think that we now understand about global hematopoiesis of indeterminate potential in cancer. So now we know that hematopoietic stem cells can undergo mutational changes, and that this leads to what's known as CHIP, and that with further mutations, patients can develop leukemia. But importantly, we also know this is associated with cardiovascular disease, and that in a pro-inflammatory milieu or state, these patients can develop cardiovascular disease as well. And so now you are seeing CHIP clinics emerge, at least in the United States, to identify these patients who are at risk. So we can't necessarily change that risk, but we can identify who's at risk and subsequently screen those patients. And I think the idea of reverse cardio-oncology is also really important. We've also always looked at cardiology, oncology separately, separate diseases, separate entities, but now we have a better understanding that if you actually do have cardiovascular disease, if you do have an MI, that creates a pro-inflammatory milieu that can also lead to increased risk of cancer. So it's not just cancer patients developing cardiovascular disease, but we can see this going the opposite way as well. And while we think we understand about anthracycline-induced cardiotoxicity, and I didn't look in the literature exactly, but there are like hundreds of papers published now looking at the mechanisms of anthracycline-induced cardiotoxicity. Do we really understand it? And we continue to sort of explore this. And this is just an interesting paper that was published in the European Heart Journal recently looking at patients with AML. So they actually took cardiac myocytes, a biopsy from an AML patient, and they also looked at a mouse model and discovered that interleukin alpha may actually contribute significantly to cardiotoxicity in those patients, in this case, who were exposed to daunorubicin, an anthracycline analog. So we continue to learn that maybe anthracycline cardiotoxicity is not as simple as we think and may be different with different compounds in different people. how do we define cardiovascular toxicity? I think this is fundamental. I'm old enough to remember when we first talked about type 1 and type 2 cardiotoxicity, which really was quite simplistic. It really talked about reversible or irreversible heart failure, and that was sort of how it was defined. So that we've grown from that definition to understand now that it's not that simple. And so in this ICOS paper published a few years ago, we now understand there's different types of cardiovascular toxicity depending on the mechanism, the class of drugs. And within those different types of cardiovascular toxicity, we're now developing universal definitions. So at least we can speak the same language when we're talking about cardiovascular toxicity. And also in this diagram, I've adapted this from the ESC Cardio-Oncology guidelines, but we now understand that cardiovascular risk is something that occurs not just at the time of cancer therapy, but patients come into their cancer with underlying cardiovascular risk. We then expose them to cardiovascular agents that may be toxic, including, of course, radiation, which we can't forget about. And then as these people survive, hopefully for many years out, they're aging and there's risks associated with long-term side effects, particularly in the area of radiation. So what can we do to try and at least recognize and actually hopefully prevent some of that cardiotoxicity? So I'm going to talk a little bit about how we assess people up front in terms of risk prediction. So this is the HFA ICOS risk assessment tool. It was published in 2020, and it was really the first attempt to identify those patients at risk, not just based on the drug that they were exposed to, but their underlying baseline cardiovascular risk factors, previous exposure to cancer therapy, comorbidities, and if available, any previous cardiovascular imaging and biomarkers. This risk score was looked at several classes of cancer drugs and then came up with an actual score that would place patients at a definitive level of risk, either low, medium, high, or very high. When this came out, a lot of this was based on knowledge at the time, but also expert opinion. So there was a lot of criticism about this tool. Now, fortunately, we have at least one paper now and more coming looking at validation, or at least using this in a different data set. So this paper was published just last year looking at the Cardiotox Registry. This is a registry in Europe where they collected data on patients undergoing potentially cardiotoxic therapy. And in this study of just over 1,000 patients, these were patients that were exposed to anthracycline-based chemotherapy, most of them lymphoma or breast cancer patients. And they categorized them according to the ICOS ESC tool. And essentially, it turned out that the correlation was quite good in terms of the ability of the tool to predict who was at low versus high and very high risk. And this correlated with overall survival and the rates of symptomatic and asymptomatic cancer treatment-related cardiac dysfunction. And we're now starting to see more tools that are perhaps more specific to the disease entity that you are treating. So this is called the CARE BMT Cardiovascular Risk Calculator. It was published just here in JAMA. And they looked at a multi-center study of over 2,400 patients with stem cell transplantation over a number of years and identified variables that were predictive of cardiovascular events. They came up with this risk calculator and a point-based system, and they looked particularly at cardiovascular events, a composite, including cardiovascular death, MI, heart failure, stroke, AFib, and sustained VT. And then they validated it against an external data set. And so this really was reflective of the 5-year cumulative incidence of a cardiac event. So I think we are going to see some more of these very site-specific calculators. And then, of course, you could talk for half an hour even more on the influence of artificial intelligence in the medicine, and it's not just medicine, well, it includes cardio-oncology as well. So this is just sort of a snapshot of some of the FDA-cleared tools now for use of AI in cardiology, but also these are now being explored in cardio-oncology. So there are AI ECG algorithm models looking at the ability to detect AFib, particularly in patients with CLL and leukemias, but also an AI ECG algorithm looking at the ability to detect left ventricular dysfunction. And so this is just one study that was recently published looking at AI-enhanced risk stratification. Essentially, they took patients that had breast cancer, lymphoma exposed to anthracyclines, but did a baseline ECG, and then also had an echo as well. And they looked at this high versus low risk baseline risk score. and this algorithm was able to help predict who would develop left ventricular dysfunction. So the ESC guidelines tell us that we should be focusing on prevention strategies for those patients who are very high risk. But I would allude that many of these studies that have been done up to date have mixed results, many negative studies, and you're going to be hearing about this again in the next section. So this is an individualized decision. But what about SGLT2 inhibitors? They really sort of are out there everywhere. They lead to better cardiovascular outcomes. In cardio-oncology, this is exciting in terms of the ability of SGLT2 inhibitors to perhaps decrease cardiovascular toxicity in cancer patients with diabetes, which is, of course, the indication for this drug. So these are small retrospective studies that have shown some benefit. And as you're going to hear in the next session, there are ongoing prospective studies looking at the role of SGLT2 inhibitors in terms of prevention. And then what about during cancer therapy? Cardiotoxicity is certainly an issue there. But permissive cardiotoxicity, I think, is the other concept that's very important for us to understand. This really emphasizes that rather than stop therapy if there's a little bit of cardiotoxicity, can we really push forward, working with the oncologist, cardiologist, and the team to allow someone to have life-sustaining therapy. Now, the issue is there have been very few studies in this area. Most of these studies have been retrospective, observational, in very small populations of individuals. For the most part, the endpoint has been looking at greater than 90% completion of chemotherapy, and so these studies would indicate that this is a really reasonable thing to do. However, we probably do need some more prospective, larger studies to really confirm that this is reasonable. So Scholar 2 is a study that's being led by a colleague of mine in Hamilton, Ontario, Canada, Dr. Leong, essentially taking patients with breast cancer exposed to HER2-targeted therapy and randomizing them to standard of care versus continuing with the addition of primary prevention strategies, continue with the HER2-targeted therapy to see if patients complete their treatment. So this study has 17 sites globally and 53 patients accrued. So one of the largest prospective studies looking at that strategy of permissive cardiotoxicity. And then what do we do for those patients who develop cardiovascular toxicity? This is prediction of poor prognosis in ICI-induced myocarditis. So they took a registry of patients who had developed myocarditis and essentially developed a clinical risk score for those patients. And then they validated it against 2 external data sets and actually showed it was quite predictive of the severity of myocarditis should you develop that during cancer therapy. And then I just want to conclude in the last couple of minutes, what about after cancer therapy and survivorship? I don't think we can forget about this. When we look at survivorship, we have to realize, again, it's not just the cancer therapy that they were exposed to. So in this study published in 2024, looked at social determinants of health and cardiovascular health of cancer survivors. And to remember, social determinants of health encompasses many things, including socioeconomic, environmental, and psychosocial factors. And in fact, what this study showed is if you have a poor social determinants of health, this adversely affects your cardiovascular outcomes in cancer survivors. Our patients are getting older, and so we give them drugs, of course, and as older individuals, they are exposed to some toxicities that we may not have observed in the trials because we tend to study younger people. But this study looked at frailty of our patients. So if our patients are frail, what is the risk of them experiencing an adverse cardiovascular event? And in this study, they measured the frailty index for patients with women undergoing early-stage breast cancer receiving adjuvant chemotherapy. And what they discovered is that actually, if you're frail, not surprisingly, you have a much higher incidence of experiencing an adverse cardiovascular event. But I just think this is important to remind ourselves that this can happen. So we're seeing the introduction of great new cancer therapies, but of course, research in this area of cardio-oncology is going to continue to be very, very important, right from the very sort of preclinical understanding mechanisms of toxicity through to preclinical research and looking at how that impacts overall patient care. Remember, of course, when we're thinking about research, it's important to understand what we're measuring and we're working together. So this group, the Cardiovascular Safety Research Consortiums out of Duke University, brought together a number of stakeholders during COVID and published this paper, really they included a number of government agencies, professional organizations. And really, this was an attempt to say we need to work together, we need to speak the same language, and we need to make sure we're measuring cardiovascular toxicity in cancer trials appropriately. And here's just an example of the advances that we've made. This is a common terminology criteria for adverse events that we commonly use in oncology. And this was just published in July of this year, which speaks to now they're starting to talk about the specifics of what does left ventricular dysfunction mean so that we can measure it more appropriately. Importantly, we're all measuring the same thing. So finally, I just want to conclude by saying, as we make advances in cardio-oncology, whether that be through risk prediction, screening, primary prevention, prognosis, we really need to focus on how we're going to implement that in the clinic. And in this nice diagram, talks about survivorship care, but the key will be in implementation of what we are finding in these studies. As that, I'd like to conclude and just, of course, invite everyone in person or virtually to our Global Cardio-Oncology Summit, which will be held in beautiful Cape Town, South Africa, October 30th to November the 1st. And if you can't attend again in person, there's a virtual option as well. And then just want to thank you again for inviting me, but also want to sort of devote this talk to our patients. I think that's why we're here. It's all about patient care. And I had the opportunity these are two of the individuals I know, one living, having survived early stage breast cancer, and one living with advanced breast cancer for now 12 years, who both experienced cardiovascular toxicity related to their treatment, but fortunately are doing well because of the collaboration between cardiology and oncology. Thank you.
Thank you, Professor, for your excellent talk. The discussion will be at the end. And now let's welcome Professor Raul Cordoba-Mascuaño, who will guide us through the topic of a hematologist's view on cardio-oncology. Professor Raul Cordoba-Mascuaño is the Associate Chief of Hematology and the Head of Lymphoma Unit and Fundación Jiménez Díaz University Hospital in Madrid. He is a former European Hematology Association board member and EHA liaison with European Society of Cardiology and the member of the Council of Cardio-Oncology of the ESC. Professor, the floor is yours.
Thank you very much. Dziękuję za zaproszenie. I hope it has sound a bit of Polish. I cannot speak anymore in Polish. It's very difficult for us. Thank you very much for the invitation. As Professor has introduced me, I am Raul Cordoba. I am a former board member of the EHA, the European Hematology Association, and I am the liaison between the EHA and the ESC Cardio-Oncology Council. So my task today is to review with you the perspective of a hematologist in the cardio-oncology field. And as I am a lymphoma doctor, because I mainly see patients with lymphoma and lymphoid malignancies, I'm going to focus my presentation in patients with lymphoma. I don't have nothing to disclose with regards of this presentation. So to start, I have to say that, in my opinion, we hematologists, I think we do a good job in order to do a baseline risk assessment. Probably we do not do very well standardized, and probably we have to learn how to implement this standardization. But at the end, we are aware about the cardiovascular toxicity along the patient journey during the treatment and the life of patients with hematological malignancies. We are used to performing baseline cardiovascular risk assessment, but for sure, with the upcoming of new drugs, we have to update our protocols because at the end, there are more drugs rather than anthracyclines that at the end are going to induce any kind of cardiovascular adverse event. We know that most of our patients with hematological malignancies are going to live for a very long period of time. Fortunately, many lymphoma patients are going to be cured, and sometimes other malignancies are going to be transformed from the malignancy to a chronic condition. So probably many patients are going to live a very long life, and we are going to deal with these long-term survivors, and we have to monitor the late adverse events that may happen in this subgroup of patients. For sure, we are now facing in the field of hematology the upcoming of a lot of new drugs with new mechanisms of action. We started to use targeted therapies that are prescribed in a continuous fashion, but now we are moving to a fixed duration therapy. So we have to balance between the risk and benefit of this continuous therapy versus the fixed duration therapy. Because if not, if we prescribe a continuous therapy, we are putting the patient at risk of developing these adverse events during the entire life. So therefore, we should perform the cardiovascular risk assessment, not only a baseline, that is what we are doing right now, but also we have to check it during the therapy continuum. This cartoon probably has been presented previously by a professor, but what I want to highlight is that the main drug that we use to treat our patients with lymphoma, and we are going to cure patients with lymphoma with these drugs, with anthracycline, we are learning now the mechanism of cardiotoxicity. We knew that anthracycline were going to induce cell DNA alteration, but now we are learning that anthracyclines are going to have an impact also in the mitochondria. Mitochondria is going to have, probably is going to play a pivotal role in the development of cardiotoxicity, but also in the development of cardiotoxicity. So probably in the future we are going to keep the eye on the mitochondria in order to prevent and also to reverse the cardiotoxicity. And the other drug that we don't have to forget is cyclophosphamide. Cyclophosphamide is an alkylating agent which is going to bind the DNA and is going to impact the DNA in the cancer cell, but also is going to have an impact in the energy metabolism through the mitochondria. So again, two drugs are going to have an impact in the cell damage. And when I was working in this presentation, the first thing that came to my mind was, oh my God, we are combining these two drugs to treat our lymphoma patients, cyclophosphamide and anthracyclines in CHOP-like regimens. So at the end, we are increasing the risk of cardiovascular toxicity in our patients with lymphoma. And with this, I found this review published several years ago about the mortality in long-term survivor patients with lymphoma, mortality related to cardiovascular disease and not because of lymphoma progression. And that's something that we already knew, but in this study, the authors collected all the publication with regards of this cardiovascular toxicity, and we found that the standardized mortality ratio was increased in lymphoma survivors, not only in Hodgkin lymphoma, but also in non-Hodgkin lymphoma patients. So in 2018 was published this paper, and in our institution we decided to conduct a retrospective study about what was going on in our patients with lymphoma. So we collected patients with lymphoma, both Hodgkin and non-Hodgkin, that were treated with anthracycline, and we found an impact in the development of cardiotoxicity in the overall survival of our population. So those patients who developed cardiotoxicity were going to have less chance for survival with this hazard ratio of 2.2. And we wanted to know what was happening in our population, because at the end populations may be different among different regions and countries. And we found in the multivariate analysis these 4 risk factors for the developing of cardiotoxicity: dyslipidemia, age above 72 years old, previous cardiovascular disease, and the elevation of baseline NT-proBNP. And if we analyze the presence of these risk factors in the time to developing the cardiotoxicity, we found that we didn't find any difference between those patients with 0, 1, or 2 risk factors. So we gathered all together in the low risk group, and there were differences between this low risk group versus those at intermediate risk, defined those patients with 3 risk factors, and the group of high risk with 4 risk factors. And we found around 15% of patients developing cardiovascular adverse events, even in low-risk patients. And what it was surprising was that all patients, 100% of patients at high risk were going to develop a cardiovascular adverse event. And when we analyzed these risk factors, not only in the development of cardiovascular adverse event, but also the impact in survival, we found that those patients with no risk factors were going to have the expected survival, so at the end in lymphoma patients around 80 to 90%, but those patients with these 4 risk factors in our population, we found a very dismal survival. So with this, and with this new concept of cardio-oncology, we started thinking in Spain about how we should move from this single condition focused approach to care, where the patients are going to be seen in the clinic in silos, completely separated, and with no communication between the cardiologist and the hematologist. And we thought that we had to move to a more multimorbidity approach to care, where the patient is put in the center of a healthcare system, and we had to focus more in how the person's health condition and the treatment interact with the quality of life, the person's individual needs, the benefit and risk of prescribing this sometimes curative approach to treat and to cure the hematological malignancies, how we can improve the quality of life by reducing the treatment burden, and of course, how we could improve the communication among all the healthcare providers when it comes to cardio-oncology. Because when we have a very complex process, in patient complexity needs a patient-centered approach, at least when it comes to cardio-oncology. And thanks to this, we had the ESC guidelines, the first ever guidelines in cardio-oncology. And it was for me a great honor to be the liaison between the EHA. The EHA didn't only endorse the guidelines, but also we participated very actively in these guidelines. And it was for me a great honor to be this liaison between the EHA and the ESC. So to continue, the second question that I asked myself when thinking about this presentation was, do hematologists doing well in doing this baseline risk assessment? Probably you are going to see this cartoon many, many times during this summit, but from the hematologic point of view, I believe that not all patients are at the same risk at baseline. We know that patients must be assessed before the start of chemotherapy with the potential of cardiotoxicity. The risk of cardiotoxicity may vary among cancer therapy, and don't forget that if we are going to cure people, these people are going to age, and probably new comorbidities may appear during these patients' follow-up. So are we hematologists doing well with regards of baseline cardiovascular toxicity risk assessment? I think we do it pretty well. We collect in the past medical history about the previous cardiotoxic therapy. We collect previous cardiovascular disease. We collect data as age, sex, medical risk factors, lifestyle factors. And before starting chemotherapy, we always check for the left ventricle ejection fraction in the transthoracic ultrasound. Probably what we have to start doing better is in doing an ECG and to start collecting data of cardio biomarkers in order to validate the use in patients with lymphoma. Because at the end, if we follow the guidelines, the ECG and the cardio biomarkers are going to help us, the hematologists, in order to identify which patients may be at high risk in order to be referred early to the cardiology clinic. And something which is very interesting from my point of view as a hematologist is all the tools that the different societies are providing to help us. And I think this tool is very relevant because not all previous cardiovascular disease are going to have the same impact in a patient if we treat them with different antineoplastic drugs. So for example, if we are thinking about treating our patient with anthracycline-based regimen, probably the most relevant previous cardiovascular diseases, heart failure, myocardial infarction, angina, but not probably the QTc prolongation. So we have to think what's going to be the targeted therapy in order to identify what is the risk of our patients. And for this, I think the HFA ICOS is a very good tool to help us. And Dr. Sen has previously said that it was criticized because it was not validated, but today it has been validated in patients with treated with anthracyclines. So to me, it's very easy to do this and to have this score, and if the patient is at high risk, to early refer the patient to the cardiology clinic. And something that we have to start doing is to do it in a more standardized way in order to identify which patients are at high or very high risk, because the risk of death is, or the developing of cardiovascular adverse events is very high, to identify this group of patients for an early referral to the cardiology clinic. How are we doing in the surveillance? Are we doing as well as we do in the baseline cardiovascular risk assessment? Probably not. Probably here we have to improve much more, because I think, in my opinion, we do pretty well in the baseline risk assessment, but we do not follow the ESC guidelines with regards of the monitoring of patients during treatment and then in the by the end of therapy. Because in high and very high risk, the ESC guidelines recommend us to collect and to do the cardiac biomarkers prior every single cycle of chemotherapy, and it's not very commonly used across all countries, at least in Europe. And it is recommended to do a transthoracic ultrasound every other cycle, and we always forget to do this. And something which is very relevant is to do at 3 months at the end of therapy and 1 year by the end of therapy. And we usually also forget about this. And it is something happening almost the same when we pay attention to patients receiving hematopoietic stem cell transplantation. We perform everything before the hematopoietic stem cell transplantation, but we usually forget to recheck again the heart health at 3 months and 1 year after the stem cell transplantation. Another field of interest is Hodgkin lymphoma. Hodgkin lymphoma is commonly diagnosed among younger patients, but there is a second wave of incidence around the age of 60. And we call this group of patients older patients with Hodgkin lymphoma. So in other populations in non-Hodgkin lymphoma, we call older patients those patients with 80 years of age or above, but in Hodgkin lymphoma, we call an old patient at the age of 60 or above. And it's because the toxicity that we are facing with in this group of patients when treated in the same way as younger patients. So concerning about this, we conducted a retrospective study in the Spanish lymphoma registry. We collected more than 600 patients with an age of 60 or above, and we tried to identify the relationship between the age, frailty, and comorbidities in the survival of older patients with Hodgkin lymphoma. And we found that the age was going to have an impact, and we have found the same cutoff of 72 as our study in our institution. So those patients with 72 years or above were going to have a poorer outcome. With regards of frailty, we found that the impairment in the baseline activities of daily living, so at the end self-care management, and the instrumental activities of daily living, those patients with impairment were going to have worse outcome in comparison with those that are completely independent. And when we check for any presence of geriatric syndrome, we found the same. Those patients with any geriatric syndrome were going to have a poorer prognosis. And when it comes to comorbidity, we commonly use in patients with hematological malignancy the SIRS score in order to grade the comorbidity. And we didn't find any clear correlation between the SIRS-G, the total score, and the survival of our patients. But when we reviewed the 14 categories that are collected in the SIRS-G, we found that only SIRS-G cardiac comorbidities were going to have an impact in work survival. And probably what we have to work is to harmonize the definition of these comorbidities, these cardiac comorbidities in the CTCAE, in the SIRS-GIP, the ESC guidelines, ICOS, HFA, because at the end, sometimes we are using different definitions and we are not collecting the same information. And just to conclude, if we know that we are going to increase the risk of cardiovascular adverse events in our patients with hematological malignancies, we have to think about strategies to prevent this cardiovascular toxicity associated to cancer therapy. And that's why we decided to start working in different approaches. And this trial, probably you all know about this, the Resilience trial, which is a randomized study that is conducted in 6 European countries. It's a trial funded by the European Commission, and we are collecting patients with a lymphoma receiving anthracyclines with at least one risk factor, and the experimental arm is we are evaluating the remote ischemic conditioning program in order to prevent the cardiotoxicity. And as we are a bit under recruitment rate, we are going to extend the recruitment until December 2026. So probably the first results will appear in 2027. So to conclude, I think that we should perform this pre-treatment cancer therapy-related cardiovascular risk assessment, and it is recommended to use a more standardized tool in order to communicate better among different stakeholders. HFA ICOS tool has been validated in patients with anthracyclines, so probably it can be one of the tools that we can start using. For sure, we need to implement the measurement of cardiac biomarkers. There are some papers. We also found the NT-proBNP in our own study, but probably we have to study better in prospective clinical trials. Cardiac comorbidities have an impact in the survival of patients with lymphoma, both Hodgkin and non-Hodgkin lymphoma. No doubt that we have to develop strategies to prevent cardiovascular toxicity because we are going to have very long-term survivors, and they are still under investigation. And something that I always say in my conclusion is that everything is collected in the ESC guidelines, so we just need to read the guidelines and follow them. Thank you very much for your attention. Dziękuję.
Thank you for your lecture. That was really interesting. Now we have a pleasure to invite Professor Giuseppe Giuliano. He's a director of the Early Drug Development Division and co-chair of the Experimental Therapeutics Program at the University and the Institute of Oncology in Milano. And he's president-elect of European Society of Medical Oncology. Congratulations, then. And his talk will cover a very important issue, how to use anti-cancer treatment with no jeopardy on patient's heart. Please.
Thank you very much indeed to all the organizers for the very kind invitation. And in the next 20 minutes, I will try to address the topic on how to treat cancer without harming the heart. So I mean personalized cancer therapy strategies. Why this is an important topic? First of all, because we know we have many patients that are cured. Actually, the overall survival rate increased dramatically for patients with diagnosis of early breast cancer or any other disease. And number of cancer survivors in the United States by calendar year and time since diagnosis are increasing dramatically. As of May 2025, it is estimated that there are 18.6 million cancer survivors in the United States. These represent 5.4% of the population, and I believe this slide should give us the opportunity to think about the opportunity to reduce the potential burden of toxicity in these patients. What's about cardiovascular mortality? So in the meta-analysis published on cancer medicine, with all the limitations we may have from meta-analysis, there is an overall 55% increase in cardiovascular mortality when compared to the general population. So receiving a previous anti-cancer treatment may potentially increase the risk of cardiovascular toxicity. So individuals are considered survivors from the time of a cancer diagnosis through the rest of their life. That's why, in my opinion, cardiovascular health should be matched completely with oncological health, because we have a cancer survivorship care, including follow-up for monitoring of recurrence, promoting healthy behaviors, coordinating of care, offering support service, assessing genetic risk, alleviating financial impact. But we have also something to do in cardiovascular health. And if you check here, cancer survivorship care with cardiovascular care, we have exactly similar goals, because management of acute and long-term toxicities, healthcare delivery, management also of a policy in order to guarantee the optimal care of these patients is a main goal for both fields. So what's about risk, potentially of long-term or acute-term effect in this patient population? Survivors have been defined as in this Danish population-based registry published just a few months ago on the GACC, are defined as free of both cancer and treatment 3 years after diagnosis. And for each cancer survivor, 5 cancer-free individuals from the general population were randomly selected and matched by birth, year, sex, and calendar year. And the participants were followed from the index date for up to 5 years. And if you check here, in the selected study outcome, the risk of cardiovascular disease in cancer survivors is strongly dependent on the cancer type and the prior systemic treatment, with more risk of atrial fibrillation, more risk of ischemic heart disease, and then, of course, we have other type of side effects. Of course, survival is not so good, but if you consider specific disease like lung, there is higher incidence of cardiovascular events. And if they received chemotherapy, there is much more toxicity rather than those who received a targeted therapy. So that's why I believe the title of my talk is really interesting. Should a tailored treatment with a de-escalation when needed or an escalation when needed reduce the burden of long-term side effects in the context, of course, of cancer patients who survived? Here we have an overall analysis of the outcome, and when we consider the cardiovascular risk, we have some specific side effects that are related to platinum compounds that can also increase the risk of thromboembolism. Baseline assessment is essential, in my opinion. This is almost an old guideline now, but baseline risk for cardiotoxicity are still considered previous cardiovascular disease, demographics and other cardiovascular risk factors, previous cardiotoxic treatment, and of course lifestyle risk factor like smoking, alcohol, and obesity. Don't forget that in the ERA trial, the first trial to assess the use of trastuzumab in the adjuvant setting, the main risk factor for heart failure were obesity, smoking, and hypertension in that patient population. So what we have to do in order to reduce the risk of cardiac toxicity? Screening before anti-cancer therapy, primary prevention therapy. Now we have many data with several studies demonstrating that you can, during treatment, prevent the risk of cardiac toxicity using also active cardiovascular treatment. Of course, during cancer treatment, we need to perform a cardiac safety surveillance. And in the post-treatment, of course, survivors of anti-cancer therapy. And of course, what we need to better understand if new treatment may impact on the overall cardiac health. What we do in practice to define cardiotoxicity. So what we do actually, based on left ventricular ejection fraction, we define toxicity, any left ventricular ejection fraction decrease more than 10% to below 50% with or without any cardiac heart failure. So if we go to consider, of course, which treatment may potentially impact on heart failure, I would eliminate anthracyclines because, to be honest, today, at least in the solid tumor fields, medical oncologists are very well trained, so they avoid to give an overdose of anthracyclines. Less common, of course, is an heart failure related to other agents. I mean, bevacizumab, trastuzumab, pertuzumab, several tyrosine kinase inhibitors. So when we show these numbers, it's important to remember that these numbers are referred to a period where the awareness on cardiac toxicity was not so high. Of course, the timing of cardiac toxicity dictates the clinical presentation and outcome. So beyond a baseline safety assessment, it's really important to understand that we need, of course, to monitor the activity of specific agents, also knowing which is the median time to onset of a cardiovascular event. Cardiotoxicity can be, of course, completely different. And why is completely different? First, because several organs can be affected, and the mechanism of action of induction of cardiac toxicity is completely different. Just to remind to you, the new generation treatment, tyrosine kinase inhibitors, may affect cardiac health in less than 1%. Immunotherapy less than 1%, ADC 2 to 3%, in the PARP inhibitor is rare, and endocrine therapy and CDK4/6 inhibitor is 2 to 7%. What to do finally? Screen before anti-cancer therapy. Assess the use of primary prevention therapy and continue during cancer treatment, cardiac safety and surveillance. ESC guidelines of 2022 usually have exactly a similar approach. So the cardio-oncology care pathway usually, again, stress the concept of baseline cardiovascular toxicity for risk assessment. And then once you identify patients according to the risk, you differentiate low risk, moderate risk, and high risk, and you approach them for a cardiology referral. To be honest, in my comprehensive cancer center, we have a cardio-oncology unit since 20 years. So, you know, it's quite usual in the large comprehensive cancer center to have a cardio-oncology unit. What is important is to increase awareness in the general hospital in order to have also in those centers a cardiac evaluation. So what we have to do, of course, to assess the medical history, to assess the cardiovascular risk factors, to better understand the previous cancer history, and then in the very high risk, consider every time to evaluate and to refer to a cardio-oncology unit. In those with moderate and low risk, consider to apply a risk-adapted echocardiographic monitoring. I believe that the recent ESC guideline of cardio-oncology endorse a risk-adapted approach. And I really believe that the monitoring schedule and this type of approach is more easy, at least for those centers in which you don't have a cardio-oncology unit. And finally, in patients with cancer, of course, assessment of risk and risk definition is the first step. And eventually, for entire two directed agents, don't forget that we have a major risk for those who received anthracyclines. But now, since the topic of my talk is personalized, in the neoadjuvant or adjuvant treatment, it's quite unusual to deliver anthracycline. And we know that in those patients who did not receive anthracyclines in the neoadjuvant adjuvant setting, the risk of cardiac toxicity for entire two directed agents is close to zero. Also in those patients that are obese, we have to come back to the word. We understand that cardio-oncology awareness is an important point, but in very well-trained centers in which we have comprehensive cancer centers, there is a complete de-escalation of the anthracyclines in many patients with HER2-positive disease. And the risk of cardiac heart failure in those patients who never received anthracycline is zero. So I would like to know from the oncologist over there, how many of you observed a cardiac toxicity with an IPT regimen using only paclitaxel etrostilsuma? So this is important to be remembered, but don't forget that now we really personalize treatment. Of course, if you have elderly patients with the left ventricular ejection fraction less than 50, and of course, potential risk of toxicity, this doesn't mean that you don't have to treat. You need to be really more, of course, careful in order to assess the cardiac function in a more easy way. Of course, also in patients with obesity, diabetes, hypertension. So during cancer treatment, in this beautiful paper, of course, in which there is an attempt to match the cardiology societies and the cardio-oncology societies guidelines, including also the NCI-CTCA guidelines. If you have a grade 2 with the resting ejection fraction to 40 and 50%, and or a 10-19% drop from the baseline, of course, you should stop treatment and waiting for a recovery. But personally, in my clinical practice with the new generation of agents I use, it's quite unusual to stop treatment because we have a strong interaction with colleagues working in the cardio-oncology field. Sometimes we have now phase 1 studies. This is really interesting. Use of bispecifics targeting HER2 may increase the risk of cardiac toxicity. Why? Because the bispecific target at the same time HER2 and also PD-L1. And in these studies, actually, it's also mandatory to do cardiac biomarkers. This is very interesting because all these data have been generated from the field of cardio-oncology. And so usually it's mandatory to perform analysis of troponin and BNP. And if there is an increase, of course, it's mandatory the use of cardioprotectant. Baseline, of course, is every time recommended. And if we compare international guidelines, finally, in terms of adjuvant monitoring, we have 3 months, for every 3 months for the first year. In the risk adapted is 3 to 4, and every 6 months for the second year. And in the EST, we have 1 echo within 12 months, but I would like to remind that we need also to understand which is the risk and the label of that specific drug. So in conclusion, cancer therapy actually may generate some agents in which you have more risk of toxicity, but personalized treatment may help us to resolve. And one of the new wave of agent is immunotherapy, and myocarditis can be observed in clinical practice. I saw some of them. Immunocheckpoint inhibitors can activate the immune system. And when discussing about immunocheckpoint inhibitors myocarditis, of course, the incidence is between 0.04% to 1.14%. Of course, what we need to do is to start as soon as possible corticosteroids in order to have a rapid resolution of the autoimmune disease. Quite uncommon is the cardiogenic shock. And of course, biomarker evaluation, as I said before, is mainly incorporated in clinical trials. Don't forget that today we have angiotensin-converting enzymes inhibitors. I personally use them in my clinical practice when I see the necessity to use them. So identifying patients at cardiac risk, in my opinion, is the main point. Beta blocker can reduce the risk of cardiac toxicity. And the use of cardiac biomarkers, in my opinion, do not have a high level of recommendation. They should be used in the context of clinical trials, or for some patients that you consider at high risk. Personally, I believe the most important thing for a personalizing care is to promote a healthy lifestyle. I am trying as ESMO president to match with ESC not on the issue of cardiotoxicity, but specifically on the issue of primary prevention, because you did a huge job on primary prevention. And in my opinion, it's really essential to work together specifically in this field, because this is really important. And finally, we need to use new tools, telemedicine tools, or patient-reported outcomes. Because if you work all together with the artery partners, of course, monitoring of blood pressure, monitoring of cholesterol, exercise, this is exactly the ABCDEF approach of the ESC guidelines. I believe we need exactly similar approach also in cancer patients, because the role of scientific societies are not only to promote development of cardio-oncology, but also to promote development of lifestyle that may benefit both on the cardiovascular health and in the reduction of the risk of cancer. So thank you very much indeed.
Thank you very much for your excellent talk. And now we cordially invite all speakers to join us, and we start the discussion. Take a seat, please.
The floor is open for your questions. Go ahead. If there are no questions, I would ask Dr. Susan Dent. We oncologists love guidelines, practice guidelines. We love it. And we love American guidelines as well as ESMO guidelines. The last version of cardiovascular guidelines presented by ASCO, it was dated, as far as I remember, 2020 or 22?
Actually, the ASCO guidelines are even older than that.
Do you plan to join forces with ESMO, for example, and to prepare the mutual guidelines? Because the last, or one of the last slides of Giuseppe, there were differences in the measuring in the monitoring of cardiotoxicity. I think this is a time to unify, to a certain extent, to a certain logic extent, the guidelines.
So thank you for that question. So I was fortunate to be involved in the ESC guideline, the ESMO guideline, and the ASCO guideline. So I can say that I have put forward to ASCO a request to update the cardio-oncology guideline, which I think is back in 2018 or 19. It's quite old now. And remember, when that guideline was written, it was written specifically around anthracyclines and HER2-targeted therapies. It was very limited. It did not address any of the modern cancer therapies that we have. So yes, I would say that I am still requesting that, realizing that ASCO there's a lot of competition, right, out there for new guidelines and to renew guidelines. So that request is in. Having said that, and of course, I think it's always great to combine forces with other organizations. One of the issues with the ESC cardio-oncology guideline, it's 131 pages. It's very cardiac focused from an imaging perspective and follow-up. So we at ICOS have joined forces with MASC and are going to be publishing a document that is what I would say a drilled down version of the current guidelines that will focus on what does an oncologist need to know, bare bones, what does an oncologist need to know to provide good cardiovascular care for the cancer patient. And so we are hoping to present that at the MASC meeting in Melbourne next June, and it will be published jointly in the ICOS and the MASC journals as well. So that's a start. But I think you're right. I mean, I think we really do have to make sure that we are all working together, and importantly, that we're recommending the same thing. One quick comment just about biomarkers, because I think this is so contentious, is that every meeting I go to in cardio-oncology, we talk about biomarkers, measuring biomarkers at baseline. That is not happening in most cancer clinics. And I think that we really have to be somewhat realistic about what are the expectations of oncologists for ordering cardiac biomarkers.
Hematology.
So I think, you know, that's, of course, it's, and I would also argue, I mean, I'm not even convinced that as many people as should have them are having baseline ECGs, which is a pretty simple test to order, but we should be doing that probably more frequently. And I would argue even those patients on immune checkpoint inhibitors are not having baseline ECGs, and that's just, you know, so important. And there's so much information that can be gained from that now, particularly in the new era of AI and the capabilities of what we can learn from ECGs.
I think very important is to stimulate international registry of cardiovascular problems in total, because there are probably differences from country to country and from the gender to gender and race to race, but the solid registry is very important. Okay. Professor Miranda has a question.
Okay, works? Okay, I have a question.
Working?
No, not yet. Okay. I have a question to Professor Raul Cordoba about your opinion. What is the most challenging unmet need in integrating cardiac care and hematological treatment protocols?
Thank you for the question. I think I have addressed it during my presentation. I think the first thing is to standardize the way of measuring everything.
Yeah, because in hematology we don't have it, actually.
I think we are collecting almost all the data baseline, but not in a very well standardized way. And probably if we conduct a retrospective study, probably you and me are going to have the same data, but not done routinely. And probably what we have to work is in developing any kind of clinical pathways, and probably to identify which patients are at low or very high risk, and to order these assessments from the very beginning in order not to forget anything. For example, in my experience, we know that we are going to see all patients at 3 months at the end of therapy and 1 year after the end of therapy. We are going to do a disease assessment. Why not to do a cardiac assessment? I never forget to request a CT scan. Why I forget, and I am very interested in working in the field of cardio-oncology, why I always forget to ask for an echocardiogram. I always forget about it. And I think if we work in these clinical pathways, probably we are not going to forget this very relevant information.
So we should change our clinical practice as well.
Just wanted to make one comment on that. And I think one way that we can try and do that is, in many parts of the world now we have electronic medical records, and at least as an oncologist, we put in our treatment plan in that record. Perhaps one way of doing this is building this in as sort of a prerequisite as part of the plan. So when that patient is, being set up to have their chemotherapy, not only are you ordering the blood work that you need for the chemotherapy, but you're throwing in there the echo and the ECG. So that's just so that there isn't a lot of thinking that has to happen from the oncologist's perspective. This is already built in the plan, and I think that would be perhaps really useful, because honestly, if you're in a busy clinic and it's not automated, you probably are not going to do or think about it.
Quite a specific question to you, because from your CV, I know that you're mostly interested in breast cancer treatment. The question goes with CDK4/6 inhibitors. There are 3. They are very similar in activity, but they have different toxicity profile. And one of them, I do not mention the name of the drug, but one of them is with cardiac toxicity. Right. Do you, in your practice, in your clinical practice, do you perform any pre-testing before deciding on the use of CDK4/6 inhibitors, or how to manage the symptoms of cardiotoxicity?
So you're right. I mean, there are 3 CDK4/6 inhibitors that have been approved in treatment of metastatic disease, hormone receptor positive, HER2 negative. One of those CDK4/6 inhibitors is associated with risk of QTc prolongation. So the FDA requires that you do a baseline ECG in all those patients. And I think that is actually, the uptake for that by oncologists is very high. So baseline, and then day 14 of cycle 1, we do one, and there used to be another one at cycle 2, day 1. They have dropped that because usually if you see QTc prolongation, it's within the first 4 weeks. So we only have to do 2 ECGs. The interesting thing, and so I think we are doing them, and I think that what's happened there, in the real world, is that they're all pretty much equally efficacious in terms of progression-free survival in the metastatic setting. However, one of them is there's more survival data or stronger survival data for the one that requires ECG monitoring. And so if you're going to go by clinical efficacy, then I think you should pick the best drug, and then you should determine how you can handle the potential toxicity. Because in actual fact, QTc prolongation, I mean, are we allowed to say the drug? I mean, I don't see why not. I mean, QTc prolongation with ribociclib, it's actually very rare.
R at the beginning of the name of the drug.
Okay.
R, okay.
Okay. And the number of individuals who had to stop therapy because of this was very low. So in my mind, as an oncologist, you always want to pick the drug you think is going to give the best efficacy for that patient. Where it is very interesting now is, as you know, there are 2 CDK4/6 inhibitors approved in early stage breast cancer. That's for those individuals at high risk.
Both are reimbursed in this no. One is reimbursed in this country, another one is on the list to be reimbursed.
Okay. So in the United States, 2 of them are approved. One, of course, is ribociclib as well. And so again, I think I don't think the potential for QTc prolongation should deter you from prescribing that therapy if you think that therapy is best for that individual that has the strongest data. So I think that's why we're here, right? To try and determine if we can give the best therapy.
Your conclusion is not be frightened.
Not be frightened, and I think that's right. I mean, the same thing happened when we first start giving trastuzumab, and oncologists used to stop trastuzumab if the EF went to 48%. I think most of my cardiology colleagues would say that's ridiculous, but we were doing it because we were so focused on that number. Anything less than 50%, we stopped. Even not understanding that if you had two people reading that echo, you would get two different numbers, probably. Right, and so I think that we have to. That's why we're working together to understand, you know, what. First of all, how common is that toxicity, and what can we do about it if that's the best drug? It would be the same thing with myocarditis and immune checkpoint inhibitors. I mean, less than 1% incidence. Are we not going to give an immune checkpoint inhibitor because there is, you know, a 0.5% risk of myocarditis? So I think, as oncologists, it's our job to determine the best drug. As the cardiologists or our cardio-oncologists, we want you to help us give that drug safely.
Got your point. All right.
If I may
Yes.
add the example in hematology, in the case of BTK inhibitors, we have three, one of them with a worse cardiovascular safety profile. And as I said in my presentation, now we try to move from this continuous therapy to a fixed duration therapy in order to avoid late adverse events. One of the combination of this BTKI inhibitor with BCL2 inhibitors is a fixed duration therapy, only 12 months, so we are going to prevent late toxicity, but we have seen that in all the patients and with previous cardiovascular conditions, we saw in the clinical trials early cardiovascular deaths. So at the end, we have to balance this risk-benefit balance in patients. And when I am thinking about prescribing this fixed duration therapy with a BTKI and a BCL2I, I refer all the patients to the cardiologist in order to get the clearance. If the cardiologist doesn't tell me that she or he is confident about to start this fixed duration therapy, I would never start it. So she is going, at the end, my cardiologist, she's an expert in cardiology, so I am not. So I need her help in order to identify which patients may benefit from a more efficacious therapy, but at the end, I don't want to put the patient at risk of death in the first 12 months because of cardiovascular deaths. So I think we have always to balance risk benefits.
And I think that's why we need to have cardiology colleagues who understand the oncology drugs. And so I can remember first starting in cardio-oncology, and I refer my patient to a cardiologist, and their answer would be, "That's easy, just stop the drug." And so it's really a cardiologist, while we're understanding, who to refer and doing baseline risk assessment, I think from the cardiology side, it's understanding that drug, the mechanisms, the potential cardiovascular risks, and the importance of that therapy for that individual patient.
So to sum up, the most important is cooperation between cardiologists, oncologists, and hematologists to improve the survival of our patients, I think.
We do thank you for the very interesting lectures and discussion. Thank you very much.
Thank you very much, and we invite you all for a short break.
Thank you. That was excellent session. Thank you for your opinion, discussion. We have 10 minutes for discussion outside the session, and we will continue with the second session together with Professor Piotr Rutkowski, Professor Fendler, and Peter van der Meyer from Netherlands. 10 minutes for the pause, break. ladies and gentlemen, I invite everyone to the room. We can open the next session, the special session with the president of Polish Research Agency, with the president of Polish Oncological Society and new chair-elect of Council of Cardio-Oncology at ESC. So Professor Peter van der Meyer, Professor Rutkowski, Professor Fendler. Great pleasure to announce this session, and I propose to make discussion after each speech because it will be more easy for the speakers and for the understanding of the session. Thank you very much. I open this session. And the request for the attendees online, you can scan the QR because in this way you may receive the certificates.
Okay. So I'll start from here. Sorry. Hello, everyone. It's a great pleasure to be here. Today I am a government official, not a scientist, which I miss dearly. And as I represent the Medical Research Agency of Poland, it is a particularly great honor for us to be here, and we greatly appreciate that we have so many ongoing clinical trials, some of which, I guess all, even in this session, are funded by the MRA. And again, this, I believe, would be impossible 6 years ago. We wouldn't just have this type of clinical projects in Poland. And through this landmark shift that Poland decided to make, and create an agency that allows Polish researchers to obtain funding for non-commercial trials, these things may happen. So the dreams of actually doing clinical research in Poland at high level with decent funding right now is our reality. And it is, again, a great pleasure and honor to have wonderful researchers in Poland doing their best and, well, pushing the horizons forward in clinical care and making patients get access to better treatment. And for the first speaker in this session, I would like to invite Dr. Maciej Drybusz, who works at the Department of Cardiology at the Silesian Center for Heart Disease in Zabrze, to have his talk about the mainstream trial. The floor is yours.
Thank you very much, dear Chairman, ladies and gentlemen. This is my huge pleasure to be here standing in front of you, representing all the co-investigators of the mainstream trial, but first and foremost, the primary investigator of this study, Professor Mateusz Tajstra, who is leading the project. And I would like to share with you some of the details of the design and rationale of this study. Ladies and gentlemen, I do not think that in such a renowned community we should dwell too much on the significance of the cancer treatment, but also on the possible interactions with cardiovascular system and cardiac cancer therapy-related cardiac toxicity. Among pharmacological methods that have been studied to date, beta blockers, sartans, or their combinations have been studied with various results, and to date, no pharmacological strategy for the prevention of cardiac dysfunction is irrefutably proven to benefit in all patients with cancer. And the ESC guidelines on cardio-oncology, as well as the most recent update of the guidelines for the management of dyslipidemias, mention some of the group drugs as those that should be considered in some of the patients of high and very high risk of cardiac toxicity. Among those, ACE inhibitors or sartans, beta blockers, and statins are recommended, as well as dexrazoxane or liposomal anthracyclines. In patients with chronic heart failure with mostly reduced ejection fraction, another drug that has not been studied to date in cancer patients, at least sufficiently, is currently recommended as standard way of treating those patients, as it has been shown, for instance, in the Paradigm HF trial. The sacubitril valsartan has been shown to reduce the risk of clinical endpoints, benefiting by the reduction in all-cause mortality or heart failure hospitalizations in patients with reduced ejection fraction. Similarly, in patients from the Pioneer HF trial, these patients with de novo or decompensated heart failure also substantially benefited when compared with standard therapy with ACE inhibitor. In patients with cancer, sacubitril valsartan has been studied mostly in the retrospective way, although in the recent days a few of the results of also prospective trials have been published. However, in those available, sacubitril valsartan has been not only well tolerated, but also was associated with substantial improvement in both clinical presentation of those patients as well as the laboratory parameters of congestion or imaging modalities. I also don't think that I should mention how significant the breast cancer is for both individual patients as well as what impact on the societal level it has, and the trends suggest that its prevalence, mortality may still be increasing also in Europe. And based on all of the caveats that I have already mentioned to you, we have designed the mainstream trial, which should first of all answer the question whether sacubitril valsartan could act as a cardioprotective measure against placebo in patients treated with breast cancer. As mentioned by Professor Fendler, we are very grateful to have the support of the Medical Research Agency as the trial is funded by the agency. On the right-hand side, you can appreciate the patient leaflet that is distributed to encourage patients to participate in the trial. On the left-hand side, you can see the most important information regarding the trial. The trial was initially designed to be performed in 3 supra-regional oncological centers in Poland. However, the 4th one will join us in the coming weeks. The population targeted is estimated at 600 patients, and after the estimated dropout due to drug intolerance, 480 will be randomized in the 1-to-1 fashion to either sacubitril valsartan or a matching placebo. The follow-up duration has been designed to be 24 months, and we are at the recruitment phase. The primary outcome has eventually become a decrease in left ventricular ejection fraction by or more than 5%, assessed on echocardiography within 24 months from the randomization, and the secondary outcomes include both clinical as well as the imaging or biomarker definitions of cancer therapy-related cardiovascular toxicity, as stated in the ESC guidelines on cardio-oncology. Who can participate in the trial? Well, first of all, patients with histologically confirmed breast cancer in the stages 1 to 3 or oligometastatic stage 4, who have left ventricular ejection fraction of at least 50% and are in the sinus rhythm at the time of inclusion. And these patients should have a radical treatment plan, including surgery and systemic treatment with pre- or post-operative anthracyclines and or anti-HER2 drugs. The exclusion criteria refer mostly to patients who have already undergone treatment with anthracyclines and or thoracic radiation therapy, as well as patients with already developed heart failure or those who have contraindications to take sacubitril valsartan as the studied drug. The study procedures that have been designed throughout the trial, first of all, as you can appreciate in the figure, the patients undergo transthoracic echocardiography and laboratory assessment, and they are initiated on the dose of 49 plus 51 milligrams of sacubitril valsartan in the single-blinded phase of the study. After 6 to 8 days, the dose is up-titrated to 97 plus 103 milligrams, and pending tolerance of the highest tolerated dose, patients are randomized in the 1-to-1 fashion to either sacubitril valsartan or placebo, and then the systemic cancer treatment is initiated. As you can appreciate, the patients undergo routine echocardiography at 3, 12 and 24 months after randomization, and naturally when symptoms suggestive of symptomatic heart failure occur. Initially, we have planned to perform cardiac MRI in all of the patients. However, because of multiple reasons, we had to eventually neglect this idea, and so the study endpoint will be assessed with the use of transthoracic echocardiography. Apart from those assessments, also Holter ECG, as well as laboratory parameters will be evaluated. The genetic biobanking will be performed in a selected cohort of patients in one of the study centers. And as I said, I am standing here in front of you on behalf of all the investigators of the study. The study is conducted in 3 oncological centers, with the Silesian Center for Heart Diseases working as the leader of the project. We are indicated by this a little bit darker red dot on the map. We have the pleasure and honor of co-working with Professor Michał Jarząb and his cardio-oncology team from the National Institute of Oncology in Gliwice. We have pleasure and honor of working with Dr. Barbara Sosnowska-Pasiarska and her team from Kielce, and also with Professor Barbara Radecka and her team in Opole. The Medical University of Gdańsk is going to join us in the coming weeks in the recruitment. Thus, I could say that the geographical distributions of those patients will substantially expand, as not only the southernmost, but also the northern part of Poland will be covered by the project. A little bit about what we have already achieved. There are more than 35% of patients of the totally estimated number recruited. These are statistics for the last Friday, so I presume that already more than 220 will be recruited and more than 180 randomized. As I have mentioned before, the screen failure rate has been estimated initially to be approximately 20%. Till now, the screen failure is 9.4%, so this still is confined in the estimated before the trial rate. And apart from what we have achieved, I would also like to mention a few problems that we have encountered all along the way, because it's not only the pros and the lights, but it's also about the shadows of what we encounter in the daily management of the project. First of all, before the initiation of the project, the market recognition suggested a substantially lower price of both drug and placebo to be purchased for the trial. And this, because of substantially higher costs, necessitated us to modify the primary endpoint from the MRI to echocardiography assessment to reduce the overall costs of the procedures. We had some slight troubles with placebo production, release, and distribution, as the number of the vendors working on placebo in Poland is relatively limited, and so this also causes some slight problems. And another problem that has been raised by some of the patients was that the non-commercial structure of the trial, without reimbursement of the transfer to and from home for every visit, also limits the number of patients willing to participate in the trial. A little bit about the future. We expect, with the support of the 4th center, to complete recruitment at the break of September and October 2026, so the next year. And with that, with the 24-month follow-up, we expect the study to be completed by the end of February 2029. And so the question remains, will sacubitril/valsartan be considered in the next cardio-oncology guidelines as class 1 or class 3 for prevention of cancer therapy-related cardiac dysfunction? With this question in mind, we are still progressing with the mainstream trial, and I would like to thank you for your attention. If you have any questions, I'm very open to discussing them. Thank you.
Thank you for your excellent presentation. Well, let me start with a bunch of questions. I may have missed that, but what kind of difference in outcomes do you project?
Well, regarding the occurrence of the primary endpoint, the initial assessment was, the assumption was that approximately 20% of patients from the placebo group and 10% of patients from the drug group will develop the primary endpoint, and so the difference would be 10% between the groups.
Okay, and do you have an interim analysis planned in this project or not?
Till now, yes, but we don't have sufficient number of patients yet to support these analyses. So we were planning on approximately 50% recruited to then perform the interim analysis, yeah.
Okay, perfect. To advocate some aspects of the agency's operations, the issue of getting placebo into non-commercial trials is a major one in Poland. Again, this is a business idea for all the startups out there. If I were to choose a scientific area, I would make a company producing placebos for Poland. Again, that's something that is not happening here.
There is my number, so please contact me.
Yeah, sure. That's one thing. But again, the agency has a policy of looking at scientific risks and unforeseen events. So if during any of the projects there are some unforeseen costs occurring because of another war, pandemic, collapse of supply chains, etc., please write to us. We have means of supplementing projects or assisting the beneficiaries in modifying the budget so that the projects are feasible. Okay, so just let us know. We are there for you.
Yeah, thank you. We are in continuous contact with the project manager from the side of the research agency, and they support us in most of the administrative work. So yeah, we are grateful for the support of the sponsor.
Thank you. Do we have any questions from the jury? Or
yeah, great work. 2 questions. How do you see this in the light of the PRADA-2 trial, which was presented at the ESC? Similar kind of design, perhaps you can reflect on that. And the second one is, how did you, why the primary endpoint, like a decrease in 5%, was there a specific reason to go for the 5%? I think it also alludes a little bit to your question, because you could also think about GLS, for example, or more the general definition of cardiac dysfunction. Yeah, so what were your thoughts there?
Thank you for the question. Well, first of all, starting from the PRADA-2 trial, which we have also observed as kind of parallel trial investigating the very similar issue. First of all, we were facing similar difficulties as they faced, the slower recruitment phase, also the slower number of patients, because they initially planned to recruit 300 patients, eventually ended up with 148. When looking at the detailed results of the PRADA-2 trials, we are even more optimistic about the results of our study. When you look at the planned primary outcome of our study, it is planned to be percentage of patients experiencing a difference in the left ventricular ejection fraction. In that study, in the PRADA-2, it was a continuous assessment, so between the group comparisons in the linear concept. Recently, we have also discussed the results of the PRADA-2 during the interim assessment and the meeting of the board. And when you look at the percentage of patients who experienced a more than 5% decrease in left ventricular ejection fraction, as well as the global longitudinal strains, those was highly suggestive that if slightly higher number of patients will be recruited, the endpoint will be positive for us. So that's element number one. Regarding the primary endpoint, in PRADA-2, one of the endpoints was also the decrease by more than 5%. We wanted to be as laboratorily sensitive as positive, if I could call it like that. So in the general clinical practice, probably the difference by 5% is not that meaningful. However, after the presentation of the ESC guidelines, we have also added the secondary endpoint being the clear definition from the ESC guidelines to support it in that way. But to investigate and to define the 5% difference would already be probably clinically meaningful, and that's the reason for this threshold.
Thank you very much. Due to time constraints, we have to go to the second presentation. So good morning, my name is Piotr Rutkowski. I'm here on behalf of Polish Society of Oncology, and I would like to introduce Professor Ewa Lech-Maranda, who is head director of Institute of Hematology and Transfusion Medicine and National Consultant in Hematology. And the second trial also will be about the cardioprotection phase 2 trial in terms of the newly diagnosed multiple myeloma, hard DAPA-MM.
Thank you very much for inviting me to present the concept, actually the concept of our study, entitled a randomized double-blind phase 2 trial evaluating efficacy, safety and tolerability of primary cardioprotection with dapagliflozin in patients with newly diagnosed multiple myeloma who will undergo autologous hematopoietic stem cell transplantation. The leader of this project will be the Institute of Hematology and Transfusion Medicine, and the partner is Center of Postgraduate Medical Education. Funder of this study is Medical Research Agency. Oh, it's here. Op. I'm sorry. It works? Okay. Green light. Okay. Okay, sorry. Let's start with some information about multiple myeloma. It is an incurable hematological malignancy and is the third most common hematologic malignancy all over the world. And based on Polish data, there are three most common causes of early mortality defined as death within the first 12 months from myeloma diagnosis. The first group is infections, which account for 35% myeloma progression, and the third is cardiovascular diseases, which account for over 14%. And moreover, cardiac cause is one of the most important predictors of survival, together with performance status, renal insufficiency, and efficacy of myeloma therapy. As for risk of cardiovascular complications, patients with myeloma are at risk of these complications, and we can divide these complications into three groups. The third group composes pre-existing risk factors like older age, diabetes, dyslipidemia, obesity. The second group composes so-called the nature of cancer, and here there are some risks like increased plasma viscosity, high output heart failure, anemia, renal dysfunction, and rare complications or rare disease that may accompany multiple myeloma is cardiac amyloidosis. And the third group is cardiotoxicity associated with myeloma therapy, and we use corticosteroids, immunomodulatory drugs, proteasome inhibitors, and high dose of chemo with melphalan and hematopoietic stem cell transplantations. And all this therapy may cause cardiovascular complications. It was reported that myeloma may lead to specific cardiac ventricular remodeling. And as I mentioned before, anti-myeloma therapy can induce different cardiovascular complications like heart failure, arrhythmias, including atrial fibrillation or arterial hypertension, as well as high dose of melphalan and hematopoietic stem cell transplantation may lead to almost the same complications. Regarding myeloma and heart failure, patients with myeloma and heart failure with even preserved ejection fraction has a higher risk of mortality and higher incidence of acute kidney injury. And moreover, each diagnosis of heart failure in myeloma patients, regardless the EF value, is associated with prolonged hospitalization and a higher risk of acute respiratory failure and admission to intensive care unit. Interestingly, patients with new diagnosed myeloma and normal ejection fraction, but abnormalities in global longitudinal strain in echocardiography had significantly worse overall survival independently of the type of anti-myeloma therapy. And anti-cancer drugs through different specific mechanisms together with the high dose of melphalan and autologous stem cell transplantation may directly damage cardiomyocytes, causing heart failure. What do we know about the role of sodium glucose cotransporter 2 inhibitors? We know that they are currently approved for type 2 diabetes, chronic kidney disease, and heart failure. And these drugs seem to be an appropriate option to improve the outcome of myeloma patients, providing cardiovascular and at the same time renal benefit for these patients. DAPA has been selected as a SGLT2 inhibitor for evaluation in our study, and we took into consideration some facts that DAPA is effective for heart failure treatment independently of baseline ejection fraction. The second point is that this drug reduces a risk of decline in eGFR, end-stage kidney disease, and death from renal or cardiovascular causes in patients with chronic kidney diseases, regardless of the presence or absence of diabetes. And the third point, that DAPA prolongs survival, irrespective of baseline patient characteristics in those with chronic kidney disease, and it causes a 46% reduction in non-cardiovascular death, as well as 58% reduction due to malignancy. So taken everything together, we would like to evaluate the hypothesis that the use of DAPA at a very early stage of treatment of myeloma patients may be beneficial in decreasing the development of heart failure and a range of other cardiovascular complications. And DAPA probably may interact with other, apart from SGLT2, molecular targets in the bone marrow, potentially reducing myeloma cell viability and decreasing pro-inflammatory cytokine production. Let's look at the study design. The study will enroll newly diagnosed myeloma patients who are candidates for autologous stem cell transplantation. The patients will receive, according to our drug program, 4 cycles or DARA-VTD. And I hope in the near future it will be the different scheme, different protocol, daratumumab plus lenalidomide, bortezomib, and dexamethasone. And after 4 cycles of chemo, patients will receive autologous stem cell transplantation. After, they will receive 2 cycles of chemo, immunochemo, as a consolidation therapy, and after then they will start maintenance therapy with lenalidomide. It is a standard of care in Poland. We will enroll 376 patients, and they will be randomized at the ratio of 1:1 to receive DAPA in the arm A, or to receive placebo in the arm B. And patients will be stratified according to the following factors: presence or absence diabetes type 2, eGFR value, GLS, and any history of acute coronary syndrome. Oh, sorry. The patients will receive DAPA at a dose of 10 milligram per day or corresponding placebo, and will be treated over the period of 18 months. And after, they will be closely monitored by hematologists as well, or maybe primary cardiologists, for a period of 12 months. We hypothesize that the frequency of cardiac events will be reduced by 50% on DAPA use versus placebo. And this hypothesis of 15 reduction in cardiovascular toxicity and emergency visits has been based on the data from the oncology population with different cardiotoxic therapies. Here you can see objectives and endpoints. The primary objective is to evaluate the efficacy of DAPA compared to placebo on the incidence of cardiovascular complications in patients with newly diagnosed myeloma, and we'll measure the incidence of major adverse cardiovascular events according to the ESC recommendations. The secondary objectives are to evaluate the safety and tolerability of DAPA compared to placebo, and we'll assess incidence and severity of adverse events and type and incidence of changes in laboratory results. Next secondary objective is to evaluate the cardiac function of myeloma patients after autologous stem cell transplantation, and we'll assess change in GLS compared to baseline over time, change in left ventricular ejection fraction, and change in biomarkers of cardiac function at the baseline and over the time. The next secondary objective is to evaluate clinical response to anti-myeloma treatment and quality of life. The tertiary or exploratory objectives are to explore a range of selective biomarkers for their potential association with incidence of cardiovascular events or clinical and molecular response in multiple myeloma patients, and will assess expression of DAPA target and off-target proteins. We'll measure changes in serum levels of inflammatory biomarkers, and also we will evaluate ex vivo cytotoxic effect of DAPA on plasma cells and some lymphocyte subpopulation, as well as we'll try to maybe assess the relationship between tested biomarkers and studies clinical and echocardiography primary endpoints. The study will be conducted, I hope, in at least 11 hematological centers in Poland. And there are some requirements for these centers, but the main is that the center is supposed to perform at least 10 autologous stem cell transplantation for myeloma patients per year. And the main criterion is that the center has to closely cooperate with cardiologists and be able to perform echocardiography and measure other biomarkers. We also have central echocardiography evaluation. So echocardiography results, images will be assessed by independent central echocardiography laboratory, which is located in Cardio-Oncology unit in Cardiology department in the University Hospital in Madrid. And this part of study will be supervised by Dr. Teresa Lopez Fernandez, and also we are planning to use some artificial intelligence in this analysis. And here you can have a quick look on inclusion criteria. Among these criteria, the most important, because others are rather typical, that the renal function in patients must be at least more than 25 milliliter per minute, and some exclusions criteria are important. The criterion that patients can't take flozins over the last 3 months, and they can't experience any history of cardiovascular events such as diagnosis of heart failure before myeloma diagnosis, left ventricular ejection fraction less than 50%, and myocardial infarction or stroke within 90 days before enrollment. And thank you very much for your attention.
Thank you very much. Are any questions from audience? I got 1 or 2. First, it's a long-term study. Do not afraid that the landscape of multiple myeloma treatment is changing, and this type of the treatment can be not efficient in terms of the recruitment to the study.
Yeah, thank you
during this long time.
Yeah, thank you for this question. This is why I mentioned another protocol, which probably will be refunded in the near, I think, 1 or 2 years. So we will start with daratumumab VTD scheme, but we know that probably it will change because the standards now are changing in the world. So we suppose to use, and we will take into account this new protocol in our study protocol. So daratumumab with lenalidomide, dexamethasone, bortezomib. But I think that the near 5 years, the standard of myeloma treatment will not change. So we hope that it will be sufficient protocol, but of course we are always aware of recruiting patients. It is not an easy task. We know we have a tough experience in it. So, but on the other hand, myeloma, as I mentioned at the beginning, myeloma is the third frequent cancer in Poland. So we have a lot of patients, but I know that some inclusion or especially exclusion criteria must be a limit.
Yes, so you should be flexible in terms of that. Any other questions? Okay, so
thank you very much.
Thank you very much. So the third speaker will be Dr. Krakowiak from Wrocław, working in the military hospital there. And you will speak about the role of dapagliflozin in preventing cardiotoxicity in patients with breast cancer. Looking forward to your talk.
Yes, thank you very much. Ladies and gentlemen, good morning. My name is Bartosz Krakowiak and I represent 4th Military Medical Hospital in Wrocław. My presentation concerns on trial involving the use of dapagliflozin in preventing cardiotoxicity in patients with breast cancer exposed to anthracycline therapy. This trial was founded by Medical Research Agency in 2023. It is conducted by our hospital in consortium with the Military Institute of Medicine and the Lower Silesian Center of Oncology, Pulmonology and Hematology, and lead primary investigator is Professor Waldemar Banasiak, current national consultant in cardiology. Let me begin with a short introduction. I'm cardiologist, so all cardiologists know that heart failure remains a major unmet need and is leading cause of mortality not only in the United States but in the whole world. And approximately 50% of patients with diagnosed heart failure will die within 5 years from the diagnosis. And 1 in 5 patients is admitted to hospital every year, and 25% of them are readmitted within 1 month. And the problem is big. We have in the United States 6.5 million patients with heart failure, in the European Union 10 million, and globally 65 million people. And this number will increase, I think, that by over 20% in next 5 years. Cancer survivors are also rapidly growing population, representing over 5% of population in developed countries. And the patient with cancer have high burden of chronic conditions that are related to not only to traditional risk factors like hypertension, diabetes, smoking, obesity, but also to cancer therapies and cancer physiology like inflammation or oxidative stress. And these patients live long enough such that non-cancer deaths are surpassing with risk of cancer-related deaths. And anthracycline-based therapy remain widely used therapy in breast cancer patients in different subtypes of this cancer. But the use of anthracyclines in this group of patients is limited by potential cardiologic complications. This complication, as heart failure, can be higher in patients with genetic predisposition, with advanced age, with additional cardiovascular risk factors, but this risk can be lower in patients with cardioprotective strategies and different type of treatment, like, for example, liposomal anthracyclines. And SGLT2 inhibitor therapy is used in many cardiac and nephrologic conditions, but it was shown that in preclinical models, in animal models, it was shown that this therapy prevents anthracycline-induced cardiotoxicity, and this is the last big study in big animals with empagliflozin, where SGLT2 therapy preserved cardiac function, improved cardiac energetics, and maintained mitochondrial fitness. So all these facts makes our idea for this trial quite rational. And the study is, of course, non-commercial, founded by a medical research agency, multi-center, interventional, double-blind, and placebo-controlled. It's phase 3. Intervention is dapagliflozin 10 milligrams per day with the placebo as comparator. We are planning to include 188 patients. The population is patients with breast cancer, and we got approval in March 2024. Main inclusion criteria are age between 18 and 80, and diagnosis of invasive breast cancer, stage 1 to 3, and planned anthracycline treatment within 60 days from the screening. And the main exclusion criteria are recognized heart failure or symptoms that, in opinion of the investigator, might be a symptom of undiagnosed heart failure, but also reduced ejection fraction below 50 and diagnosed diabetes, type 1 or type 2, or fasting glucose over 126, or level of glycated hemoglobin over 6.5. The randomization is 1 by 1, and the treatment of dapagliflozin starts before first dose of anthracyclines. This treatment is for 12 months. We have, during the study, 3 big procedural visits. It's the first visit before its randomization visit. The second one is visit after 3 months, and the last one is after 12 months. And all patients will have echo, Holter ECG, and blood samples for biomarkers, troponin and NT-proBNP. There are few observational visits after 1, 3, 9, and 13 months. The primary endpoint is composite, and it's according to ESC guideline definition of cancer therapeutics related cardiac dysfunction. So it's appearance of heart failure symptoms within 12 months. It's asymptomatic decrease in left ventricular ejection fraction, and also decrease in global left ventricular longitudinal strain, and asymptomatic increase in biomarkers. The secondary endpoint is the same, but after 6 months. We have also a few additional secondary endpoints, like changing in ejection fraction, troponin level, NT-proBNP level, and quality of life, and some safety endpoints. We have included also a few sub-studies in the actual protocol. First sub-study is biobanking, is for future scientific analysis. The second sub-study is genome study. It's a whole genome sequencing in this group of patients with trying to find novel genetic biomarkers responsible for susceptibility of patients for cardiotoxicity. And we have also a biomarker sub-study and echo sub-study with trying to find a novel echo markers for heart damage during cancer therapy, like right ventricular strain, left atrial strain, etc. So where we are. Now we have randomized 123 patients, which is 65%, 35% of patients left, and also we have 30% of time left. So we think that we can randomize all this group. We have lots of adverse events, despite that many events were excluded from reporting because this group of patients, as we all need, may have many adverse due to anti-cancer treatment, and all these events were excluded. Last data safety monitoring board meeting was in April, and there was a recommendation of study continuation. Next meeting is in September. And the future milestones, we are starting now with sub-studies. Last patient first visit is planned in June 2026, and last patient last visits in June 2027, and end of the trial at the end of the 2027. Thank you very much. Feel free to contact me and our team. Thank you very much.
Thank you for a great presentation, and congratulations that already 2/3 of your patients have been included in the trial. I think there's room for one small question. Yes, Susan.
So thank you for that great presentation. Just a question about your inclusion criteria. So women with triple-negative breast cancer, particularly higher stages now, get upfront neoadjuvant treatment containing an anthracycline. So I assume that was okay. But they also get an immune checkpoint inhibitor, pembrolizumab.
Yes.
So
Yes.
were those patients included?
Yes.
Okay, so that's interesting, right? I just want to make that point because that's yet, combining potentially an anthracycline and immune checkpoint inhibitor. So that's great.
Yep, I think puts also one of your primary endpoint, the troponins, into perspective. Of course, I was wondering. So that was like you can meet the primary endpoint if your troponin bumps from, let's say, 10 at baseline to one time during follow-up to, let's say, 16, 17. That would qualify, I think, isn't it?
Well, I will just a second.
If I saw it quickly, it was one of your last primary endpoints. Yeah, here. So if it would go up,
increase in troponin level, its endpoint is when we have higher level than upper reference level, and increase at least 30% from pretreatment concentration. Yeah.
So that is relatively minor, of course. Aren't you not afraid that people will, if most of your endpoints happen at 0.5, that people would say, like, well, a relatively minor bump in your troponin, is that really valuable? Or how does that translate eventually into harder endpoints?
Well, we look at the literature considering troponin assessment in previous trials with assessment of cardiotoxicity and cardioprevention. And in many of them, definition was quite similar, and that's why we have it.
No, I understand the definition. I think it comes also from the Cardio-Tox trial, for example, from Teresa in Madrid. But it is a relatively, quite soft endpoint, of course.
But I must say that from our observation now, I don't have results because the study is still recruiting.
Sure.
I'm afraid that the troponin doesn't rise in these patients.
No, okay. Well, that's a reassuring. Thank you very much for your very nice presentation. Congratulations.
Thank you very much. And we are going to the last presenter, Dr. Anna Borowiec from National Research Institute of Oncology, empagliflozin in prevention of chemotherapy-related cardiotoxicity.
Good morning. My name is Anna Borowiec, and I'm a cardiologist at Maria Curie Skłodowska-Curie National Research Institute of Oncology in Warsaw, and I have a pleasure to present this EMPACT study. And thank you. A randomized, double-blind, placebo-controlled study to evaluate empagliflozin in the prevention of cardiotoxicity in cancer patients receiving anthracyclines. Empagliflozin, along with dapagliflozin, belongs to SGLT2 inhibitors, known also as flozins. As previous speakers already outlined the background for studying flozins in cardio-oncology in the prevention of cardiotoxicity, but I would like to add a few more points. SGLT2 inhibitors were initially developed for diabetic patients. After that, their use were extended to heart failure patients, both with reduced and preserved ejection fraction, and to chronic kidney disease patients, even without diabetes. And according to current European Society of Cardiology guidelines, SGLT2 inhibitors are recommended as class 1 in heart failure treatment, regardless of left ventricle ejection fraction. But importantly, they are also recommended as a prevention of heart failure in patients with type 2 diabetes and chronic kidney disease. Most pharmacological interventions that have been studied as a cardioprotection have been adapted from heart failure medications. And this includes neurohormonal antagonists such as beta blockers, ACE inhibitors, angiotensin receptor blockers, and mineralocorticoid antagonists. They all have been studied, but so far they have shown limited benefit in patients undergoing cardiotoxic therapies. There are also controversies regarding statins as a cardioprotection. So, to sum up, at present, those medications are only recommended as a preventive strategy in patients at high and very high risk, according to HFI-ICOS risk score, and as a class 2 recommendation. This slide summarizes the potential benefits of studying SGLT2 inhibitors and their use in cardio-oncology in prevention. This includes anti-inflammatory, antioxidative, antifibrotic properties of SGLT2 inhibitors. They reduce apoptosis, improve mitochondrial function, regulate autophagy, ion homeostasis, and even attenuate ferroptosis. And on the right side, we can see the potential translation into clinical outpoint of this mechanism. This includes prevention and treatment of CTR-CD and heart failure, possible anti-cancer effect, renal protection, and antiarrhythmic properties with reduced mortality. What is also interesting about SGLT2 inhibitors is that they are considered hemodynamically neutral, which means that they do not reduce the blood pressure significantly. And we can use them even in patients with low baseline blood pressure, which is always our concern with the patients with neurohormonal blockade. In vitro and observational studies suggest that the use of SGLT2 inhibitors during anthracycline therapy may be a promising cardioprotective strategy. So far, there is only one prospective case control study by Danielle, which showed a smaller decline in the LVEF and lower impairment of global longitudinal strain. There's also one more very interesting aspect of flozins in oncology, in cardio-oncology, and some retrospective and preclinical studies have suggested possible anti-cancer effect of this drug class. However, these findings are limited and should be interpreted with caution. And now we move on to MPACT study, which is a randomized, double-blind, placebo-controlled study. We are going to enroll 220 patients, 110 in placebo and 110 will receive empagliflozin 10 milligrams daily. The study group consists of patients diagnosed with cancer, without a history of heart failure, with left ventricle ejection fraction 50% or higher, which are scheduled to receive anthracycline therapy, at least 240 milligrams per square meter of doxorubicin, or 360 milligrams per square meter of epirubicin. There are two study centers. One is here. We are the leaders at Maria Skłodowska-Curie National Research Institute of Oncology, and the second one, Institute of Hematology and Transfusion Medicine in Warsaw. The primary objective of MTAC study is the diagnosis of cancer treatment-related cardiac dysfunction at any time over the 12-month study period, And CTR-CD is defined as the decrease in LV ejection fraction of at least 10% from baseline to a final of less than 50%, and or a new relative decrease of at least 15% in global longitudinal strain from baseline. The secondary objectives include composite of all-cause death, cardiovascular death, myocardial infarction, and stroke, and others include decrease in left ventricle ejection fraction measured both by echocardiography and cardiac MRI, decrease in GLS, difference in quality of life questionnaire, changes in concentration of biomarkers, and the clinical outcome, heart failure hospitalizations, and need for outpatient intensification of heart failure therapy. Inclusion criteria are straightforward, and the most important is diagnosis with cancer and patients scheduled to anthracycline therapy. Exclusion criteria are more complex, but the most important is history of heart failure, left ventricular ejection fraction less than 50%, significant valve disease, previous chemotherapy of radiation to the chest, prior treatment with SGLT2 inhibitors, life expectancy of less than 1 year, and contraindications to cardiac MRI. There's also exclusion criteria connected strictly to the empagliflozin. And this is the flowchart of our EPAC study. Patients are screened for up to 13 days. After that, they are randomized to empagliflozin 10 milligrams daily or matched placebo, and they are followed for 12 months. After the end of treatment visit, they are also followed for another 12 months. And this table presents the all scheduled visits and study procedures, but what I would like to emphasize is that we are performing cardiac MRI at the beginning of the study, before chemotherapy, before the randomization, and then after 1 year at the end of treatment visit, that at every visit we are doing echocardiography with GLS assessment. We are taking blood samples for troponin T, NT-proBNP, and galectin-free, and also we are taking blood samples for biobanking for future research. Study enrollment progress looks like this. We have already enrolled 210 patients and randomized 160. Majority of them are with the breast cancer, followed by sarcomas and lymphomas. The planned completion of patient recruitment is January 2026. The first study results are expected at the beginning of 2027, hopefully. And these are the details of EMPACT study. And if you have any questions and for further details, please contact me, or to refer patients to the study, please contact me by email or by phone. Thank you very much for your attention.
Great presentation, thank you. Any questions from the audience? Okay.
Thank you very much. It's a question for actually yourself and the previous presenter. You have great randomized trials going on in the same country with relatively mild endpoints. At least we don't really know what happens when you have a low GLS in 10, 15 years after breast cancer. We don't have that data as far as I'm aware of. Are you considering perhaps at some point pulling your data to look into clinical outcomes, like major cardiovascular events?
Yeah, we have this composite endpoint of stroke.
Pulling the data from the free trials. This was.
I don't know. We'll see. It's not a question only for me. Yeah, maybe we'll collaborate to have more patients and bigger patient. Yes, study enrollment. Yes. Thank you for this idea.
So just a quick comment and question. So all of these studies we saw present in this session are including, all comers receiving anthracyclines, whether you have for breast cancer in this case. Did you ever consider looking at risk stratifying patients up front? Because when you look at the current ESC guidelines, they talk about primary, prevention strategies for those at high and very high risk. And if you didn't do that, will you go back retrospectively and determine what is the benefit of this intervention in this low versus the high, very high risk patients?
Yes, we are stratifying patients, and we are trying to involve patients with at least one risk factor, if it is possible, of older patients. to have more ill patients in the study, to have more outpoints. Yeah.
Thank you very much. Do you have any other questions from the audience? No? Thank you for attending this. Thank you for excellent lectures. And this will conclude our session, and I believe we have a short break now.
Yes, I propose 5 minutes for a break. Thank you. Thank you. Great presentations. A great discussion. Thank you, the chairs.
Thank you very much.
Ladies and gentlemen, it's a time to start with session number 3. I invite everyone to enjoy our meeting. Great pleasure to introduce our main person from the Polish Cardiac Society, the current president, Professor Robert Gill, and President-elect, Pan Professor Gierlotka. Mr. Professor, please start the session.
So thank you very much for this invitation. We are very proud to be a part of this important conference. What is a very important message to the organizers of the health service in Poland is that the alliance between oncologists and cardiologists exists. We started just in May this year. And we think that this possibility to co-chair the session under our wings in your conference is a sign that our cooperation is valid and still alive. So let's start with the first presentation. By the way, the topic of this session is new therapies, new cardiac challenges. As it was already said, I co-chair this session with my friend and President-elect of Polish Cardiac Society, Professor Marek Gierlotka. So let's start with the first session, with the first presentation. The topic is Cardio-Oncology in Europe, Guidelines and Challenges. Just to bring you some information about the lecturer is Dr. Lopez Fernandez. He's a senior consultant cardiologist at La Paz University Hospital at the Research Institute in Madrid. So let's start. The stage is yours, Dr.
Good afternoon, everyone, and thank you for the opportunity to present today. My name is Teresa Lopez. I'm cardiologist at La Paz University Hospital, and I'm pleased to be here today with you. The idea of my talk is to present challenges, but also opportunities to facilitate ESC guideline implementation in daily practice. These are my disclosures. As you know, patients with cancer and cancer survivors are at high risk of developing cardiovascular toxicity. And with more than 600,000 downloads, the ESC Cardio-Oncology strategy proposed and the ESC guidelines have gone global. But the big challenge is how to implement it in daily practice. The good news is that we have multiple tools that help us to identify patients who are at high risk of cardiovascular toxicity, to complete the clinical information, to organize a precise cardiovascular evaluation during and after cancer treatment. But we are all aware that cancer incidence is increasing and therefore cancer treatment needs, and that we are managing patients who are older with multiple comorbidities. So this is another challenge that we need to bear in mind. Additionally, patients are receiving new drugs that can cause different cardiovascular toxicities. So our focus is not just heart failure. Patients with pre-existing cardiovascular problems are at high risk of cardiovascular toxicity and are generally excluded from oncology and cardiovascular trials. And we also have the big challenge of organizing a comprehensive and sustainable monitoring for cancer survivors who are at high risk of developing cardiotoxicity. And as I mentioned before, most of these aspects are not addressed in oncology and cardiovascular trials. In addition, education in cardio-oncology is also limited. Most of our patients who have cancer and have cardiovascular diseases or are at risk of cardiovascular diseases are seen in general cardiology clinic. So there is a need to educate the cardiovascular community and also the oncology community to address the most common issues that these patients can experience. So in the next minute, I want to focus on what are the opportunities we have to address all these challenges. For sure, we have new evidence that comes up after the publication of the ESC guideline, but we also need to work hard, multidisciplinary team, to organize a new way to do research in cardio-oncology and also to facilitate education in cardio-oncology. Starting by new evidence, I want to focus your attention on these three main areas: risk stratification, early detection, and intervention. Starting by risk stratification, as you know, the ESC guidelines place the Heart Failure Association and International Cardio-Oncology Society score at the center of baseline risk stratification. However, until now, we lack strong evidence of its real performance. The HFA-ICOS risk score was validated in over 1,000 patients from the CardioTox registry. And as you can see, patients who are at high risk or very high risk of developing cardiotoxicity are also those who are at higher risk of global mortality. The performance of the score was strong, with an area under the curve around 0.8 and good calibration across time points. At the same time, different groups have validated the same score, the HFA-ICOS score, but for other cancer drugs, HER2-targeted therapies, TKIs, proteasome inhibitor, androgen replication therapies, and in all these scenarios, the HFA-ICOS risk score is able to identify patients who are at high risk, for cardiovascular toxicity. However, their availability to accurately identify patients who are at low risk was clearly variable. Probably this is because, in addition to clinical data, the future of these risk stratification strategies will need new genetic tools and also to incorporate social determinants of health that are really critical in some high-risk patient population. The HFA-ICOS risk score do not include other therapies. So, for example, for patients who are referred to hematopoietic stem cell transplantation, we have now a new score, the CARE-MT, that use, as you can see, very easy variables: age, the type of transplant, general comorbidities like coronary artery disease, heart failure, or peripheral artery disease, and easy laboratory test to identify the risk of cardiovascular events at 1 year and 5 years after bone marrow transplantation. But definitely one of the most important advances in risk scores is this risk score, or recently published at European Heart Journal, that identify or is able to differentiate between severe and non-severe immunotherapy-related myocarditis. So the score is designed to predict a composite of severe heart failure, severe respiratory failure, arrhythmias, or death for any of these causes. As you can see, the incidence, the 30-day incidence for this primary endpoint was 33%, with a large population of patients suffering several severe conditions at the same time. Using a multivariable analysis, the primary composite endpoint was associated with active TMOMA, the presence of cardiomuscular symptoms, low QRS voltage on presenting ECG, left ventricular dysfunction, and an incremental troponin elevation. So the score combines really simple, clinical, and accurately discriminate severe from non-severe cases. And as you can see, 30-day primary outcome incidence increased gradually from 4 to 80%. And additionally, the score was validated in 2 external cores demonstrating the same performance. Regarding early diagnosis, one of the most impressive studies published in the last year was the SOCUR MRI trial. As you remember, the original SUCUR trial compared GLS and 3D ejection fraction to guide cardioprotection. The SUCUR MRI asked this new question: does cardioprotection help when GLS falls before left ventricular ejection fraction? To answer this question, authors organized a multi-center randomized clinical trial including above 300 patients with cancer receiving anthracycline with an additional risk factor for developing anthracycline-induced cardiotoxicity. 100 of these patients developed an isolated reduce in GLS and were randomized to receive or not cardioprotection. Most interesting, patients who receive ACE inhibitors and beta blocker have a smaller reduction in left ventricular ejection fraction compared with usual care at 12-month follow-up. And is it true that this difference was modest but was consistent and reinforces GLS as an efficient marker of early cardiovascular toxicity? Another important aspect when we consider cardiovascular monitoring of patients with cancer is how many patients can we monitor at the same time. And as in other cardiovascular scenarios, artificial intelligence is helping us to address this issue. So using an AI ECG algorithm developed in general population, at Mayo Clinic, authors are trying to demonstrate if this algorithm also identify patients with breast cancer who can develop cardiovascular toxicity, and effectively this algorithm is able to detect new reductions in left ventricular ejection fraction with an area under the curve of 0.93. Another important aspect that we need to consider when organizing the cardiovascular monitoring of patients with cancer is how often do we need to test or to do an echo of these patients. As you know, the general recommendation is to perform an echo every 3 months in patients who receive HER2-targeted therapies, but we have learned that those who do not receive anthracycline and do not have other additional cardiovascular risk factors, the incidence of cardiotoxicity is really low. So this is a very interesting study, including 190 patients who receive HER2-targeted therapies because of breast cancer without previous anthracycline treatment, and the patients were followed every 6 months instead of every 3 months, and author confirmed that this new protocol is safe and is also feasible and well received by patients in terms of adherence to monitoring. Regarding intervention, the most important aspect is definitely awareness, because the perception of cardiovascular risk in patients with cancer and in cancer survivors do not always reflect the reality of these patients, and we have learned that most or a lot of cardiovascular problems that these patients suffer during treatment were related with uncontrolled cardiovascular risk factors. So it's really good to see in new guidelines, and this is just an example, how they address the way to implement recommendations also in patients with cancer and cancer survivors. Another good strategy that we need to develop more and more is to modify general scores in order to make them more applicable to patients with cancer. This is just an example, adding cancer as a binary variable in the precise DAP score significantly improve its performances to identify patients who are at high risk of bleeding, and definitely this will help us to make safer and more personalized decisions in this high risk group. Regarding cardioprotection, we have a lot of data that refer to the use of ACE inhibitors, beta blockers, statin, exercise to prevent cardiovascular toxicity. However, most of these data came from small studies that randomized just a few patients, and most of them who are not at high risk of developing cardiotoxicity, so most of them are neutral. So we have the opportunity to change this strategy and to organize larger studies that really can inform new guidelines. This is an example, the Cardio-Tox trial from Brazil, randomize 1,000 patients who are going to receive anthracycline and who are at risk of cardiovascular toxicity to receive or not carvedilol. This is the type of design that can inform new guidelines, and we really need to promote this type of research. Regarding other cardioprotection pillars, we have preliminary data on the use of sacubitril/valsartan. In the SARA trial, it seems that it can prevent anthracycline-related cardiotoxicity. The PRADA-2 trial showed a neutral effect of sacubitril/valsartan, and probably most of the research now is focused in the area of SGLT2 inhibitors and GLP-1 receptor agonists. This is a very nice study organized by the CENIC Center in Madrid. Authors try to demonstrate why empagliflozin can prevent cardiovascular toxicity and demonstrate in a pig model that empagliflozin exerts a clear and, most important, dose-dependent cardioprotective effect. As you can see, left ventricular ejection fraction was preserved in all the animals who received 20 milligrams of empagliflozin, and at the tissue level, empagliflozin reduces myocardial fibrosis and also preserve mitochondrial integrity. So it seems that SGLT2 inhibitors look very promising for protection. Indeed, in this meta-analysis, the impact of SGLT2 inhibitors on heart failure outcome in patients with cancer is really impressive, with a reduction by 50% of heart failure hospitalization and by 70% of new heart failure diagnosis. But for sure, we need to confirm all this data in randomized clinical trials. What are the next frontiers in cardio-oncology research? Definitely to understand the mechanism that leads to cardiotoxicity is a strategy that is very, very important, because it's the only way to identify new therapeutic targets. And from the clinical perspective, we need to work very hard with oncologists and hematologists in order to harmonize the way we report cardiovascular toxicity and we monitor cardiovascular toxicity in clinical trials to have evidence when these new drugs come for a clinical practice. One of the major advances this year is the new CTC-AI definition of CTR-CD that is now aligned with the ESC guidelines criteria. And as you see, the field of cardio-oncology is becoming more precise, more patient-centered, and a lot of groups are developing very innovative projects. A number of these were presented at the first ESC Cardio-Oncology conference in June in Vienna and are published in this European Heart Journal supplement. And we now look forward to the new ideas you will bring and present next year in Vienna. Regarding education, based on the ESC Cardio-Oncology curriculum, we have developed at the ESC Council level this new Level 1 certification program on cardio-oncology that is designed to prepare the first certification exam that will take place on December 9 this year. And we have also new activities for 2026, a new e-learning course, and most important, a course of advanced studies in cardio-oncology in collaboration with the European Society of Medical Oncology. So to conclude, we need to bear in mind that the main goal of cardio-oncology is to improve cancer outcomes, to facilitate cancer treatment. And the way we do that is by preventing cardiotoxicity. So definitely we need to work on multidisciplinary team to address all the cardio-oncology challenges and to be able to create new opportunities to improve the field in the near future, the field of cardio-oncology. And with that, I want to thank you for your attention and to invite you all to join us at the ESC Council of Cardio-Oncology. Thank you.
Thank you very much for this very interesting and exciting presentation. Although we have, let's say, time limitation for everything, we need to ask at least one question to you. So we prepared, before I ask the audience whether there is another one, Professor Lopez Fernandez, what do you see as the biggest hurdle in implementing European Society Cardio-Oncology guidelines uniformly across the European system?
Hello, good morning. Thank you for this question. I think the most tricky part to implement ESC guidelines is to convince oncologists and hematologists to work on a more personalized cardiovascular toxicity risk stratification, because we really need their help to receive the right patients at the right time in our cardio-oncology clinics. So improvement of this risk stratification tool is really a key point to improve the implementation of other ESC guideline recommendations.
Okay, so thank you very much for this short but straightforward description. Just to conclude, my question, so my perspective is a little bit different, because as a cardiologist, we envy you to have this beating cancer program, which is additionally financed by European community. So this is the way when you can use additional resources to implement all of these new demands and needs for our patients. Thank you once more.
Thank you also, and let me introduce the next speaker, is Professor Van der Merwe. He's a chair-elect of ESC Council of Cardio-Oncology and clinical cardiologist and chair of Department of Experimental Cardiology at the University Medical Center in Groningen, and his research focuses on understanding the susceptibility to develop heart failure and exploring novel treatment targets and therapies. So please, Professor Van der Merwe, the topic is cardiotoxicity beyond anthracyclines.
Thank you very much, dear Mr. Chairman. First, I would like also to thank Sebastian for organizing this wonderful conference here. And it's really a pleasure to be here, and thank you. I'm very grateful for this. I think Teresa already talked, two important points for her is, like, on one hand, better understanding of the toxicity and novel treatments. And I think that's where I would like to discuss with you this afternoon, because my research focuses also on a translational perspective. Here you can see my disclosures. And if we talk about cardiotoxicity, the first question is, how can we model it? And I think we've seen in a previous presentation very nicely that you can use pig models, very well recapitulating the phenotype we see also in patients. But these experiments are very difficult, very expensive, and takes a lot of infrastructure to do these experiments. So if we talk about cardiotoxicity, how can we model it, and how can we stay as close as possible what we do see in our patients? And second, we do see a lot of preclinical or translational research on anthracyclines. And this is great work from the group from Pietro Amiri, where they specifically looked on the left side, the preclinical studies, where do preclinical studies look at? And on the right side, you can see what are the clinical trials. And as you can see in red on the left, is anthracyclines. So we do a lot of work on anthracyclines to understand it. I think that makes still sense, because what we also heard from the previous speakers, anthracyclines are still used in many, many cancers. But on the other hand, we're also, I think what Susan then said, like we also need to think about all the other therapies which are emerging. And do we also preclinically, why don't we focus more on these therapies where we don't know? Why does it lead, for example, to cardiac toxicity? And I will show an example, for the CDK4/6 inhibitors, how that may be related to cardiac toxicity. So there is a little bit disconnect between what we do preclinically and what we do clinically, and how can we get that better streamlined. So if we talk about cardiotoxicity, well, there are a lot of options how you can model it, and it really depends on your research question, what you would like to understand, what kind of model you choose. So very simple model here, for example, you take cardiomyocytes. It could be cardiomyocytes from a neonatal rat, which you can easily culture, but you can also take cardiomyocytes from a stem cell source or from an iPS, so from a patient-specific source, you can make cardiomyocytes. You make a little layer of it, and you can easily see like what's going on. And you can culture millions and millions of cells at the same time, and you can do hundreds of different experiments within a few weeks. But it doesn't give you a lot of readout on contractility, preload, afterload in your model. So it's a very simplistic model, very suitable, for example, for high throughput. Spheroids, it's the same. You just bring a clump of cells together, you look at it, if it moves a little bit, and that gives you an idea if the cells are dead or not, and then you can check, for example, if there are dose response curves with a lot of different agents. But here we get into more difficult, less high throughput models, for example, engineered heart tissues. I will show a few examples what we did in our lab, and here the animal models. What we've seen, mouse models, mice are quite resilient to anthracyclines, so you need to give a very high dose, not always that relevant for the human setting. And for example, the pig models, relevant for the human setting, but very difficult to handle and absolutely not high throughput. So what we actually would like to model is cardiac dysfunction, so heart failure. And when we look in the clinical setting, what are main outcomes of when we talk about cardiac dysfunction, heart failure? We would see like dilatation of the heart. We would like to see a reduced contractile force, and we would like to see an increased wall stress, like reflecting elevated filling pressures. So we went back to our lab and we said, how can we model these features? Here you can see how we did it. So we took from a patient, we took a skin biopsy. You can take it also from peripheral, from the blood. In this case, we cultured the fibroblast. You add a few factors for 1 or 2 weeks, and then these cells are being reprogrammed. The so-called Yamanaka way, the man from Japan who got a Nobel Prize a little bit more than 10 years ago for this invention. And then you can differentiate these induced pluripotent stem cells to every cell you want. Endothelial cells, smooth muscle cells, cardiomyocytes, whatever. There are very specific protocols, and you get very pure populations. So you can actually model in your dish all these cells which you also encounter in a heart. And what we did is we made a little model where we put the cells all together in the well, cardiomyocytes, fibroblasts in this case, and we let them grow, and it's a kind of a self-assembly. So these cells know how to work together without giving them a lot of clues. This is how it looks. So if you bring these cells together and you have a little spring here, and you can see here the moving model. This is great work from Mathilde Vermeer. She's working as a postdoc in our lab. And here you can see the little piece of human tissue. So these are cells, like 4 weeks ago, these were stem cells. We differentiated from that single patient, and we got actually a beating piece of cardiac muscle from a specific patient. And when you know the stiffness of this spring, you can actually calculate how much force is this little piece of tissue actually producing. So from that patient, you can measure how well does that contract. And here you can see how it looks. The cells are very well aligned, and the alignment comes because of the stretch which has been put to the tissue. So then the cells align, as we also see in a normal heart. So we wanted to model anthracyclines. We modeled also dilated cardiomyopathy from a genetic cause, worked quite well. And we would like to see in our model a dilated LV, a reduced, so we see in patients a dilated LV, reduced ejection fraction, a limited role of apoptosis, and an increased percentage of senescent cells. So we took as a gold standard tissue from patients who experience severe cardiotoxicity. Here, controls. Here, the patients, we saw a lot of senescent cells. We didn't see any apoptotic signal there. And here you can see all these patients underwent cardiac transplant or VAD implantation. So these were the clinical features. So that is what we would like to see also in our model. And here you can see the model when we exposed it to anthracyclines. So we had different cycles of anthracyclines, similar what we've seen, what we also do in the patients, relatively low concentrations. If you give high concentration, you can immediately kill all the cells. So we use a low concentration, also the similar concentrations you see in the serum of patients when they've been treated, and really in cycles 4 times. And when that happens, you can clearly see that there the contractile force goes down. There is no apoptosis, and there is more senescence, as you can see here. And when we look more functionally, we saw the features we would like to see in these models. So we see dilatation of the heart, as you can see here. If you expose them to 4 cycles of anthracyclines, you see dilatation, you see a reduction in the diameter, so increased wall stress, and you see a decrease in systolic force. The key features we're also observing in patients. So senescence, no apoptosis, and clinically reduced ejection fraction. And here you can see when we were interested because we saw so much senescence in these cells, can we actually prevent senescence from happening? Because if you get rid of these senescent cells which are secreting, like SASP, which has a detrimental function on the heart, if you can get rid of these cells, would it be beneficial? Also in the light of potentially future trials. And we were actually very well able to get rid of these cells. So when we used these senolytic drugs, or xenomorphic drugs, we were able to get rid of all these senescent cells. But unfortunately, when you get rid of these senescent cells, what we got back is more fibrotic tissue. So we did not see any improvement in cardiac function. The senescent cells were replaced by fibrotic cells. So I think that's also how we phrased this in that paper. We said, like, well, these xenomorphics or senolytic drugs, be careful, because the heart is not regenerating in itself. And that is completely different from other organs where senolytics may play a role. So getting back to the model, so later on I will tell you a little bit more where we look patient specifically with this model, but also to coming back to Pietro's data, what about other drugs? Can we also use this model to see whether we can explain cardiotoxicity which have been associated with certain drugs? Because that's, I think, what we see in most of these trials. These are associations with the occurrence of cardiac dysfunction. And this is work from the group from Bonnie Kai and Brett Fredley from Penn, where they looked at CDK4/6 inhibitors. We heard already this morning about it, mostly used in metastatic breast cancer. And you can see here what they did is they looked at more than 1,000 patients who had been using CDK4/6 inhibitors. And they saw that the occurrence of heart failure was actually similar to the patient who had been using anthracyclines. And of course, these are observational data, and it's very difficult to say whether there is any causal relation. So we thought, like, well, let's use our model to see whether we can expose these cardiac tissues to CDK4/6 inhibitors and see whether we can, if there is cardiac dysfunction. And I'm sorry, it's a little bit a busy slide, but here you can see on the upper part, you can see where we started. So we gave, well, nobody wanted to use the name, but we used ribociclib, so one of these CDK4/6 inhibitors. I think well, you know better, Susan, but I think it's the oldest one, which has been, I think most data is from the ribociclib CDK4/6 inhibitors. But anyway, so the data from Bonnie and from UPenn were based on ribociclib, so that's the reason why we took ribociclib. We exposed it to a low dose of 2 cycles of ribociclib, and then we replaced the media. And as you can see, if we exposed these tissues to ribociclib, there was, again, a dilatation of the tissue, and there was a reduction in systolic force. So actually it shows that there is a direct effect of these drugs on cardiac function, at least in vitro. And of course, we were interested in how can we actually explain what has happened. Can you actually, because I always tell my kids, it's always easy to damage something, but can you also repair it, or can you prevent damage from happening? So what we did is because the mode of action of the ribociclib, here you can see the CDK4 inhibitors, it's related to cyclin, and these CDK4 actually leads to phosphorylation of retinoblastoma gene. And when the retinoblastoma gene is phosphorylated, it doesn't bind anymore to E2F1. And when it's unbound, it leads actually to proliferation. And that's the whole idea about this drug, that you inhibit proliferation of your tumor cells. So what we did is we made a construct where we overexpressed the E2F1. As you can see here, there was quite a significant overexpression. And when we overexpressed that gene, we actually could prevent the damage from happening. So actually showing that's not an off-target effect where we're looking at, but it's really at the core of the mode of action of the drug. So it occurs due to the E2F1 binding to retinoblastoma. I think we talked already about it. The large animal models, I think Teresa also nicely showed it, that these animal models in pigs, so you have a clear question. For example, you would like to know what about mitochondrial function and the role, for example, of SGLT2. These models are very useful to use, and you get a clear idea of the mode of action, but absolutely not suitable for screens to better understand the mode of action. And this is the last slide I would like to end with, because what we've seen with these induced pluripotent stem cells, so from every patient or healthy person, you can make stem cells, and these you can differentiate to every cell you would like to test. And this is an idea. So this has been done already almost 10 years ago. This is work from San Francisco, where you could see the patients who actually experienced cardiotoxicity. The iPS cells, so these cells induced from these patients who had toxicity with no toxicity, also in vitro, they showed a kind of a phenotype. And we're currently working on a project, and we're almost wrapping that up. As you can see here, if you look at the relationship, and this is more the personalized medicine, so here you can see LV function, for example, and here you can see the dose of anthracyclines, and there is a clear relationship between the dose of the anthracyclines and the cardiac function. But you can see that this is not linear for all patients. So here are patients who have been exposed to a relatively low dose of doxorubicin, but experienced already cardiotoxicity. And then there are also on the right upper corner patients who received a very high dose of the anthracyclines, but even 20 years after the treatment, they are doing completely fine. And we were interested in this, specifically in this group, why are these patients so resilient to anthracyclines? And this is work which we almost are wrapping up. And we took iPSCs and we made tissues from these patients, and we made tissues from these patients, exposed them to anthracyclines, and you could actually recapitulate the phenotype. So the patients who were resilient were also resilient to withstand a high dose of anthracyclines. And like as a little look at it, it seems related also to mitochondrial function. I think that comes also back to the previous slides there. So we now try to rescue that phenotype with, for example, mitochondrial transplant, where you take mitochondria from these patients and you add it to these patients, and whether you can rescue their phenotype. And hopefully I can present some of that data within the coming months about it. So to conclude, I think an in-depth understanding of cardiotoxicity is needed. Why do certain drugs lead to toxicity? And that's not easy, because anthracyclines have been studied for more than several decades, and we still don't fully understand why they lead to cardiotoxicity and why that happens in certain patients, and it might be very likely that it's multifactorial. If we talk about modeling, it really depends on the research question, what kind of model. Do you want to do a large drug screen for small molecules? Go for organoids or go for simple 2D layer of cells. However, if you want to understand susceptibility and discovery of cardiotoxicity, you might be able to go to more advanced modeling. And I think, and that has been very clearly shown in a JACC Cardio-Oncology paper from Pietro, his group, there is a mismatch between the oncology drugs used in clinical studies and what we do study in clinical studies. And I think that's where we also need to work on that. So I thank you very much for your attention.
Thank you very much. It was very interesting, and as I understood, there is a lot of questions about the toxicity now, and toxicity now, and what I have learned, probably there are some drugs already used that we do not know about their cardiotoxicity much, or even sometimes it is under clinical exposure. So this cardiotoxicity, however, there is, and do you think that there are some drugs already used or already in the trials that can have the cardiotoxicity we do not know about it? Or
I think for sure. I think if you don't search for it, you don't find it. And I think that's also a discussion we had during the coffee. Like, for example, these CDK4/6 inhibitors, they are used in a metastatic breast cancer setting. So I think the thinking has been long, like, well, metastatic breast cancer, well, try to do its best for the cancer, and the heart, later. And I think with much better outcome, I think we will face much more, and these cardiotoxicity may preclude what we discussed during the coffee, may preclude further treatment. So it is very important. So I think we should better understand why it is happening, and some translational work can help to look more at causality instead of association, so that helps to make a stronger point there. And of course, we need, in cardiology, and that's the reverse cardio-oncology, which has also been touched upon, that if you have a heart problem, you have a higher chance of getting cancer, and if you have cancer, you have a higher chance of getting cardiac problems, not only due to the treatment, but also due to shared risk factors. So I think from both sides, we need to look better in heart failure trials, for example, what I'm doing a lot, we need to look at cancer outcomes, and in cancer trials, we need to look at cardiac outcomes. And I think that's a lot of networks are already working on that, but it's difficult. And big pharmaceutical trials are not always putting that much effort in it. So it's really these, I think what we're all doing, investigator-initiated trials, that's where we really need to focus on these, this collaboration.
Yes, it is very important. Thank you very much, Professor. And the other question, of course.
So with regards to CDK4/6 inhibitors, so ribociclib is the only one where it's mandated we do ECGs because of QTc prolongation. However, in the Fradley study that you showed, which used the One Florida database, you showed the increased risk of cardiovascular events, but that was across all three CDK4/6 inhibitors, not just ribociclib.
No, that's
and
true.
Since then, there's been a pharmacovigilance study published also showing the same thing. So it just goes to show you that, we're maybe missing information. And it's interesting because as those drugs came out, the other two competitor drugs focused on the fact that they were safe from a cardiovascular standpoint.
Yeah, I think that it would be unlikely that they would be safe if you showed a mode of action why a CDK4/6 inhibitor leads to cardiac dysfunction, I think.
Yeah, and I think that's just an understanding of why one of a family of three drugs do we see a signal.
Yeah.
And I don't think we clearly understand that.
No, so probably it's related to the E2F1 because that's a pro-survival. I think that also comes back to reverse cardio-oncology, that the pro-survival leads to tumors, but it may be beneficial for the heart, although it's of course a post-mitotic organ. So we don't exactly know why it is, but these overexpression of E2F1 has been shown to have a beneficial effect, for example, also on cardiac hypertrophy. So, but of course, inhibiting E2F1 like general for a patient may not, or overexpressing it in a patient with a cancer, of course, that's a no-go because that's the whole mode of action of that drug. But perhaps if you can get specifically cardiac targeting, that might be something. But this was more shown, we did it to show that it was really related to the drug and not like an off-target effect.
So we need more real-world data too, right?
For sure. And I think these, I'm not sure how many, if there are any randomized trials, probably not placebo-controlled anymore. So yeah, so it's really these old data where there was not specifically done an echo, perhaps an ECG. So with your, what Teresa also, what you showed, like with the AI, perhaps you can better understand whether, you know, it has an area on the curve of 0.93. So if you, with your ECG, you can predict already cardiac dysfunction, that would be a way perhaps to show that it's likely missed cardiotoxicity.
Thank you.
So the next and last question regarding so we have very limited Do we have more time to allow other questions? Okay, so let's start with you, from you. Yeah. Please.
I think there was a question. Yeah. Yeah.
I have a question related to the very important topic, whether the cardiotoxicity in general is off target or not. That was a really beautiful example of this, although the function is different, obviously. Yeah. But can you comment about the different drugs, how much we know about whether the cardiotoxicity is really off target? Doxorubicin, you know, topoisomerase 2 alpha beta, you know, and everyone is using doxorubicin. There are many other drugs. So just shortly, in your perspective, do we really know how many of these drugs use cardiotoxicity as an off-target, and how many of them have it linked to their mechanism of action?
What's off-target? I don't know. It's unwanted. Let's put it that way. Very difficult to answer, of course. I think what with anthracyclines, there is no way how you can. So for example, why we are so interested in mitochondria, it's oxidative stress, and I think we've also seen from. I can't pronounce her last name, but Beata, the director of the institute, where she liked that slide so much, like the topoisomerase, the cell DNA, and then how that relates to the mitochondria and oxidative stress. I think that's so complex that it's unlikely that there is just one pathway which will explain everything. But I think there is a pivotal role for the mitochondria, and that's and hopefully we can better predict already beforehand if the patient has a certain mitochondrial makeup, that patient would be more likely to get toxicity, so we can perhaps find a different treatment regimen for that specific patient, or already start with cardiopreventive drugs, etc. But that's really for the future, I think. Thank you.
So thank you very much. Let's proceed with the program of this session. The next one is a lecture on can we minimize radiotherapy-related cardiovascular toxicity? And the presenter is Barbara Alicja Jareczek-Fossa. She's a full professor of radiation oncology at Radiation Oncology Department, including the Proton Center at European Institute of Oncology, Milan, Italy. She's the president-elect of ESTRO and serves on key scientific boards, including, and some list of them. She's very deeply involved in many trials on radiology in oncology patients. What is also important that she's the author of nearly 500 publications. So please, Okay, so
hello.
Yeah, we are hearing you. Please proceed with your presentation.
Hello to everybody. Hello, good morning, Lano. So I'm Barbara Jareczek-Fossa. It's a great honor to be with you, even remotely. Thank you to Professor Schmidt, to Polish Cardiology, Polish Cardio-Oncology for the invitation. So I work in Milan. I work in the center where actually Cardio-Oncology was born. It was Dr. Cardinale, Dr. Cipolla, as you know, in beginning of 2000, so quite many years ago, they started discussing and cardio-oncology, and I must say, we are lucky because we really collaborate from the very beginning with cardiologists. So I'm a lucky radiation oncologist, discussing patients, managing patients from the very beginning with cardiologists. So I will try to answer the question: can we minimize the cardiotoxicity of radiotherapy? I'm radiation oncologist, I'm clinical oncologist, partially trained also in Poland, so I'm really happy to be today with you. We see that oncology the incidence is growing, so this problem and also the meeting is just underlining how the problem is growing. The cure rates are improving. The treatments, however, are more and more complex, both for medical treatment but also for radiotherapy. Today, multidisciplinary approach is standard. So fortunately, in many centers, especially if this comprehensive cancer center, it is quite easy. As a patient, it may be more challenging in case of the remote centers. And what we also notice, the patient expectations are higher. Maybe because they are more cured patients, so we are all very ambitious, we want to cure without complications. And I'm a radiation oncologist. I don't know if there is any other radiation oncologist in the room, but you probably know that there are 3 treatment modalities in oncology. And if we ask, probably you will say, okay, surgery. But if you see the numbers of patients cured from cancer, and today 2 out of 3 can be cured, surgery has been done in half of them, radiotherapy in 40% of them. So many patients, many cancer survivors received radiotherapy. So the cure is also thanks to radiotherapy. And these are our treatment plans. We know that radiotherapy is indicated in about 60% of all cancer patients. You see here we can treat any body area, chest, head and neck, pelvic tumors, and so on. And these are the plans. So this is as a form of virtual surgery. We can treat really any tumor, primary tumor, metastatic tumor, lymph node disease, and so on. The indications are many. So one of the most important is this curative treatment. So when the patient is undergoing radical radiotherapy, but many of them receive radiotherapy also as an adjuvant treatment, palliation, and more as ablation. So small volumes, high doses. And as I said, we can treat primary tumor or lymph node disease or metastatic disease. The request for radiotherapy is growing. It has been evaluated that about 20% will be the growth in the next years. Still, in many countries, even in Europe, and I have this data as a President-elect of ESTRO, European Society of Radiotherapy and Oncology, still, even in Europe, 1 out of 4 persons with indication to radiotherapy does not receive it. So it is not only for the problem of the machine, of the access to the tumor, but also the problem of referral or maybe multidisciplinary collaboration. It is still very cost-effective treatment. If you take all the costs for oncology care, radiotherapy takes less than 5%, costs less than 5%, so it's still very cost-effective. It is also the way to optimize spending because we do a lot of hypofractionation, so short treatments, not long treatments anymore. We can treat oligoprogression, so imagine patient on oncological treatment, chemotherapy, immunotherapy, all the lesions are in remission. There is 1 or 2 growing, so we call it oligoprogression. And in this case, instead of changing the line of treatment, and obviously there is limited numbers of lines, we can do the treatment for oligoprogressive lesions, and so the patient can continue the systemic pharmacological therapy. And also from the point of the research, I like very much the previous presentation with a lot of research. I think this is the way to grow and to understand how really our treatment works. So we have the problem as surgeons and radiotherapy, not only radiotherapy, but also surgeons, so all local treatments have the problem of quite low research funds available. Here you see the data published a couple of years ago. If we see all the public or philanthropic cancer research funds, less than 3% go to local treatments. But as I shown you on the previous slide, 90% of patients cured from cancer received local treatment. So solid tumors need local treatment. How radiotherapy works, and here we are if we discuss cardiotoxicity. So it works at the level. You see here the direct or indirect damage of the DNA through chemicals and then fail repair. We have the difference in the repair capacity. Normal tissue can repair, tumor tissue cannot repair. But anyway, we also touch normal tissue, and that's why the same effects may happen on the normal tissue level. From the clinical point of view, the clinical side effects or effects of radiation on normal tissue can be divided into big categories. It can be stochastic, very rare event, carcinogenesis, and I will not discuss it here. What we see every day, it is deterministic effect, gradual and dose-dependent, and it is a kind of acute and late inflammation. So we know more or less what is the mechanism behind radiotherapy effect on normal tissue. And as you see, it may be acute, so we see it during the treatment or in the first weeks, but it can be also late, so even months or years after. And indeed, we know the mechanism. So behind the radiation-induced heart disease, the main event is inflammation with all the cascade and all the cytokines. And here you see our plans again on the thoracic disease. So you see that it is rather mechanistic approach. We see, where is the dose, there will be the effect. So it's very easy way to understand, but also to prevent and maybe to treat the events thereafter. So here you see that everything will depend on the location of the tumor and the plan that we prepare. And fortunately, there is a lot of interest in the last years. So you see here the possible events of all oncological treatments on the heart with many possible scenarios and events: cardiac dysfunction, myocarditis, vascular toxicity, hypertension, arrhythmias. And all of them may happen also in patients undergoing radiotherapy. The interest is growing. You see here the PubMed and bibliometric results on the interest on cardio-oncology. So there are more and more data information available. But we know that our patients, and you probably know that the mean age of patients undergoing radiotherapy or patient with a cancer diagnosis, apart from pediatric patients, if we take adult patients, the median age will be about 60-65 years. So this is the age where 10 up to 30% of all of population actually have already some cardiology problems. So they already have some cardiologists and they have already some ongoing treatments. So these pre-existing conditions can really make life difficult, because then we have to treat thoracic tumors with some effects of already not healthy organs. So the question of my presentation, the title was, can we minimize radiotherapy-related cardiovascular toxicity? I would say the answer is quite easy. Yes, we can. Because for more than 10 years, we have very clear correlation. We have this New England Journal of Medicine publication showing very straight, direct correlation between the heart dose and the cardiac events. And there is no threshold. So the dose should be as low as possible. And we know that if the dose is growing, every gray as a mean heart dose will increase cardiac events, and here I speak mainly about late events. The increase is about 7%. So this is very intuitive. To prevent these events, you just need to work on the dose to the heart. Indeed, here you see the evolution from the technical point of view. So you see in the 20 years ago, it was 3D conformal radiotherapy. This is a breast tumor. And left breast, you see that the heart receives some dose. And then we moved to IMRT or even to proton therapy in difficult cases. And you see how the dose is becoming really low or even zero. Today, it's not only the mean heart dose. We have a lot of data on different radiosensitivity of different heart structures. So today, when we contour the heart, it's not like a ball. It must be contoured with all the substructures, and we have some dose limits for every substructure. And some of them are more sensitive, so we are more careful for some of them, and we can still have some compromise for the others. And this is, our support we have also from the AI and auto-contouring, auto-planning. Today we are very careful about some substructures of the heart. As an oncologist, I see two big trends in radiation oncology. From the one point of view, there is really a revolution in technological and biological precision of the treatment. And I would say this first strategy really helped us to reduce the hard dose. The second trend, which is a combination of radiotherapy and new drugs, actually adds some challenges here. And we nicely have seen it before, Professor Van der Meer, and I'm sure that also Professor Curigliano showed you a lot of new drugs with a new toxicity that we are not used to manage. So what we have as if on the technological point of view to reduce hard dose, so we have starting from patient positioning, and the position of the patient that can make the distance between the target and the heart bigger, so we reduce the dose. Deep inspiration, breath hold, so the treatment is given only when the heart is far from the target. Accelerated partial breath irradiation, so we reduce the volume that we treat, and obviously hypofractionation and modern planning, as you've seen already also with proton therapy or IMRT. This is an example. I mean, all the studies we have for the partial breast irradiation, so instead of treating all the breast, in some patients, not all of them, but patients with low risk, as an adjuvant radiotherapy, we can treat only the quadrant of the breast. And in this way, obviously, we use the hard dose. What about the new drugs? So as I said, it is becoming really more and more common that our patients received combined treatment. So not only surgery, not only radiotherapy, they receive combined multimodality approach. It can be, for many years, it was chemotherapy, and we have a lot of data on chemoradiotherapy. But in the last 10 years, patients receive target therapy, TKIs, antibodies, and immunotherapy. And all of them, they have new toxicity, new side effects. This is the example of the difference. Thoracic radiotherapy induces heart disease. So what type of disease, what the event you can expect, and what is the immunotherapy-related heart damage. They are quite different, and obviously the toxicity will sum if we do radiotherapy in a patient undergoing also immunotherapy. And here you see the synergistic effect. So if we combine sums, really 1 + 1 is 3. So we have this effect of the escalation of toxicity. That's why we have to be very, very careful in patients undergoing combined treatment. It's, increased effect on the tumor, but also increased toxicity. That's why multidisciplinary here and collaboration with cardiologists from the very beginning, before starting any treatment, is really essential. So what we should do? Prevention is absolutely the key here, screening, evaluation, and treatment. What about the prevention? So as a radiation oncologist, we are really working hard on the planning, dose-sparing techniques, heart-sparing techniques, IMRT, protons, risk factor modification. I mean, this is probably the easy win. We have a lot of, as you probably know, that of all tumors are cigarette smoking related. So 1/3 of our patients usually are heavy smokers. So, this kind of risk modification, even late, but we know that it is already better late than never. Patient education and monitoring, clinical intervention, microbiome modulation, and so on. And indeed, in the literature, we will find a lot of algorithms, data, how to manage the patient before the treatment, how to do the best treatment possible, how to monitor the patient during the treatment, and after the treatment. And again, there are also some new, this is from our radiotherapy society, showing how patient must be managed based on the pre-existing conditions, but also on the hard dose. So the patients undergoing the treatment with high hard dose, because the tumor is near to the heart, obviously must be monitored differently than the patient receiving 0 or very low dose and having no pre-existing conditions. And this is another algorithm, so we see a lot of these proposals in the literature for radiotherapy and immunotherapy. So coming to the end, I would just mention that our collaboration is not only cardiotoxicity of the treatment, but we have very nice collaboration as radiation oncologists with cardiologists for management of patients with cardiac implantable electronic devices. And as you probably know, about up to 5% of our patients have these devices. And every patient must be seen before together with cardiologist based on the dose that the device will receive. So we do the plan, we discuss the patient with the cardiologist, based on the dependence and the dose, we decide the algorithm, either cardiologist here with us or only monitoring before and after the treatment. Another very nice collaboration we start to have, it is cardioablation for cardiac arrhythmias, and I'm sure that many of you already discussed it, maybe already have these protocols. Here in Yale with Monzino and other cardiology institute here, we just concluded phase 1, phase 2 study on cardioablation, one single fraction to patients with advanced ventricular tachycardia. And you can find these papers also in the PubMed, so I will not show this data, we don't have time, and I hope we have time for some discussions. So take-home messages. Modern series show reduced cardiac toxicity versus historical data because there is awareness. We reduce the dose with our new techniques. There is still ongoing. There are still many ongoing challenges like long-term follow-up, systemic cardiac, new drugs and new cardiotoxicity, patient-specific risk factors. The future is obviously the growth of cardio-oncology, and I'm really happy for this initiative also for Professor Schmidt. I know that he's one of the Polish cardio-oncologist, advanced imaging, biomarkers, AI, and so on. And definitely networking and collaboration is key here.
Thank you very much. We are a little bit short of time, so we move the discussion to the end if we have time at the end. And let me introduce the next speaker is Bonnie Kai, Professor Bonnie Kai, Editor-in-Chief of JACC Cardio-Oncology. And the talk will be about the best of JACC Cardio-Oncology. Please, it's an online also.
Hello, my name is Dr. Bonnie Key, and I'm the Founders Professor of Cardio-Oncology and Director of the Thalheimer Center for Cardio-Oncology at the Perelman School of Medicine at the University of Pennsylvania. I also serve as Editor-in-Chief of JACC Cardio-Oncology. I want to thank Sebastian and his colleagues for this tremendous opportunity to present to you today highlights from JACC Cardio-Oncology, our work in advancing the field of cardio-oncology together. In terms of our fundamental mission and vision at JACC Cardio-Oncology, we seek to innovate and advance actionable science in empathic, evidence-based cardiovascular care for all patients living with and beyond cancer. And my vision for the journal, when we started this together 6 years ago, is to grow and build a community that advances cardiovascular health and enables longer, healthier lives for all. What are our strategies to achieve our mission and vision collaboratively with all of you? Well, number one, we want to curate the most impactful science and advance evidence-based, actual knowledge and care. We want to deliver knowledge with innovation and ensure accessibility for all. We seek to strengthen the global community and the pipeline investigators and clinicians with a focus on humanity and excellence. And we seek to inspire innovation, collaboration, and patient-centeredness. In order to achieve these essential strategies and our successes, it really comes down to defining and addressing our key scientific priorities in cardio-oncology research and clinical care. And in the next few minutes, what I'd like to do is to share with you what I think are our priorities for our field and highlight examples from JACC Cardio-Oncology, recent publications that I feel are moving the field forward in terms of addressing these priorities. Number one, we need to define the epidemiologic basis of cancer and cancer therapy-associated cardiovascular disease in the modern treatment era and ask and answer, in whom does cardiovascular disease occur? Why does this occur? And then further, how can we use this knowledge to help mitigate the risk of cardiovascular disease and informed care, again, in the modern treatment era? And excellent examples of this work from the immune checkpoint inhibitor therapy space come from Dr. Itzhaki Ben-Zadok and colleagues, where she has defined in a single center experience updated one-year cardiovascular mortality outcomes and all-cause mortality outcomes in patients with severe, non-severe myocarditis and compare these to negative cases, defining that one-year cardiovascular mortality rates in those with severe myocarditis are on the order of 29% compared to 5% in those with non-severe. No differences, interestingly, in all-cause mortality across all three groups. Moreover, work from the International Immune Checkpoint Inhibitor Myocarditis Registry, over 700 patients, show what are the risk of LV dysfunction in ICI myocarditis, what are the clinical predictors, and then what are the clinical outcomes as well if a patient experiences LV dysfunction, hazard ratio 1.50 in terms of 30-day all-cause mortality. Number two, we need to find the mechanistic basis of cancer and cancer therapy-associated cardiovascular disease. Ask and answer, what are the basic mechanisms by which cancer and cancer therapies increase cardiovascular disease risk, and how can we use this knowledge to best inform cardioprotective therapies? Work led by Paul Burridge, Yadav Sapkota, and colleagues detail what are the doxorubicin-induced cardiotoxicity-related genes in terms of the pathophysiology of DOX-associated cardiotoxicity, including alterations in iron uptake, reactive oxygen species production, doxorubicin transport, electrical activity, DNA damage, and calcium handling. And moreover, work led by Bora Banyas, also in a basic translational study, details what are the changes in cardiac structure, cardiac metabolism, and mitochondrial quality, and how this may inform subsequent intervention strategies such as remote ischemic conditioning. Number three, we need to advance the field of bidirectional cardio-oncology and define the mechanisms of both cancer and cardiovascular disease. This is a really exciting field within cardio-oncology, looking to ask and answer, how does cardiovascular disease potentially increase cancer risk? And I think this leads to a fundamental question for our field in terms of asking and answering how we can translate our understanding of both cancer and cardiovascular disease to our patients and help develop new therapies that really target both disease states. And Caitlin Bell, along with Nicholas Leeper and colleagues, published a really phenomenal epidemiologic study detailing the increased risk of cancer after a diagnosis of cardiovascular disease, suggesting a hazard ratio of 1.13 for patients with cardiovascular disease compared to no cardiovascular disease in terms of risk of incident cancers. And there was an increased risk of specific cancers, including lung, bladder, colorectal, and heme malignancies. Moreover, those patients with atherosclerotic cardiovascular disease seem to have an even greater risk, hazard ratio 1.2-fold increase. And moreover, basic studies, those led by Drs. Tani, Takeshi, and colleagues, suggest that heart failure post-myocardial infarction can actually promote mammary tumor growth through the NGF-TRKA pathway. And in August, we just published a focus issue on this topic of bidirectional cardio-oncology with a really excellent state-of-the-art review led by Drs. Conetti and colleagues, detailing the epidemiologic overlap as well as some insights into the basic mechanistic overlap. Moreover, we had a state-of-the-art review on CHIP, a really exciting growing field in clonal hematopoiesis and the risk of not only cancer, but importantly also that of cardiovascular disease. A short form primer led by Rudolf de Boer, detailing the risk of cancer through heart failure and the cytokines and inflammatory markers secreted in response to heart failure and how they may implicate and increase the risk of cancer development. And then a really excellent basic science paper led by Catherine Moore and her group, detailing how acute peripheral ischemic injury can actually also accelerate mammary tumor growth. Number four, we need to understand and determine individual patient risk and ask and answer, what is our individual patient's absolute cardiovascular disease risk in the context of the competing risks of cancer? This is fundamentally important when we counsel our patients in our clinic. What is actually the absolute risk, not just the relative risk? Because oftentimes we can read studies where we can see there's a twofold greater risk. When we look at the absolute risk, it's 1% versus 2%, for example. Also, what are the imaging, biologic, social, and clinical factors that most accurately and precisely explain and predict cardiovascular disease and cancer risk. We know from work led by Celeste McCracken and Dr. Razi Asterbrag in terms of what are the predictive performance of cardiovascular risk scores in our cancer survivors. We know that these traditional cardiovascular risk scores do not perform well in our cancer survivors. Why is that? Well, largely they were not derived in cancer populations, mostly in patients without a history of cancer. Moreover, they do not account for cancer treatment regimens for cancer itself, which we know may modify and can be major modifiers of cardiovascular disease risk. Work led by Jan Leering and Walter Koch and colleagues do detail in adult survivors of childhood cancer that if you take a clinical model, and those factors here in their clinical risk model do include age at cancer diagnosis, age at study, anthracycline dose, and chest-directed radiotherapy, as well as sex and heart rate. If you take that clinical model, add to it biomarkers, you can actually improve upon the AUC of the model, as well as the specificity of the model and the negative predictive value. Number 5, we need to accurately and precisely phenotype disease to provide care according to risk, and ask and answer how can we best characterize cardiovascular disease with high accuracy and precision for all across the globe. And what is the role of imaging or biologic measures? And what is the importance of subclinical cardiovascular disease? And then how can we further leverage this understanding to better target cardioprotection according to risk? And work led by Dr. Masanich and Siri Heck and colleagues detail the work that we still need to do as it pertains to cardiovascular biomarkers in terms of understanding cancer therapy-related cardiac dysfunction. Here, their work demonstrated that according to how you define troponin elevations, according to sex-specific or not, and what platforms you use, you can come up with dramatically different definitions of cardiotoxicity. And really, mild asymptomatic CTR-CD was not associated with subsequent CTR-CD development. So again, a lot more work we need to do in the biomarker field in terms of understanding cardiac dysfunction. Number 6, we need to innovate using AI to advance science and clinical care, and ask and answer what is the role of AI and machine learning in phenotyping and predicting cardiovascular disease, and how can we leverage AI to innovate in screening, recruitment, and clinical trial processes. And really elegant work led by Kate Atkins and Raymond Ack detail what is the risk of radiation-induced cardiotoxicity using AI to delineate cardiac dose volumetrics and really delineate the dose to pulmonary veins, this left circumflex artery, the right coronary artery, and the left main coronary artery. Really exciting work in terms of where the field of radiation oncology is headed. Number 7, we need to innovate our cardioprotection strategies and ask and answer what are the most effective cardioprotective strategies and what newer strategies might exist, and what is the optimal duration of cardioprotective therapy. And in the session prior to this, you just heard about exciting clinical trials in SGLT2 inhibitors, and indeed a lot of exciting interest in this field as it pertains to SGLT2 inhibitors, not only for their cardioprotective effects, but potentially also according to their anti-cancer effects. And again, work led by Borja Banya's group has detailed what are the potential basic translational mechanisms by which SGLT2 inhibitors may exert a cardioprotective effect in terms of improved cardiac energetics, maintaining mitochondrial fitness, and increasing myocardial ketone body consumption. A lot of interest also in exercise, and work and data has suggested that aerobic exercise can improve upon VO2 in our cancer survivors, and also a lot of excitement towards diet. And there are retrospective studies that suggest that Mediterranean diet is associated with lower all-cause in cardiovascular mortality amongst long-term cancer survivors. Also, in terms of what we should do, in terms of once we start cardioprotective therapy, can we ever stop? Really nice retrospective analysis led by Drs. Park, Anand, and colleagues suggests that in patients who discontinued cardioprotective therapy, there was an increased risk of suffering from major clinical events, adverse clinical events, hazard ratio 3.06, and this was exacerbated in those with an ejection fraction less than 45%. Number 8, we need to innovate in our clinical trials and ask and answer what are meaningful endpoints and what are innovative, rigorous study designs to pragmatically test our hypotheses. And we were very fortunate to publish the PROACT study led by Dr. Austin and Plummer and colleagues, suggesting in this study of high-risk cancer patients who received high-dose anthracyclines that enalapril did not have an effect in terms of GLS, ejection fraction, and troponin. Granted, this was an early time point in terms of 1 month post-chemotherapy in terms of the endpoints, however, very detailed assessment of these measures of cardiac function, injury, and remodeling. Number 9, we need to implement equitable, inclusive, high-quality care globally and ask and answer, what are the standards of care for our patients? If standards are not being met, then why? And how can we deliver the best possible care to the right patient at the right time and the right place? And work led by Mamas has suggested that cancer patients who have suffered from STEMIs, when admitted to the hospital, they receive less coronary angiography, they're discharged on less post-STEMI medications, and are more likely to be readmitted. We need to do better, and we need to understand why this is happening and develop quality care metrics by which we can adjudicate and define how we're doing in terms of the care of our patients, and steps in the right direction include that quality of care measures, state-of-the-art review, led by both the ICOS and ACC Cardio-Oncology Leadership Council, detailing a roadmap for us in terms of how the field can move forward in terms of developing quality of care measures and assessing these for our patients. And of course, we need to continue to fill gaps in evidence in cardio-oncology, clinical care, and science together as a community. We all recognize what a triumph the 2022 ESC guidelines were in terms of cardio-oncology. But we also know that there's a lot more that we need to do together as a field in terms of filling gaps in evidence prior to, during, and after cancer therapy. And at Jack Cardio-Oncology, we commissioned an expert panel series looking to address these needs. In closing, again, I wanted to thank you for this tremendous opportunity to share with you highlights from Jack Cardio-Oncology. And I'd also like to share with you my hope for our field. My hope and my earnest desire for our field is that we can continue to be cohesively driven by this common mission of providing the best possible care for our patients so that they can live longer, healthier, and fulfilling lives. And fundamentally, I do believe that this is through evidence-based care, empathic care, accessible care, and inclusive care. And in these very trying and challenging times for our field and for the whole globe, I would say that we need to focus on science, on humanity, and integrity. And fundamentally, our collaborative mission is to transform cardiovascular care and improve heart health for all. And we envision a world where science, knowledge, and innovation is really what optimizes cardiovascular care and outcomes. With that, again, I wanted to thank you very much for this tremendous opportunity to share with you. Thank you.
Thank you, Professor Kai, for this important conclusions and for showing us all these important studies. But if you have to choose one which can change the most our everyday practice and everyday patient care, which one it could be, in your opinion?
Well, first, thanks for that really interesting question, and thanks for the opportunity to present. Sorry I can't be there in person, but have clinical care patients to take care of here in Philadelphia. I think that's a great question. If we could only choose one, something I've been very passionate about since the beginning of my research career in cardio-oncology is risk prediction. I think identifying the highest risk patients and that concept of precision phenotyping, defining the epidemiology of disease, and so we can treat, so we can understand who will develop cardiotoxicity, what is cardiotoxicity in the modern treatment era, and then form a risk-guided cardioprotection so we can treat the right patient at the right time, at the right place. That's where I would really, if I were to only choose one thing, and I'll just add that it's critically important that we work together as a field. It's all about collaboration and investment in each other and in our patients and in the field.
Thank you, Bonnie. Excellent presentation. Sebastian Schmidt from here. I have a small question. Do you think this is a moment to update the guidelines, and what you'd propose to change in the guidelines? ESC, of course, guidelines.
Oh, that's a great question as well. Yeah, when is the right moment, right? I think that takes consensus from the field and from the input of the key stakeholders. When is the right moment? Because undoubtedly we are generating a lot of evidence, but not sure if we're still not there yet. It's only been 3 years. I think it's a short time frame. I really think we need more robust evidence for the next, version 2.0, to tell you the truth. I think that's what I think in my heart. But key to engage all the stakeholders and get their input on when is the right time as a field. We should be reiterating.
Okay, thank you. Thank you very much, and thank you for being with us. So we move to the next presentation. Let me introduce with pleasure Professor Robert Gill, the president of Polish Cardiac Society, and he will talk about coronary artery disease in cardio-oncology perspective of an invasive cardiologist. Please, Robert.
Thank you very much, first of all, to the organizers giving me opportunity to share my opinion on this specific and very important issue, that is perspective of invasive cardiologists. Why? Because we still have to remember about the fear which is caused by oncology among our society. It impacts on our decision-making process for sure. And I still remember when I started my medical career, carcinoma was a contraindication to do any invasive, any operative procedures. That was just like a sentence, a verdict for these patients. Right now, I would like to present you my personal approach. I was forced by Professor Sebastian to go through that, and I realized in a certain moment that it touches me, and this is maybe this is information what we have to do just to increase the knowledge about the oncology problems, and how we as cardiologists should basically our patient. Why? Because in majority of cardiologists, cardio-oncology is just a useful, helpful role of cardiologists to improve oncology treatment, but it doesn't work let's say in another direction. So this bi-direction relation between these two groups of professionals should be changed. First of all, let's start, which is green. Green. Okay, I'm sorry. First of all, this is a point of disagreement between oncology and cardiology. Theoretically, mortality is more related to problems of cardiovascular system rather than to cancer. Even if we go for standardized indices, we see that first of all, circulatory diseases are on the first place. This is true, but we see the differences between western and eastern part of Europe. This is the problem that exists, and the consequences of this problem is illustrated by the fact that, as I already mentioned today, oncology has own especially financed program beating cancer, but for cardiovascular diseases, it doesn't exist. Why? Because for Western countries, the mortality is, let's say, higher for cancer-related problems rather than cardiovascular. So we have to work on that to change. Otherwise, we have to remember that still, despite these differences, we have some links. We have some patients that suffer from cardiovascular in terms, let's say, being also unhealthy in terms of cardiovascular diseases. It's a significant percentage. For men, it's almost 10%. For women, 8%. So we should take into consideration this fact that both groups of patients are very close to each other. We meet this patient as a cardiologist. We should be much more aware, and we should be prepared for real help to them. What was also very striking for me when I look at the literature, that the improvement in a survival of the patient with cancer really improved. So we see instantaneous increment of longevity, I would say, or survival of the patient with cancer. This is it's already not just a verdict. This is just a disease which should be treated. Of course, the results of this treatment is related to how fast the diagnosis and the real optimal diagnosis was found and how it was treated. If you take into consideration the development in this topic, in this field, we should believe that the survival will improve more in the coming future. And of course, as a cardiologist, we should look at the diagnosis of the patient. There are significant differences in terms of survival, time of life for people regarding the type of cancer. And this is also very important. It's related to the efficacy of treatment for different cancers. So we, as cardiologists, should be aware of that for sure. What we should know also, that this is the problem of this toxicity, which was mentioned many times today already. But as interventional cardiologist, what I really keep in my mind is the fact that, first of all, these drugs impair the function of endothelium. This is one. The second, it impacts also the let's say plattles, and of course it has some connection to atherosclerosis process as well. These facts should be taken into consideration, especially that in a contemporary interventional cardiology, we are forced to use double antiplatelet therapy, which is, of course, is on one hand protects the patient, let's say, against thrombus, but on other hand, can be a cause of hemorrhagic problem in our patient. But if we look at these tables, we can appreciate that this is the truth, that the patient with cancer are prone to increased percentage of hemorrhagic and ischemic events, which is of course correlated to worse let's say, outcome of the patient. We should take it into consideration, and in this paper was stated how important is knowledge and experience of cardiologists just to choose a proper antiplatelet therapy, which is a crucial just to keep the effects of revascularization, percutaneous revascularization process, which is available very well in our country. This is also the very important information that let's say cancer doesn't mean the same in all clinical scenarios, because first of all, as we can appreciate in this slide, we know that metastasis problem is the biggest problem of the patients. And what does it mean? It means that the more, the better we treat the patient, the let's say, probability of recurrence of process improves the outcome of the patients. What I would like to let's say to express that there are many papers showing how important is this optimization process of antiplatelet therapy. But we know that nowadays we have drug-eluting stents with a very thin struts. We can improve, we can optimize our results with intravascular visualization process as well. And then we also have possibility to manage this antiplatelet therapy, taking into account many trials showing that shortage of the dual antiplatelet therapy is available, especially after optimizing procedure of stent implantation. Just one sentence regarding TAVI, I mean percutaneous aortic valve implantation procedure, which became also very popular in Poland. This procedure increased probability of survival of patient with severe aortic stenosis, and you can appreciate from this table, just to shorten this illustration, that the patient with and without cancer problem has the same outcome. This is a very important message, because more than 75 years old, a patient mainly sent for this way of treatment can have also the cancer problem, and this is not a contradiction for them, not at all. Of course, just to remind you that we, the cardiologists, know that many modifiable cardiac risk factors are equal for oncology. We can appreciate this here. But we should remember that the processes which are related to endothelium, to platelets, the problem with inflammation process, it's very important, and in a relation with cancer is very important in terms of acute coronary syndrome problems in our patient. What is also important to be known by cardiologists, that radiotherapy, which was mentioned today, is also theoretically causable for problems with thrombosis and intercoronary thrombosis, and with acute coronary syndrome. We also know from the literature that the number of percutaneous, let's say, primary PCI in patients with a cancer problem is not sufficient. The volume of this patient is rather low. Might be it's too often contraindication in a certain of centers, but we have to remember that the results are comparable to the patient without acute coronary problems. The biggest problem is a patient with recurrent process, metastasis. And of course, we have also remember that the population of patients with cancer is relatively old. We have to take into consideration all of new factors which were not taken into consideration, let's say 5-10 years ago. So-called frailty. This is also a kind of message, information, how important can be, and let's say for vascularization compared to surgical approach. I don't have time to go into the details, but these slides show what kind of fields of areas should be taken into consideration by the cardiologist, mainly by interventionalists, because there are some relations between all of these fields, because we have the processes which are, let's say, connected to the focal changes in the organ, in vascular, let's say, field, but we have also these modifiable and not modifiable risk factors. But radiotherapy and chemotherapy bring us additional problems which should be taken into consideration. Just to conclude my presentation, I'm truly aware how important is understanding from both sides, how important is cooperation with these two very important specializations. We have to remember that together we are responsible for 60% of mortality patients in nowadays. Thank you very much for your attention.
Thank you very much, Robert. If you allow me not to ask you a question, it could be great, because we are now out of time. We have another presentation from Professor Maciej Banak, very important speech about lipid-lowering therapy for better prognosis of cancer patient. And Professor Banak is the president of both International Lipid Expert Panel and also the president of Polish Lipid Society. Please.
Thank you very much. Thank you, Sebastian, for being here. And it is a great opportunity and great pleasure to say a few words about the lipid disorders in cancer patients, especially as you could have seen on the previous presentation of Professor Robert Gill, when he talked about the modifiable risk factors. Lipid disorders were not mentioned at all. So it was quite fun, and especially a great introduction for my presentation. Okay, these are my disclosures. We know it very well for many years, taking into account the different data we have had from global burden of disease, as well as the WHO, that we have 21 million deaths attributable due to cardiovascular disease. Fortunately, it is about 2/3 attributable due to atherosclerotic cardiovascular disease. These are quite modifiable. But if we look at the number of cancers, we know it very well that the number of cancers is twice less in comparison to atherosclerotic cardiovascular disease. This is critically important because when we talk about the cancer, everyone is afraid of the cancer. But if we talk about the cardiovascular disease, I could have heard, for example, from one of my colleagues, interventional cardiologists in Poland, that don't be afraid. People in Poland knows that we are very good in what we are doing. So they are not afraid of cardiovascular disease in Poland. So yeah, we need to change our approach, because it is critically important to talk about the number one killer and how to overcome these numbers, especially as you look at the risk factors. We have the same risk factors for cardiovascular diseases as well as for cancer. So if we are very effective in the prevention, and optimal management of cardiovascular risk factors will be also effective for all civilization diseases, including also cancers. What is more, we know it very well that in cardiovascular disease, if you would like to be effective, we need to look also not only for the LDL cholesterol, glucose, and many other cardiovascular risk factors, we need to look on the comprehensive view of the patients. And this is the same for the suitable prevention of the cancer patients. If we are effective with prevention, not only looking for the, when we are not LDL-centric, glucose-centric, and we focus on all risk factors, we might avoid and prevent a disease. And it is the real issue of prevention, because please notice that mostly in most of the healthcare system, in most of the guidelines, we focus on the disease already. So we are talking how to be effective on patients after MI, and we are talking how to be effective in patients with cancer. But we are not talking enough in order to how to be effective in order to prevent cancer. What is more, we know it very well that these are something which is called modifiable risk factors or risk modifiers. Please have a look at these guidelines that they were presented at the European Society of Cardiology meeting in Madrid as an update of the 2025 update of the EAS and ESC guidelines. And please have a look at the number of different risk factors that we know it very well that they modify cardiovascular disease risk, but there is no cancer disease by itself. And we know it very well, taking into account the numerous papers that cancer disease by itself is an independent risk factor of cardiovascular diseases. Please have a look at our also lifestyle changes. It is an ILAP SMILE algorithm we introduced several months ago. If we are effective in those lifestyle changes, including obesity, including physical exercise, including smoking, and so on, we will not only be effective against to prevent cardiovascular disease, but we also significantly reduce the burden of cancers. And what is more, we know it very well that we are very, very much effective, and Professor Robert Gill also mentioned about this, in order to be very early in the diagnosis of the atherosclerosis. And if we are very early in the diagnosis of atherosclerosis using AI algorithms, we can also suggest lifestyle changes and suitable treatment, including statin therapy. I would like to focus a little bit more. That might also be very effective in the prevention of cancers. Okay, so let's focus on the cardio-oncology area and the role of lipid disorders. We have two issues, as you can see. One issue is associated to the fact that cancer by itself, and you have very recent data just published showing that despite we might have the same results concerning the LDL cholesterol, concerning the treatment drugs that were used in those with and without cancer that underwent acute coronary syndrome, they were the MACE events, and so the number of the cardiovascular outcomes were much higher in those with cancer in comparison to those without. But on the other hand, please also look at our the registry we started in the Polish Memorial Hospital Research Institute, in which we wanted to see how many patients are diagnosed with cancer, are diagnosed with lipid disorders. You cannot imagine, lipid profile is measured in 7% of patients with cancer, 7%. And this is not the issue only of one center, of the Polish Memorial Hospital Research Institute, the second largest hospital in Poland. But when I talk to other experts, mamas, and many others, we know it very well. This is a great problem in all the countries in Europe, and this is the same for obesity, the same for diabetes and many other different things. And what is more, even in those, as you can see, who are measured with lipid profile, if we look at the drugs that were used, they were completely undertreated and not effectively treated, taking into account the LDL cholesterol. Okay, so one thing is that we should treat patients with cancer as those that should have the same methods of cardiovascular prevention as those without. Why? Because taking into account the personalization treatment of cancer we have now, which is highly effective, taking into account overall survival as well as PFS, we know it very well that those patients may die not due to the cancer by itself, but may die due to the cardiovascular disease. The second issue is associated obviously with the drugs and side effects of the drugs. Please have a look at the number of different classes of drugs and how they affect lipid disorders. This is an amazing problem because for many of those drugs, they simply increase the level of not only LDL cholesterol, not only total cholesterol, not only triglycerides, but also ApoB and lipoprotein A. If we look at the very concrete example, you probably know the lorlatinib, a very well-recognized drugs for those patients with lung cancer. As you can see, lorlatinib might cause a very severe hypercholesterolemia and very severe hypertriglyceridemia, which is quite similar to those we observe for patients with homozygous FH as well as those with familial chylomicronemia syndrome. So that is why in those patients, we might expect, for example, acute pancreatitis as well as very progressed atherosclerosis process. And obviously, it is still possible to avoid those side effects having suitable lipid disorders treatment. But if you look at the suggestions made by oncologists without any communication with cardiologists and lipidologists how to overcome this, it is quite interesting and surprising because please consider statins. Please consider statins for LDL cholesterol 300. Please consider fenofibrate for triglycerides over 500. Come on, it is ridiculous, simply. Let's communicate to each other, let's work together, and let's collaborate with each other, as have been already mentioned at the previous presentation. Okay. What is the link between the cancer and lipid profile? There are many links, but I would like to put your attention for at least two. One of them is associated with the HDL cholesterol. So something you may consider as a good cholesterol. Come on, it is not good cholesterol at all. Please forget about it, right? There is no good cholesterol. If you are talking about the cholesterol, it is simply bad. So please don't consider HDL cholesterol as a good cholesterol. Especially, we know it very well that HDL cholesterol, having, for example, inflammation process, glycation process, oxidative stress process, is simply dysfunctional. So it is the same, and it causes the same risk as LDL cholesterol, non-HDL cholesterol, ApoB. And what we've noticed, please notice that we have a number of trials that saying that if we have very low HDL cholesterol, we might observe higher risk of the all-cause mortality associated with the cancer and higher risk of metastasis in those patients already with cancer. And as you can see, for every 10 milligrams per deciliter increment in HDL cholesterol, there was a 36% lower rate of the development of the cancer. What is more, if we look at these data from the Copenhagen study, there is an even U-curve. So very low and extremely low level of HDL cholesterol, as well as very high level of HDL cholesterol over 100, were associated with the risk of cancer and metastasis of the cancer observed during the cancer. And it was also confirmed in our study based on the REGARDS study in the US, and especially what was quite interesting, in women, not in the male patients, which requires further investigations. And we look in detail what is the issue outside this, in the background of this association. We've noticed that it's always associated due to the fact to the scavenger receptor B1 as well as ABCA1 and ABCG1, which are strictly associated with the transfer of cholesterol to the cancer cells. So that is why cholesterol, HDL cholesterol, is associated strictly with the cancer prognosis and with the cancer formation and with the cancer advancement. So that is why it is so important. I would like to tell you, for your interest only, that now we are checking whether an HDL cholesterol or even some of the premature HDL or even small dense HDL or large binaural HDL cholesterol might be a very sensitive biomarker for cancer by itself and the progressed cancer or advanced cancer, taking into account the metastasis we might observe. What is more, there is no issue that, and no doubts that lipid disorders are associated with the risk of cancer. Please notice for 3 targets we usually have in the lipid disorders patients. So PCSK9 protein or PCSK9 gene as you prefer. So the gene related to the LDL cholesterol as well as CETP protein. And for all of them we might observe the risk with the cancer. So LDL cholesterol, lipid disorders, and all the processes associated with this. So atherosclerosis progression, inflammation, endothelial dysfunction are associated simply with the progression of the cancer. What is more, please have a look at our data with anti-PCSK9 vaccine. It is still ongoing studies we are doing because we hope we will be able to introduce to the market anti-PCSK9 vaccine. These are the data from the experimental studies that using anti-PCSK9 vaccine. So if we have an opportunity to block completely PCSK9 protein, which is associated with the metabolism of cholesterol, is associated with the significant reduction of the risk of breast cancer, colon cancer, because such models we were able to have in this study. Okay, what about the treatment by itself? Why the patients with cancer are completely undertreated, taking into account the lipid disorders? First of all, it is the fear of statins, right? Everyone is afraid of statins. Come on, there are so many patients that came to me and say, I don't want to use statins because I think that I will go to Cosmos or something like that because I've heard everything about statins already. So please have a look at the number of statins we have. And obviously, if we are afraid of the drug-to-drug interaction, which is in 99% related to cytochrome P450-3A4, these are only associated with atorva and rosuvastatin. For atorva and simvastatin. For rosuvastatin, there is no risk. And for pitavastatin, which is already on the Polish market, pitavastatin does not use the metabolism with the cytochrome P400 and 3A4. So there is no that drug-to-drug interaction. If we look in detail for the role of statins, it is one of the largest ever meta-analysis we did in chronic liver disease patients. And please have a look, these are not only effective in those patients with hepatitis B and C viruses disease, but also it is associated with the significant less risk of cancer by itself and significant less mortality in those patients treated effectively with statins. So statins should be indicated for all those patients with cancer already. What is more, it is finally, because we know these mechanisms very much. I don't want to focus on it. Please don't be afraid, don't be worried about it because it is quite complicated. But this is our recent study we published together with Sebastian on the novel approaches for the management for the doxorubicin-induced cardiotoxicity with statins. And please have a look, many different mechanisms by which statins are very effective in order to avoid cardiotoxicity in those patients. And what was quite surprising for us, in the update guidelines 2025 of the management with lipid disorders, it was included in this guidelines. So obviously it is a very short message, but it is the first step in order to have how to treat lipid disorders in patients with cancer, which is the very important group of patients, and they should be treated well in order to prolong survival in those patients. Okay, what about pitavastatin once again? Why pitavastatin is so effective? Because first of all, it does not use cytochrome 450 metabolism, but on the other hand, it is the statin associated with the lowest risk of the side effects. This lowest risk of the side effects is associated with the role of pitavastatin at the level of mitochondria, because they does not reduce the coenzyme Q10 in the mitochondria in comparison to rosuva and atorvastatin. So please consider for your patients, if you are afraid of the side effects. However, it is not the true at all, taking into account the drugs we have and innovative drugs we usually have in cancer patients and we usually use, that pitavastatin is the one that you may use because it does not increase the risk of the side effects, especially those associated with the statin-associated muscle symptoms. Please have a look at something which is again with lorlatinib. What was the suggestion of those after the Crohn's study you probably recognized well? Lipid-lowering therapy may include statins, nicotinic acid, which is not available in most of the countries, taking into account the negative results we have had based on the HPS2 trial. Fibric acid derivatives, as well as icosapent ethyl, which is also used only in a few countries. So fenofibrate, omega-3 acid, and please consider using statins. What we can do, in fact, please have a look at the recommendation we have just published with hepatologists. This is probably the same issue. Hepatologists are also very much afraid of the statins. It was the issue for the last 10 to 15 years. Please have a look at not only those statins who are very much effective and they are not associated with the risk of side effects, but please have a look at the non-statin drugs. There is no joint points with the drugs used by hepatologists, but also by the oncologists with bempedoic acid, with ezetimibe, with alirocumab, so PCSK9 inhibitors, with inclisiran. So if you are afraid of using statin due to the different reasons, please always consider non-statin drugs in order to be effective with your patients. Because having your patients on the LDL cholesterol goal, you might reduce the risk of cardiovascular events by 60%. 60%. So this is the most effective way of prevention. That is why these are my last slides. If you would like to be effective, we should follow the guidelines we should use. First in the primary prevention, so upfront lipid-lowering combination therapy of statins and ezetimibe. If you are afraid of high doses of statins, please start with the low to moderate statin therapy plus ezetimibe within the fixed dose combination. If you are not effective, please consider PCSK9 inhibitors or bempedoic acid, depending on the countries, because, for example, in Poland, bempedoic acid is still not available. And for the patients already with atherosclerotic cardiovascular disease, please use triple or even quadruple lipid-lowering combination therapy, and in those with diabetes and metabolic disorders, or even those with statin intolerance, you may have very effective drugs that you may use and personalize your treatment in order to be effective. Thank you very much.
Maciej, thank you very much for this beautiful, interesting presentation. For me, that was, as usual, as a cavalry attack, but in a very interesting way. Do we have any questions to Professor Banach? Please.
So what about those patients with metastatic cancer? How do you feel about statin therapies in those? I mean, I think in the past, we were always worried about their length of life, but we're seeing now people living longer with chronic cancer. What about statins in that patient population?
It is obviously very interesting questions. We have always a kind of discussion, not only with oncologists, but also with palliative medicine specialists, whether we should deprescribe statin therapy, taking into account the quality of life of those patients, or whether we should try to continue. It obviously depends on the stage of the cancer disease, right? If it is still metastatic cancer, but it is, we predict the life, taking into account the years of PFS or OS, and that is why. And this is, and based on this, we obviously always consider to continue statin therapy or statin therapy plus non-statin drugs, because obviously if there are any side effects, we reduce the dose of statin and using only those low to moderate dose with other non-statin drugs. But in palliative medicine patients, taking into account the recommendation we have had and we've prepared, this is probably the only group of patients for which we may consider complete the prescription of statin therapy, taking into account the quality of life and very short life expectancy of those patients.
So thank you very much. Let me conclude this session. First of all, the Cardio-Oncology is developing specialty, I would say. For me, this session proves me necessity of cooperation. We have a lot of work, let's say, to be done for both sides. What I really realized preparing this presentation, that there is a real lack of oncologists in heart team, especially for the patient with comorbidities and with cancer problem. The implementation of oncologists to this heart team, for me, will facilitate and speed up the decision process, yes or not, and what kind of operation should be performed. For, let's say, in terms of oncologists, this is your choice. What do you need to improve yourself? How do you see our cooperation? I leave it to you. So thank you very much for all of the presenters. Thank you very much for keeping time and being with us for the whole session. Sebastian, thank you very much for organizing this session, and I hope this is just the first, and the next will come, of course. Thank you very much.
Thank you very much. I hope the time for lunch. Please be invited. Ladies and gentlemen, I would like to invite everyone to the room, and we can start the session number 4. And small change, Marianne Mirabel will chair this session instead of me, together with Susan Dent and Dimitrios Farmakis. Please go on.
Good afternoon, everyone, and thank you for joining us again back for the next session. So I'm going to introduce our first speaker, who's Dr. Aaron Swerdloff, who's from Newcastle, Australia. He has a virtual presentation. He may join us later for questions. We'll see. It's 11 o'clock at night there, so a little bit later there. He has a very extensive CV and involvement in cardio-oncology. He's been involved in a number of international cardio-oncology initiatives, and he's currently the co-director of the Newcastle Center of Excellence in Cardio-Oncology, working in Newcastle, and they also have a very strong basic science research program there. His topic today that he's going to talk to us about is cardio-oncology in Australia and their program. So let's hear his talk.
Hello, everyone, and thank you very much for the kind invitation to present at this fantastic forum. And I'll be talking about cardio-oncology in Australia. These are my disclosures. Just to begin with a little bit of information about Australia. We're a small country sort of down the bottom of the world, a bit bigger than all of Europe by land size, and tiny in population. So whilst the Europe is about 3/4 billion people in population, we have less than 30 million, and a third of them were not born in Australia, which poses its own, all of this poses its own unique challenges. You can recognize those from Poland. The central picture here just is iconic old town in Warsaw. This is probably one of the most iconic pictures of Australia's Ayers Rock. You can see the geographical difference. But now let's talk about the current topic. In Australia, we actually have one of the highest cancer rates in the world. And there are a number of reasons for it, including really good early detection and publicly funded screening programs for a number of cancers, including prostate, breast, bowel, and now lung cancer. And at the same time, our cancer survival is actually the highest in the world, currently at 1,850 people per 100,000, slightly ahead of New Zealand, a bit ahead of Ireland, and reasonably far ahead of the United States, which speaks to our health care system and universal health care, as well as, once again, accessibility of medications and health care. Now, I generally start by acknowledging that the reasons we're even here is because our oncology colleagues are doing such a fantastic job. These are some Australian figures. Essentially, our current 5-year survival for all cancers combined is about 72%. That excludes non-melanoma skin cancer, so truly malignant. And for some common cancers like breast cancer, we see that about 92% 5-year survival, and that includes metastatic stage 4. However, when we look at cardiovascular events, unfortunately on the left, this is data on 30,000 patients who were treated for cancer in the 1990s and followed up long-term. If they survived more than 5 years, by 10 years post-cancer survivorship, their predominant mode of death was cardiovascular. And if we look on the right, this is more recent data from our own health district, looking at our regional and rural population. Those who have been receiving chemotherapy treatment in those regional centers do a lot worse than all other patients combined who present to those centers. They have more readmissions for cardiac events, more all-cause cardiac readmissions, and worse outcomes overall. Why that is the case? Well, if we look at prescribing of potentially cardiotoxic anti-cancer medications in Australia from 2005 onwards, you can see there is a progressive rise, whether it's male, female, by age, and that's understandable. There are more and more cancer therapies available with time, more and more being recognized as cardiotoxic. To cut the long story short, about over 50% of our patients received at least one cardiotoxic therapy during their cancer journey. And these are medications not just with a single case report of cardiotoxicity, but are well known to be cardiotoxic. Now, what happens in the survivorship? This is once again our own data. And if we looked at consecutive cardiology inpatients admitted to our hospital. 25% of them had prior cancer, and those with a history of prior cancer were significantly less likely to receive cardioprotective therapies such as statins, ACE inhibitors, antiplatelet agents than their counterparts. And that's even adjusting for all other cardiovascular risk factors and the severity of their cardiovascular disease. They also had higher rates of cardiovascular disease. These were not palliative care patients. These patients had a mean time from their cancer diagnosis of 11 years. So predominantly they were cancer survivors being undertreated according to the prevailing guidelines for their cardiovascular risk factors. So not surprising that we're seeing these excess cardiovascular events that persist in the long run. So what are we doing about it? So at our Cardio-Oncology Center of Excellence in Newcastle, we were the first in Australia to get ICOS Gold Tier certification, and I'm very proud of my team's achievement. There are now 3 centers in Australia in blue stars on the map. All you can see on this east-southeast border. This is ours in Newcastle. There is one across 2 centers in Sydney and one in Melbourne and Victoria. Just to look at our center, that's on the right. We're located here in John Hunt, the Newcastle Martyr area. We serve a population of 1 million spread over the area of England. 130,000 square kilometers. We get patients from 27 regional and rural centers, frequently staffed by family physicians or nurses. Only 3 of them have specialists in those hospitals. So once again, certain challenges to delivery of care. Nevertheless, to put a plug for our program, we've been running for a little while. We've just been recertified for the next 3 years as Gold Tier Center of Excellence, and we run a comprehensive bed-to-bench side program. We have a strong discovery science arm looking at mechanisms of cardiotoxicity, cardioprotection, and dual-purpose drug development, clinical research focusing on novel biomarkers and risk stratification, specific program targeting our most disadvantaged Australian Indigenous peoples, Australian Aborigines and Torres Strait Islander people who have worse cancer and cardiovascular outcome, training, education, running conferences, webinars, fellowships, and being a testbed for implementation and piloting various models of care to improve cardiac outcomes for our cancer patients. Just a little bit of our clinic data. We looked at the first 250 patients coming through our clinic in the first 3 years. We've now been running for 8. And you can see on the left, pretty wide spread of cancers, as not surprisingly, lung, breast, and lymphoma are the commonest ones. On the right, you can see pretty typical Western population, multimorbid, higher rates of hypertension, dyslipidemia, reasonably high rates of previous cardiovascular disease. And those patients who were referred to our clinic for cardiovascular management of their cardiovascular complications of pre-existing disease, less than 9% of them needed to delay or interrupt or discontinue their cancer therapy. That's compared to 30 to 35% historically. So our clinics do make a difference, similar and consistent with what has been shown from absolutely fantastic center run by Alex Lyon in London and published earlier this year. We're getting similar rates. So what I tell my oncology colleagues is that really for most patients with non-severe cardiotoxicity, we can get them through without interrupting or discontinuing their therapy. And since that time, our clinic is just getting bigger. We've now had 4,500 patient visits, and you can see there is a steady growth at around about 20% per annum, and 2025 data is at 6 months. So we expect that there will be about a 25% growth this year as well. In addition, we have a nurse-led cardio-oncology clinic that has seen over 200 patients for risk stratification predominantly. These are the patients. You can see there very high rates of dyslipidemia, hypertension, diabetes, not well controlled at all with total cholesterol and LDL well above a recommended range. So 70% of them were undertreated when they went to the clinic, and we achieved 80 to 92% guideline-directed outcomes for those patients. And our star nurse, Trent Williams, received Nurse of the Year 2023 in New South Wales in Australia for that work. This is in parallel with development patient-oriented resources that target the appropriate health literacy of our patients, including culturally sensitive ones. For Australia's first people, we've developed those, and we have very high rates of patient satisfaction. To help our patients, we ran the first in Australia Cardio-Oncology Q&A event for patients and their carers that was oversubscribed. We couldn't fit all the people in. Well over 100 people attended, with a significant number additionally online, and we were very proud to receive the recognition for this from our government, all to help build the bridges to better cardiovascular care. Now, I would like to change tack here a little bit and talk about some of the research that has recently been completed and published from Australia, and also some studies that are currently being run. To start off with SUCO MRI trial, where we showed that in anthracycline-treated patients who developed worsening of GLS only, without a drop in ejection fraction, starting those people on ACE inhibitors and beta blockers reduces their 12 months incidence of left ventricular dysfunction or deterioration of their left ventricular function as measured by cardiac MRI. So this results support GLS-guided cardioprotective therapies to prevent LV functional decline. Small study, but very reassuring and very promising. Another important one was ELA Active trial from Aaron Howden's group that showed that a tailored multi-component activity program with aerobic resistance training and reduction in sedentary time during hospitalization for allogenic stem cell transplantation and continued for 12 weeks post-discharge improved exercise cardiac function compared to usual care. So they've done VO2 max measurements, cardiac output from exercise training, and that showed improvement. In the absence of improvement in conventional imaging, such as echocardiography and cardiovascular biomarkers, suggesting that exercise capacity training is a useful measure to improve cardiac functional reserve. Has very important implications, as obviously exercise training has benefits far beyond cardiovascular. Now on to some currently running trials. CORP-RCT is a multi-center RCT testing supervised cessation versus continuation of cardioprotective therapy with ACE inhibitors and beta blockers in low-risk cancer survivors who recovered after asymptomatic CTRCD engendered by anthracyclines and HER2 therapies. The endpoint is a 6 months ejection fraction measured by CMR. We hope that this study will provide us with an answer of when is it safe to discontinue cardioprotective therapies. On the other hand, REDEEM-CAD study will guide a pragmatic, risk-guided pathway for coronary artery disease screening in cancer survivors, especially those at the intermediate risk. Looking coronary artery calcium scoring as a guide to lipid therapy and further follow-up. Next couple, Socrates trial, a little bit similar, but this looks at a pragmatic study of patients treated with immune checkpoint inhibitors for melanoma, including melanoma survivors, looking at baseline and follow-up CT coronary angiography in patients stratified to or not stratified to statin therapy. The primary outcome is looking at non-calcified plaque volume, with secondary outcomes looking at cardiovascular events, total plaque volume. And on On the right, finally, our Impact CVD in Cancer trial, which looks at the implementation of nurse-led cardiovascular risk stratification clinic based on automated calculation of baseline HFA ICOS risk score, and then stratifying patients into those with high and very high risk to attend the clinic, whilst those who at low and moderate risk will not attend the clinic and will be subject to usual follow-up. There's a pre-intervention cohort, and we will compare the impact of this clinic on cardiovascular management as well as need for cancer therapy interruptions. And finally, I would like to give a plug for our latest publication, our basic science program, where we looked at this fairly novel and at face value strange concept that if you understand the mechanisms, you can find a combination of anti-cancer agents that will have dual anti-cancer mutually cardioprotective effects. We've looked specifically at olaparib, the PARP inhibitor used in ovarian cancer, and its effect in doxorubicin-induced cardiotoxicity. We know doxorubicin does cause PARP1 overactivation, which leads to cardiotoxicity, whilst PARP inhibitors can be protective in this sense. This is the work of Kelly Chen from our group, who was just awarded her PhD for this work. And what we did show that indeed olaparib co-treatment with doxorubicin at a cell level prevented human cardiomyocyte death engendered by doxorubicin. There was improvement in cardiac function in animals treated with doxorubicin that were co-administered olaparib. There was preservation of cardiac function. There were improvement in innate immunity pathways, which we think are responsible for this. And this really provides proof of concept work that cardioprotection can be achieved not just by adding more cardiovascular drugs, but finding combination anti-cancer agents that can be mutually cardioprotective. And that might be the new era in dual purpose therapy. Finally, we've recently published a number of call to arms and framework papers to help guide cardio-oncology development in Australia. And to finish off with, I would like to give a shout out to our inaugural Australian Cardio-Oncology Research and Education Symposia that we're planning to hold in March next year. And with that, I would like to thank the organizers and happy to answer any questions.
Thank you. Are you online, Aaron? I don't.
Yes.
Oh, there you are. Hi, it's Susan. Thank you for that great lecture. One question I wanted to ask you is, you mentioned you've done a lot in a very short period of time, so congratulations. You mentioned one of the challenges was COVID, but beyond COVID, maybe you could let the audience here know what was the other challenge or the biggest challenge in implementing your program in Australia?
Thank you very much. Thanks for the question, but also thank you for inviting me to present. So look, as I mentioned before, some of our challenges is that in Australia, cardio-oncology is quite young. So we started probably about 10 years behind US. So it still wasn't as well recognized. Only in the last really 4 years or so that our professional societies have taken an interest, and so have our Heart Foundation. Prior to that, because if your professional societies are not legally interested, it's very hard to get things up and running. And the other challenge that's probably a bit more unique to Australia is our geography. So as I pointed out, we have a very small population spread over an enormous area, and that makes it hard to implement. Patients have to travel. Even having cardio-oncology networks, it's not an easy half-an-hour drive across town. So I've just came back from doing a clinic. It's a 7-hour round trip in one of our regional cancer centers. So things like that is a challenge. It's a financial challenge implementing something that far away, especially for patients. It's, they have to travel. There are limited resources. These have been probably the two biggest challenges: geography and the fact that in Australia, we're starting a bit late to the game.
Well, despite those challenges, and as you allude to the geography, same issues too in Canada, by the way, but you've done an amazing job. So I think we do have to move on, but thank you very much for joining us, especially for you. It's 11 o'clock, I believe, there.
Yes, yeah.
Okay, thank you, and thank you for joining us today.
Thank you so much. Thank you. Thanks, Susan.
So now it's my great pleasure to present the next speaker, who is Mariana Mirabel. She comes from Paris, France. She's a lead expert in the field of cardio-oncology in France, where she established actually the first cardio-oncology service in Paris, but also internationally. She's a member of the board of the ESC Council of Cardio-Oncology and also a communication officer. So Mariana will talk about new drugs in France.
Thank you very much, Dimitris, for your very kind introduction. So for me, it's a great pleasure to be here, and really very grateful to Sebastian for organizing all this in a so short span time. So I work in Paris. I'm a cardiologist by training, and I have been doing cardio-oncology for now over 10 years. And I provide services, cardiovascular services, for the Institut Curie, which was founded by Marie Curie, who, when she had her first Nobel Prize, founded the Institut Curie, then came to Warsaw, founded this one, then widowed and had a second Nobel Prize because some people thought it was just her husband's biting. So basically, it is a pleasure for me to be here for historical reasons, and emotionally, this is my family hometown, 2 generations back, and so I'm very, very glad to be here today. So I have no conflict of interest related to this talk. And so I'm going to just give a brief overview of what cancer drug development is about. Oncology is probably the specialty where the industry has actually worked the hardest over the past 20 years. Here on the right, you have the drugs that have been approved for cancer treatment in the United States of America from 2009 to 2020. And 2009, it was 8 drugs per year. And 5 years ago, it was nearly 60. And this isn't stopping at all. On the lower curve, you can see the new mechanisms of action. So it's not only, drugs within the same class drug that is already known with small differences. These are groundbreaking changes. And you can see the 2011 year, which for me was groundbreaking year because I had my first child, but actually for cancer patients, it was a big change because immune checkpoint inhibitors were released in the market, and that considerably changed initially the prognosis for metastatic melanoma patients, then subsequently for lung cancer patients, and now it's given in a very wide range of solid tumors, in hematology patients, including in patients with non-metastatic disease. And on the left, you can see the benefits for the industry in the field. So basically, within 2 years, the industry reimburses their own investment, and there is a lot of benefits. It's counted in thousands of millions and billions, and this is not stopping either. So this is data from the European market, in which the prices are a bit more regulated than in other markets. So you can imagine how it is worldwide. So basically, this is a very profitable thing for patients, but it is also for the industry. So that's one of the reasons why this is not going to change, and there are going to be big changes to come over the coming 5, 10, 15 years as well. And so that's why we need updated, original information on a regular basis. We have different sources of information when we have new drugs coming into the market. The one that was within the trials, but as if you know, in trials, patients who are selected for the trials are perhaps not real-world real practice patients. They're younger, they have less comorbidities, and usually the trials are made to assess mainly the efficacy of a drug, not necessarily the safety of a drug, and the definitions of safety change, on the case definitions change. So basically, we really need independent data. And this is a very nice work from a French group based in Normandy, in Caen, the group that has been founded by Joachim Alexandre, who now leads the French Society of Cardiology, Cardio-Oncology working group. And they looked at the WHO pharmacovigilance database, and after having a look at over 36 million reports, they identified 42,000 cancer therapy-related cardiac dysfunction reports, and they had a look at the different drugs. And you can see here, the red ones are the ones that have the highest, let's say, incidence in some way. And it's still target therapies like trastuzumab has been on the market for nearly 20 years now, and other classic, not that new therapies that may be combined with chemotherapies. And they show that thalidomide, chloramfamide, and ponatinib, which are target therapies for the last one, have the highest odds ratio of developing cancer therapy-related cardiac dysfunction. This is quite new data, and we know that anthracycline cardiotoxicity is mainly related to the doses, and our colleagues in hematology and in cancer, solid cancers, have significantly reduced the doses that the patients receive nowadays. So we really need this updated pharmacovigilance data in order to really keep in pace with the changes in the oncology field. Of course, this has already been discussed earlier today, risk stratification. The Heart Failure Association and International Cardio-Oncology Society score has been validated after its first publication in a wide range of cancer drug classes, including anthracyclines, target therapies like HR2, VEGF inhibitors, proteasome inhibitors, RAF/MEK inhibitors, and hormone therapies. And these have been subsequently validated in independent cohorts. So basically, the fact that we have new drugs, and these new drugs are combined in a single patient. Usually patients now receive neoadjuvant that might include chemotherapy, target therapies, immune therapies. We really need, given the complexities of cardiotoxicities that may not be reduced only to cancer therapy-related cardiac dysfunction. It can be atherosclerosis-driven disease, can be arrhythmias, it can be myocarditis. But just to address cancer therapy-related cardiac dysfunction, of course, cornerstone is the use of echocardiogram, but it's not the only biomarker that we're going to use when we have poor acoustic windows, or we're not quite sure of the left ventricular ejection fraction. We may require cardiac magnetic resonance imaging. In a patient with intermediate or high risk of coronary artery disease, we need to rule out coronary artery disease, and we do use a lot of CT scanners. And of course, we need, for prognosis, also CMR or troponin levels. So basically, when we're diagnosing cancer therapy-related cardiac dysfunction, it's just not one echo and that's it. We may use an ECG to detect it, augmented by AI. We may use troponin assays to detect it. We need an echo, but sometimes we need a CMR, and sometimes we need a CT scan too. So basically, the complexities of our population has to face a complexity of the cardiovascular care and the diagnostic workout we're offering our patients nowadays. When we go to arrhythmias, this is another work based also on VG-base, which is the WHO pharmacovigilance database. And this work has been published by Joëline Salem in Paris, and he showed which drugs were associated with long QT syndromes, which were associated with long QT syndromes and symptoms. And you can see that there's a wide variety of therapies. Some of them are not that new, but But for the general cardiologist, they are new. When I trained in cardiologist, these drugs, most of them, didn't exist. So it really depends, as my kids say, what is new to you. And for instance, ribociclib, crizotinib, all these are drugs that are not necessarily well known by the general cardiologists. So we really need to enhance education just to make sure that our patients get an ECG, especially when they're receiving target therapies, just to make sure that they don't have underlying long QT syndromes and that their QT doesn't lengthen. So to go back to what Sebastian asked me to talk about, which is my daily practice. Well, my daily practice is quite wide because these patients are very heterogeneous. I care for 20-year-old sarcoma patients, but also 85-year-old prostate cancer patients. And in the middle, well, the 4,000 new breast cancer patients are taken care of by Curie Institute in Paris. So it's a lot, and they're very different because of very different underlying cardiovascular risk factors and the various therapies they're going to receive. But in spite of all my educational efforts, my daily practice is still like this. 60-year-old gentleman who's treated for metastatic hepatocarcinoma. He's hypertensive, past smoker. He receives urgently a second-line therapy by cabozantinib, which is a tyrosine kinase inhibitor that targets VEGF. And on the third day after starting, well, he calls the ambulance because he feels unwell. He can't breathe. He's got very high blood pressure, gets to the intensive care unit. His lung X-ray looks like this. And indeed, things did resolve because the intensive care unit was very fast. He did have LV dysfunction when he had very high blood pressure, and this patient certainly could have benefited from a cardiovascular assessment before starting therapy because he had high blood pressure. No one looked at his blood pressure before starting cabozantinib. No one looked at the fact that he was receiving a channel blocker that increases the biodisponibility of cabozantinib. So this is just across my practice. These are my colleagues that just across, because we still need to educate not only the patient, but especially our colleagues in cardiology, general cardiology, and in oncology and hematology. Indeed, cancer therapies, target cancer therapies have been around for a while now. This is a very nice review by Professor Moslehi in the United States, where he depicted the various mechanisms of target therapies given either intravenously or orally. And when you have a look at VEGF inhibitors, they all are responsible for increase in the blood pressure, including in normal controls. If you get a VEGF inhibitor, your blood pressure will increase. And it will increase even more in patients who already have underlying high pressure. So really, sometimes it's not about big data, it's just about caring for the patient, educating the patient, and making sure that our colleagues have the right pathway, or at least that they have been educated in order to, for instance, treat high blood pressure before starting this kind of therapies. So a more novel cancer drug in the market, he's been there for now over 10 years, 2011, immune checkpoint inhibitors. And this is a very nice work that has been published by Joëlie Salem in Paris, France, showing the incidence of myocarditis, but also peripheral myotoxicity, myasthenia on ICI inhibitors. On 170,000 patients have been treated for a period of 10 years. All the patients who had been admitted to hospital for myocarditis, myasthenia, myositis, we had this data in a very large national database, and what has been identified as factors associated with cardiomyotoxicity is the fact of having underlying immune disease. So basically, it's not necessarily the fact of having smoked or having reduced ejection fraction, et cetera, et cetera. It's not the classic cardiovascular risk factors. It's more about having an underlying autoimmune disorder, either thymic, thymoma, but also thyroid or rheumatoid arthritis. So this is something that opens a bit our minds about what questions we need to ask our patients when they're starting ICI therapies, not only focusing on the heart and on the vessels. This is ICI therapies not only are responsible for myocarditis or cardiomyotoxicities. This very nice work, which was retrospective by Tom Nealon's group in the United States of America, showed that patients who received ICI after adjusting for all the other potential confounders, which are cardiovascular risk factors, had higher rates of atherosclerosis-driven disease, that is STEMIs, stroke, need for angioplasty. And indeed, there is currently more and more data about the relationship between atherosclerosis, vasculitis, and the adverse events that are due to the endothelium and to the vessels. So that is acute coronary syndromes and stroke mainly. This is our, so Sebastian asked me to talk about our experience. So basically we see a lot of patients who are referred for high troponin levels on ICIs. And the question is, what do we do with them? Most of them are asymptomatic, and this is a prospective single-center study with 175 patients that had been referred over an 18-month period. And basically, we couldn't admit everybody, so we did a sort of pragmatic approach, no symptoms, no ECG changes, mild troponin level. Then we see them as outpatients. We did a sort of systematic workout with echo, repeat biomarkers, repeat ECG, CMR, sometimes biopsies, and actually what we found is that we had no cardiovascular death at 30 days. It was pretty safe to treat them as outpatients, so basically we didn't have this sort of traffic jam at the entry of our cardiovascular department, and the factors that were associated with cardiovascular immune-related adverse events were history of cardiovascular disease and low global longitudinal strain on echo. And what was associated with ICI myocarditis was extracardiac toxicities, ICI plus something else, ECG abnormalities, and low strain. It is very tricky to diagnose ICI myocarditis. It's easy when the patients are severe. When a patient comes to you, to the ICU with a severe phenotype, it's complex for the patient because her or his outcomes are poorer, but for the doctor it's easier. The thing is tricky when the patients have no or little symptoms. And here you have an MRI from one of our female patients, 35-year-old, treated for non-metastatic breast cancer with pembrolizumab and anthracyclines. And you can see here very nicely that she had extensive myocarditis. She did have a biopsy because we thought she wasn't well enough at the beginning to get an MRI, and she only had 17 T cells per square millimeter. And on the other side, you have a normal MRI in a 70-year-old lady with metastatic lung cancer, and she had over 50 T cells. So the correlation between the histology and the MRI is still very tricky and needs further work. So what happens when we see these patients first, when they're referred for suspected cardiovascular immune-related adverse events? Well, this is our own data on this 175 patients. Basically, they mainly present with cancer death. Okay, so cancer is the disease they have. We're not going to stop ICI therapy because we're suspecting cardiovascular immune-related adverse event that is not severe. And we did re-challenge this population, half this population, the suspected cardiovascular immune-related adverse events was re-challenged, and basically none of our patients died from cardiovascular disease within the first 6 months, okay? And the fact of re-challenging improved their overall survival. So please do not stop ICIs when you have mild troponin rise and perhaps some mild imaging abnormalities, especially if your patients are having very complex therapy regimens. Should we be testing them all? Well, really, we really don't know whether we should be testing troponin. It's been released in the guidelines, but the level of evidence in that is very low. And we looked at 850 patients. We did a propensity score matching. And actually, patients who have troponin surveillance die less, but basically, they're very different from the ones who do not have this troponin surveillance. So just to finish, cancer therapies evolve constantly. Novelty does not imply less toxicity. To me, it implies more complexity. We need multimodal cardiovascular biomarkers in order to address the multimodal therapies. We really need to work together, and I think by this we may learn more and improve the care for our patients. And if you want to know more, please do come to Vienna. Next year is going to be the second edition of the ESC Cardio-Oncology Conference in Vienna. Thank you very much.
Thank you, Mariana, for this excellent presentation. Any burning questions from the floor? No. May I ask you, now with the immune checkpoint inhibitors and immunotherapies, the field is changing. We see strange things like typical cardiovascular risk factors do not predict the risk of cardiotoxicity in terms at least the myotoxicity, myositis or myocarditis. Then we have challenging issues regarding, as you showed us, the diagnosis with non-concordant biopsies with imaging studies. And we all have a big number of patients running around with a rise in troponin and troponinitis. And we're not very sure how to interpret this. So does this change the whole story of cardiotoxicity and so on?
Yes, indeed. I think like in every disease, it's actually you have shadows of gray. Not all the patients are extremely severe, need abatacept, ruxolitinib, or a bolus of steroids. And as in every disease, you have a pattern. We presented in Florence our data on 50 consecutive endomyocardial biopsies, and it does correlate with the troponin rise. But we found a lot of borderline disease with which we don't really know what to do, and we re-challenged a lot of them when we thought it was really worth it from an oncology perspective, and the patients are doing pretty well so far. So this is work in progress. I think we cannot only focus on data from tertiary, quaternary centers to which only patients who need an ECMO are referred to, because real life is something else.
Thank you very much. Any questions? No? If not, thank you.
Okay, so it is a great pleasure to invite Professor Dimitrios Farmakis from Athens in Greece, and who's going to talk about arrhythmias.
Thank you once again, Mariana. Dzień dobry, dziękuję bardzo. This is the only thing I know in Polish for the moment, but I'm still here for less than 24 hours. So thank you very much. A big thank you to Sebastian, my very good friend, for the kind invitation. Congratulations for this very high-level meeting that we all enjoy since early in the morning. So thank you very much for having me here. Arrhythmias in cancer, as with actually every form of cardiovascular disease that we encounter in patients with cancer, this comes from the interaction among three factors. First, anti-cancer therapy that may provoke arrhythmias. There are directly arrhythmogenic drugs in oncology, like those prolonging QT, but also indirect arrhythmias, like when a drug causes, for example, myocarditis or heart failure. This may also lead to arrhythmia. So either directly or indirectly causing arrhythmias. Then we have the cancer that may actually affect the cardiovascular system, again, either directly by invading the cardiovascular structures or indirectly through systemic inflammation, sympathetic nervous system activation, and so on. And this may also lead to arrhythmias. And then the patient, of course, with the background of cardiovascular disease, constellation of cardiovascular risk factors, and so on, that may be or not be prone to arrhythmias development during and after the cancer therapy. So we have to consider the interaction among these three factors. Then we have all types of arrhythmias in patients with cancer. We have, of course, QT prolongation. This is a very known one. We have bradycardias. We have tachycardias, tachyarrhythmias, atrial fibrillation, everything. We can have everything in patients with cancer. And I will focus on three distinct types of arrhythmias that we encounter frequently in patients with cancer, including QT prolongation, bradycardias, and atrial fibrillation. With QT prolongation, we know that some of the anti-cancer agents, or many of the anti-cancer agents, tackle with these ion channels in the cardiomyocytes, prolonging repolarization and prolonging the QT interval, and different agents are interfering with different ion channels, so they have a different QT prolonging property. For example, arsenic trioxide may cause a significant prolongation, while nilotinib not so much. And I will come back to this study presented earlier by Mariana from the Wikibase, from the WHO Wikibase, showing that approximately 40 drugs are associated with a long QT, and some of them are also associated with arrhythmias, and most of them actually belong to the kinase inhibitors class, and there are also some with cytotoxic, associated with cytotoxic agents, and less with other drug classes. So many drugs prolong QT, but most of them do not cause a significant or clinically very, very severe QT prolongation, leading to ventricular arrhythmias and torsade de pointes and risk of sudden death. These are the agents, according to the ESC guidelines that we published 3 years ago, associated with the highest risk of QT prolongation. You can see the list here. But what we need to consider also is other QT prolonging factors, actually, that may also be correctable, like other QT prolonging agents that patients with cancer may receive, like antibiotics, antiarrhythmics, antiemetics, and so on. The very common electrolyte disturbances that we have in patients with cancer, with vomiting, with diarrheas, and so on, and also bronchiarrhythmias that may also come from the cancer therapies. Then let's move to atrial fibrillation. This is a topic that has been in fashion for some time now. There are different conditions and factors leading from cancer to atrial fibrillation, but we're talking for patients that they have a common denominator of aging and many comorbidities that promote both cancer and both atrial fibrillation. And lately there has been some considerations that there may be a reciprocal association between cancer and atrial fibrillation, cancer and anti-cancer therapy causing atrial fibrillation, but also atrial fibrillation increasing the risk of cancer. Of course, this is mostly attributed to the fact that atrial fibrillation leads to a decoagulation therapy, and decoagulation therapy actually reveals an underlying lenient cancer that would be revealed anyway later on. But still, there is some research in this field of reciprocal association between cancer and heart disease in general, including atrial fibrillation. What the cancer drugs are associated with atrial fibrillation? At least 19 drugs are, according again to WHO Wikibase analysis, are associated with atrial fibrillation, and most of them actually concern hematological malignancies. The most known one is the Bruton kinase inhibitor ibrutinib, associated with atrial fibrillation. Now, regarding bradyarrhythmias, now we have three main drug classes that are associated with bradyarrhythmias. Of course, immune checkpoint inhibitors that may come with every form of arrhythmia, including conduction disturbances and interventricular conduction disturbances, leading to sometimes to bradyarrhythmias. Then we have the ALK inhibitors used in lung cancer, also associated with bradyarrhythmias, along with other complications such as heart failure or QT prolongation, and then immunomodulating agents such as thalidomide, also associated with bradyarrhythmias. Regarding ICI toxicity, of course, we talked about the myotoxicity in forms of myositis, myocarditis, the overlapping syndrome, and so on, but also arrhythmias are very common in this class of agents, either in the form of tachycardia or tachyarrhythmias, or in the form of conduction disturbances and bradycardia. And this is a typical evolution of a case of ICI myocarditis in a patient with lung cancer treated with a combination of ipilimumab and nivolumab. So two ICIs, starting with a normal ECG in the top, then within 2 weeks with a first-degree AV block, interventricular conduction abnormalities with RBBB, and then proceeding some days later to complete AV block with a drop in left ventricular ejection fraction, left bundle branch blocks, and so on. So how do we approach arrhythmias in patients with cancer? Well, it's the whole story about cardio-oncology, covering the whole trajectory of cancer, starting with cancer diagnosis, then continuing to the active phase of anti-cancer therapy, and then to long-term cancer survivors follow-up. And the same applies also for cardiac arrhythmias. At baseline, we need the baseline risk certification that also includes ECG, and also we have to consider arrhythmias and prolonged QT, particularly if we're talking about patients that are going to receive QT prolonging agents. So the screening for arrhythmias, at least with an ECG, is part of our baseline risk stratification models. And then we have the prevention, some preventive measures, the management of the optimal management of pre-existing cardiovascular disease, and also an effort to minimize the potential cardiotoxic effects, like with a QT prolonging agent in a patient who has already a QT prolongation. Then monitoring for arrhythmias in patients with an increased risk of toxicity, including arrhythmias. This is the case of BCR-ABL TKIs used for chronic myeloid leukemia, and this is the case also for immune checkpoint inhibitors. So different monitoring schemes according to baseline risk and according to the drugs that the patient are receiving. Then when arrhythmias develop, then we just follow the guideline recommendations as in non-cancer patients, with some special considerations, mainly regarding the drug-to-drug interactions that we may consider, or the prognosis of cancer. For example, a patient with atrial fibrillation, maybe a rate control strategy is preferable over rhythm control in an end-stage cancer patient, or we need to avoid, for example, the TSM or verapamil, which have a lot of interactions with many cancer therapies. And also another thing that we need to consider, of course, in close collaboration with oncologists, with hematologists, is what to do with anti-cancer therapy, whether we need to continue, hold at least for some time, or terminate permanently. This is the algorithm in the guidelines for the QT prolongation. Of course, when torsade de pointes or ventricular arrhythmias develop, or when there is a significant prolongation of the QTc with a fiduciary formula above 500 milliseconds, then we have to stop the drug and look for alternative agents. But we also need to consider other QT prolonging conditions and drugs. Then what about the management of atrial fibrillation? Well, we do it as in non-cancer patients, but the challenging thing here is anticoagulation therapy, of course. And our host here, Sebastian, is leading now a paper, a position statement within our ESC Council of Cardio-Oncology on anticoagulation therapy. There are challenges in anticoagulation resulting from the fact that cancer may be a prothrombotic state by itself and at the same time a bleeding tendency state. So we have to somehow consider both risks of thrombosis and bleeding that are increased in cancer patients. The traditional risk models, although also validated in cancer patients nowadays, are not very well constructed in a manner that to consider also cancer patients. And of course, we need to consider drug-to-drug interactions. And a few time ago, we came up with this acronym with the DBIP, showing the things that we need to consider when we need to start the coagulation therapy, either for atrial fibrillation or for venous thromboembolism, for T studying for the risk of thrombosis, B for the risk of bleeding, I for the interaction, and patient P for the patient preferences. And we need to reconsider this periodically because things may change in the course of cancer. The bleeding risk may increase, for example, because of a thrombocytopenia that develops during the course of anti-cancer therapy, and so on. So it is not enough to have just a baseline evaluation, but we need to reevaluate our strategies and again, at least in patients with active cancer, because the others, we treat them as in non-cancer patients. And this is the algorithm for the guidelines for the coagulation or for atrial fibrillation in patients with active, cancer, with the DBIP acronym. And then there may be patients with a very high bleeding risk in whom we do not want to start anticoagulant, at least for the moment, until we reevaluate the patient again as patients with active, very recent bleeding, a low platelet count below 25,000, with an involving intracranial lesions and so on, and then conditions that may actually favor low molecular weight at least for some time during the active phase of cancer. And then we can also go to the DOAC, of course, which is our mainstay of therapy now, such as some intraluminal tumors that may be more prone to bleed, a platelet count between 25 and 50,000, some drug-to-drug interactions with DOAC and so on. For the rest of the patients, of course, and outside the active phase, we treat the patients with DOAC as in non-cancer patients. And last but not least, the long-term follow-up that we need to apply to all cancer patients. That also includes the screening for arrhythmias. And I will stop my presentation here. I would like to remind you our resources, educational resources in the context of the ESC Council of Cardiology. We have already launched in the summer the Level 1 education and certification program with online learning, and also the first certification exam that will take place at the beginning of December this year. Of course, our dedicated ESC Cardio-Oncology conference, the first one was held in June in Florence, and the next one is scheduled for next June 2026 in Vienna, and you're all invited there. And I also invite you all to be a member of the ESC Council of Cardio-Oncology. It's completely free of charge, and you can scan the QR code here. Thank you very much for watching. I hope this is correct.
So thank you very much, Dimitros. Basically, based on your personal experience, what is the most common arrhythmia you face in your daily practice?
Of course, the most common arrhythmia is sinus tachycardia, as we all know. This is very common also in patients with cancer, be related either to cancer, pain, dyspnea, and so on, or to cancer therapy like anemia and so on. This is the most common one, but we're not very worried about it. I think that a challenging arrhythmia is actually atrial fibrillation because we need to diagnose it, we need to detect it, and it's simple to detect actually atrial fibrillation with just pulse taking. And we need also to consider what is the type of anticoagulation therapy that we're going to prescribe. This is challenging, that's why there are guidelines, there are specific algorithms, there is a paper on anticoagulation now going on and so on.
So quick follow-up to that question. Are we doing a good job at treating atrial fibrillation in cancer patients?
No, actually we do not. First of all, because we do not detect it properly. So there are cancer patients that come to the cardio-oncology clinic with active atrial fibrillation on the ECG, and they have not been diagnosed. Perhaps this was not there at the time that the patient went to the oncologist, but maybe it was there. So first, the detection, and second, of course, is the anticoagulation, which is actually very challenging in these patients, in some of these patients.
So then more really cause to do a baseline ECG for our patients, a simple test that really could, help maybe pick up this entity, right? I mean, I'm not saying it could develop while they're on therapy, but...
Well, now there are so many modalities to diagnose AF. Actually, there are the clever watches, the phones. There are so many modalities now that we can use to detect atrial fibrillation. It's not that difficult anymore. And actually, with cardiac auscultation, you can detect it.
If I may add, this is a very complex decision because we might, of course, increase the surveillance for atrial fibrillation, even with using devices and so forth. But then the management issues, as Dimitrios alluded to, would be enormous. And in the general population, there's great uncertainty whether the opportunistic screening of atrial fibrillation is cost-effective. I really cannot imagine whether it could be in cancer patients or not. So it's a really complex perspective. And
yeah, this is, of course, is the discussion nowadays. It's a very, very in fashion, but at the same time, the patient with cancer is not the common population. It's not the general population. There are patients with cancer that have an increased risk to get atrial fibrillation, actually, at least some of them. So we're not talking about the general population. We're talking about the specific population at increased risk of atrial fibrillation arrhythmias.
Okay, thank you. I know it's a complex question, but we have to move on, but thank you for that talk. So our last speaker for this session is Dr. Pietro Ameri from Genova, Italy, who is not only a cardiologist, but runs the basic translational research program there. And I think we're going to end this session by talking about basic science in cardio-oncology. We've heard a little bit about it throughout today, but let's focus on that for the next 15 to 20 minutes.
Yeah, me too. When I read the title, I thought that everyone will fall asleep before I start speaking. And in addition, I don't even dare say a single word in Polish, which, again, makes the things more complex. Thank you, Sebastian, for the invitation. It's really nice to be here. And I must say that I'm really grateful to see that basic science is part of the program. These are my conflicts of interest, not related to this talk. And I'm grateful because cardio-oncology has historically been at the intersection between clinical and preclinical science with a continuous exchange of information from one side to the other one, eventually advancing knowledge and informing clinical practice. Now, basic science, well, the field of cardio-oncology to which basic science has mostly contributed so far is for sure the study of cancer treatment-related cardiovascular toxicity. First of all, and most straightforward, by elucidating the mechanism by which cancer treatments are cardiotoxic. There are plenty of good examples in this regard. I'll just cite this study, a very, very elegant study made by a group of investigators, where they first observed that continuous treatment with ibrutinib caused atrial fibrillation in a mouse model. This is not surprising. It recapitulates what we see in patients. But quite surprisingly, the same happened when mice with a non-functional Bruton tyrosine kinase were treated with the drug, suggesting that the induction of atrial fibrillation did not require the presence of a functional Bruton tyrosine kinase, the target of ibrutinib. So the investigators moved on and doing a very complex chemoproteomic profiling, where basically study one by one the possible kinases targeted by ibrutinib, and in comparison they also assessed the kinases targeted by acalabrutinib, another Bruton tyrosine kinase inhibitor, which is associated with a much lower incidence of atrial fibrillation. And they were able to find that these kinase pointed out here, CSK, was selectively inhibited by ibrutinib and not by acalabrutinib, and was indeed expressed in the rat, in the mouse and human heart. So they moved on. They demonstrated that cardiac-specific deletion of SCK was sufficient to induce atrial fibrillation, and so they made a syllogism. Ibrutinib inhibits CSK. Inhibition of CSK is sufficient to cause atrial fibrillation. Therefore, this is the real target by which ibrutinib causes atrial fibrillation. And this explains why ibrutinib and none of the other Bruton tyrosine kinase inhibitors is so potent in causing atrial fibrillation. And confirm this in the pharmacovigilance EMA database that has already been mentioned. They found that drugs, different types of tyrosine kinase inhibitors with an activity on CSK were much more frequently associated with atrial fibrillation as compared with tyrosine kinase inhibitors without activity on this kinase. Now, in clinical practice, we all know that administration of a certain cancer treatment will not invariably result in cardiovascular toxicity. We know that there are other factors influencing the risk of cardiovascular toxicity. In fact, we try to estimate the influence of these risk factors by applying the HFA, ICOS, and other stratification tools. So the first factors we all take into account is the presence of other treatments. And in this regard, it was a very elegant the demonstration of the contemporaneous toxicity of anthracyclines and HER2 targeting agents. So shortly after trastuzumab was tested in clinical trials, it was seen that there was an unexpected high incidence of left ventricular dysfunction and heart failure. And this led to the generation of mice with the deletion of the gene encoding this receptor, HER2, specifically in the heart. These mice are viable, but they develop massive hyperdilation when subjected to stresses like transverse aortic constriction, which is the experimental correlate of aortic stenosis. And they are also very sensitive to the toxic effects of doxorubicin. You see here that mice with the deletion of the gene encoding HER2 die much more, the black dots, as compared with the mice without the deletion when treated with doxorubicin. And as you all know, this eventually led to understanding that trastuzumab not only inhibits HER2 in cancer cells, but also inhibits these receptors in cardiomyocytes. And in cardiomyocytes, HER2 exerts a number of protective actions after being engaged by neuroreguling, a ligand secreted by cardiac stromal cells. So when a patient receives a drug inhibiting HER2, like trastuzumab, the protective effect of HER2 is lost, and the toxicity of anthracycline is amplified. Moving on, we also know that many cardiovascular risk factors and cardiovascular disease compound the susceptibility to cancer treatment-related cardiovascular toxicity. And again, basic science has provided important answers to the question of how risk factors or cardiovascular disease predispose to cancer treatment-related cardiovascular toxicity. I would say that we do have more mechanistic explanation than what it is commonly believed. Simple example, well, simple, looks simple. Sunitinib, another tyrosine kinase inhibitor, causes the death of cardiac microtissues made of red cardiac cells. You see here that the number of dying cells, as demonstrated by positive activation of caspase, increases when the cells are treated with sunitinib. This is the positive control. The effect is dose-dependent, and it's associated with a decrease in the capability of cardiac cells to beat in cultures and to generate systolic and diastolic forces. Nothing surprising, however. What is remarkable is that these detrimental effects of sunitinib are amplified when the drug is used to incubate cells that are put on more in a support, and a plastic support, and a culture support that is more rigid than usual. It's called stiff pillar instead of soft pillar. And you see here that the number of dying cells becomes greater when the cells are on a stiff support rather than a soft support. This stiff support somehow simulates an increase in afterload against which the heart can be exposed. And so it's a very elegant way to show in vitro, in cell cultures, how hypertension can amplify the toxicity of sunitinib, which is, by the way, a common clinical observation. One more, genetic background. It's now established that patients who have mutations in genes that are associated with cardiomyopathies, let's say in general, are at higher risk to face the cardiotoxicity of different cancer treatments, especially anthracyclines. And we can dig into the mechanism of this predisposition by using human samples. Now, there's plenty of different human samples you can use in basic and translational studies. I will not go over all of them, of course. Every type of sample has pros and cons. Blue means useful, yellow means so-and-so, black means we really can't use that for the purpose. And one of the most potent type of human sample we have is represented by cells obtained by induced pluripotent stem cells. These were already mentioned by Peter van der Meer this morning. In a very short story, I'm trying to summarize in less than 1 minute a Nobel Prize story. You take somatic cells like fibroblasts from the skin, they differentiate them to pluripotent stem cells, and then you differentiate them back into the cell line you want, for instance, cardiomyocytes. The trick is that by doing so, the cells you use keep the memory of the cells where they come from. So the genetic background of that certain patient, the patient from which the skin fibroblasts were taken, is maintained. And so then in vitro it's possible to study what happens with that certain genetic background. This is important, and the group of Paul Burridge made the seminal studies showing that cardiomyocytes derived from induced pluripotent stem cells of patients who had faced cancer treatment-related cardiotoxicity were more prone to develop injury when treated in vitro with the cardiotoxic drugs. For instance, you see that these are cardiomyocytes from patients treated with doxorubicin, women with breast cancer. Some of them, called DoxTox, developed clinically evident cardiotoxicity. And you see that their cardiomyocytes are more sensitive to the damage of doxorubicin. The red dots I'm pointing at are a marker of doxorubicin injury. And the sarcomere organization, the organization of the cytoskeletal organization of the cardiomyocytes, is definitely more disrupted by doxorubicin in patients who are prone to develop cardiotoxicity than in those who are not. And the beating capability is also perturbed. And later on, this has been mentioned also by Bonnecke, this group was able to pinpoint one by one the genes that underlie the genetic susceptibility to anthracycline-related cardiotoxicity. So I could go on forever. I swear that I'll switch. But I would like to, before that, I would like to call your attention of one of the last type. Last is not correct. As Mariana said, new depends on what's new to you. This is another powerful tool to investigate human samples in the preclinical setting. It's living myocardial slice. It's not new, but in cardio-oncology, the attention to the potential of this methodology has been growing only recently. So living myocardial slices are small pieces of the heart that are taken, cut in very thin slices, and cultured in a biomimetic environment. And again, like for the cells I mentioned before, these pieces of the heart, of course, keep the genetic background of the patient they come from. So in this work, for instance, it was shown that living myocardial slices from different patients with end-stage heart failure were differently susceptible to the toxic effects of doxorubicin in vitro. Patients who, the myocardial slices that were not susceptible had a smaller perturbation of the expression of the genes encoding proteins of the cytoskeleton in red as compared to the patients with susceptibility. And here you see representative pictures where susceptible, let's call them like this, living myocardial slices had more frequently loss of the typical striation of sarcomeres, and the yellow arrowheads point to that, and the loss of an important protein for electrical communication between cardiomyocytes, which is connexin 34. We may even envision a future where a living myocardial slice is taken from a patient to see in vitro how the heart of that patient tolerates or does not tolerate specific cardiotoxic drugs and take important clinical decisions. This is a case report, a very weird case report, where a patient was put on ECMO for crush and burn, acute heart failure. A living myocardial slice was taken. In vitro, it was seen that the heart tissue of that patient was actually capable to contract very well and was responsive to inotropic drugs, even though it was affected, of course, by doxorubicin and trastuzumab. So it was concluded that that patient could be suitable to undergo long-term LVAD implantation. And so forth. Now, what I also would like to share with you is that despite all these studies, I just mentioned really a few of them, and despite very important insights, we still have more experiments than profitable results in basic science. The body of evidence that is available is definitely not exploited to the extent it could be. And this is also because there are intrinsic limitations in our current knowledge, our current body of evidence in preclinical cardio-oncology. Well, some studies are flawed by methodological inaccuracies, and of course I won't spend time on those because these should be carefully checked and avoided by the investigators. But there are more complex criticalities regarding the choice of the experimental models, the choice of the study design, the choice of the endpoints that can be can affect even very important efforts, possibly because the expertise of those who embark upon such a study is not so strong. And the number of different experimental models that can be used is very wide, and this adds to the complexity. So the study group on basic and translational cardio-oncology of the ESC Council Cardio-Oncology has recently teamed up with an panel of international experts in basic cardio-oncology, and has tried to delineate some quality standards that might hopefully will help a future researcher in designing strong, reproducible, and trustworthy studies in preclinical cardio-oncology. And the paper will come out soon, hopefully. Peter van der Meen already alluded to this, so I'm just stressing again the concept. A major limitation of basic cardio-oncology is that it's strongly focused on anthracyclines, which is fine. Anthracyclines remain an important chemotherapeutic agent, but they are not the only one. And there is clearly a mismatch between the number of studies on anthracycline done in the last 3 years and the role that anthracyclines here have in the clinical trials, phase 3 clinical trials in oncology during the same time period. So I have just 1 minute left, and I would like to spend it to tantalize you about another completely different field of cardio-oncology, which is the so-called reverse cardio-oncology, a term that has been coined by Rudolf de Ver to define the possible effects of cardiovascular disease, pre-existing cardiovascular disease on cancer growth. The hypothesis is that at least some types of cardiovascular disease promote cancer development and cancer progression, especially heart failure. There are many epidemiological studies, including the one by my group shown here, indicating that patients with heart failure have a higher incidence of cancer and die more from cancer as compared with controls. Multiple possible biological explanations for that, and to synthesize, there are currently 2 different lines of evidence. One line suggests that the failing heart releases soluble factors that reach cancer's foci through the bloodstream and stimulate the proliferation of cancer cells. And the other line of evidence suggests that heart failure induces a rewiring of the immune system so that immune tolerant cells are selected over cells killing cancer cells, and therefore cancer growth is promoted. Possibly both mechanisms are valid. We don't know that. For sure, this is an exciting frontier of cardio-oncology, new frontier of cardio-oncology, about which I'm sure that we'll listen again in the future. And with that, I conclude with, again, an invitation to come to Vienna for the upcoming ESC Cardio-Oncology Conference. Thank you.
Thank you. I just have one quick comment and then a quick question. So I think what you've shown both from the translational science viewpoint and this holds true for clinical science is that we have to work together as a global community to do this research, because small, poorly controlled trials is not going to give us the evidence that we need to make clinical decisions that are best for our patients. So one quick question: of the translational work that has been done recently, what is the one thing you think that may lead to promises changes in clinical care?
Yes, well, a paper I didn't cite because of time constraints, published in European Heart Journal, Chinese paper. The authors show that acute leukemia cells, when they undergo necrosis because of treatment with chemotherapy, release interleukin-1. And interleukin-1 goes to the heart and modulates in a negative manner cardiac metabolism. And that is the way by which daunorubicin, a chemotherapy drug used for treating leukemia, causes cardiotoxicity.
It's okay, because before you got here, you were here late because your flight was canceled. I showed that study in my talk.
Great,
yes, the interleukin-1
So the study she showed, but I wasn't here.
So we think alike. Okay, thank you very much, and that closes this session. Thank you.
Thank you very much for the excellent session and discussion. I'm very happy to have you as a speakers, as the chairs. So this is amazing moment that the expert from European Society of Cardiology came to Poland and discussed about such amazing problems. Thank you once again. And it's a moment to start the last session together with my friends from National Institute of Oncology. I will chair this session together with Pietro Ameri and Marianne Mirabel from France, maybe. Okay, with Peter. Pietro, I would like to give you the special gift from our institute, the book about Marie Curie, Marie Skłodowska-Curie in Poland, about friendship with Albert Einstein. Thank you for your coming.
Thank you. Thank you so much.
And my great pleasure. Please let me open this session because I would like to introduce my good friend from the USA, Professor Dan Lenihan. We know for many years Dan is present with us but online. Dan, can you hear us?
I can very well, thank you.
Thank you, Dan, that you agreed to enjoy our meeting as a speaker. I remember the time when you created the International Cardio-Oncology Society. That was 2009, many years ago. So I'm very happy that you are together with us. You support us. And Susan then came to Warsaw and had a special talk during the first session during this meeting. Thank you, Dan. Thank you, Susan.
No, thank you all so much. And this has been a really amazing presentation so far. I mean, you have like an all-star cast at your meeting, and so I'm honored to be a part of it, and sorry I can't be there in person. I do want to, since you have a pretty tight schedule, we probably ought to get to it. I think what I was assigned was kind of modern methods of early detection of myocardial injury. So let me make sure I got my clicker going. These are my conflicts. So this slide I actually got from Teresa, and I thought it was such a great slide, so I thought I better use it. But it's, you know, when we're thinking about multimodality imaging and cardio-oncology, we of course have lots of choices. And then the factor is what's available to you, and you know, what kind of quality is it and how quickly you can get it. And then if you have subsequent tests, you know, there always are potentially delays in retesting. So I think that one of our main questions is, at the beginning of cancer therapy, we always want to know how accurate is our test for telling us, you know, how risky it is for the patient. So, you know, we've proposed, you know, strategies for assessing the risk, and they are based on a number of clinical factors and then supplemented with either biomarkers or imaging. And then what you're trying to do is understand how much this patient may be subjected to some sort of toxicity as a result of their treatment. And so how accurate is your assessment, both by clinical means, but also by imaging? And then as the patient is undergoing treatment, you know, you're testing how precise is it, or how accurate is it for detecting a problem. So you don't want to do a test that says that there's toxicity happening when there may not actually be toxicity, because you certainly the cancer therapy, we want them to get their best case scenario, get the best cancer therapy to get rid of the cancer. So we don't want a test to mislead us from that path. So these are key questions as we're undergoing, you know, as patients are undergoing treatment for their cancer. So I'm just going to highlight, you know, a new tool that is out there, and really to give you some glimpse into the future. So there is a process of cardiac MRI strain measurements called fast sync, and what it can do is give you a very accurate assessment of risk at baseline, and then during the course of treatment you can facilitate very early detection and subsequent management of CTRCD. So the basic strategy is that this tool would allow you not only to know how much risk the patient is exposed to, but also with an accuracy be able to detect those any evidence of toxicity at its earliest stage. So This process has been published in different forms over the years. This is a paper from a few years ago looking at this tool over the span of 2 years in patients that were undergoing predominantly anthracycline-based chemotherapy. And as was mentioned in the previous talk, you know, most of the clinical trials or clinical investigation about detection are based on anthracycline-based treatment, mainly because, you know, it's used in so many different cancers, and also is associated with toxicity. In newer therapies may or may not have some specific toxicities. So whenever we're talking about myocardial function, the anthracycline-based model is really what we have to go with for the most part. And what this particular study showed is that MRI determined strain parameters were very effective at not only predicting their baseline risk, but also detecting toxicity as they underwent treatment for their breast cancer or lymphoma in this case. And so the idea here is on this figure, the red letters are the ejection fraction. And as you know from all of our CTRCD guidelines, they're based predominantly on EF changes. But the problem is that, and we've known this over the years, but it's been difficult to prove this point, that there may be a significant amount of toxicity that's occurring, but the ejection fraction may not change until basically the patient sort of falls off a cliff, in the sense that the cardiac function will be able to make adjustments to maintain close to normal LVEF. And then at the point that there's a sufficient amount of cardiac damage to where the EF drops, then that patient basically fell off a cliff. So the arrows, the letters in red indicate the ejection fraction, but if you look at the letters in blue here, that is a myohealth score, which is the percent of normal segments throughout the myocardium. So it's a much more detailed and regional assessment of cardiac function. So it's not basing it all on just a global measure. It's looking at each regional segment and how many of those are normal. And what we found from this previous study was that as the myohealth score is reduced, it may be more sensitive in detecting toxicity. It also may be more accurate in terms of assessing their baseline risk. If they have a low myohealth score, then it could be indicating that they're already have some evidence of cardiomyopathy, even though their EF may be in a normal range. So this whole concept of using the myohealth score was extremely important and seemingly more sensitive than EF changes. This is the data from that particular trial, and I'll mainly point out the left panel here. And if you look at the black dots, that's the patients that had no evidence of cardiotoxicity during their treatment. And you can see the percent normal myocardium stayed the same throughout treatment. If you look at the red dots, you see that these are patients that had evidence of toxicity early on, and then they gradually recovered as they were treated with cardioprotective therapy. And then in the blue dots, these are patients that developed toxicity and they did not have any recovery. And so this was CTRCD that was persistent. And the whole concept of detecting toxicity early and enhancing your cardioprotection is really based on Daniela Cardinale's initial work, some of her initial work about the earlier that you institute cardioprotective therapy, the more likely is it that it will return and hopefully all the way back to normal. But if you don't detect it early and it becomes persistent, then the chance of improvement is negligible. So we recently looked at this study in more detail, and again, this was 59 patients that had mostly breast cancer and some patients with lymphoma. They were treated primarily with anthracyclines and in certain cases HER2-based therapy. They were followed for over a year, and over the summary of the whole study is that 44% had no evidence of toxicity throughout the trial. 41% had what was considered subclinical toxicity, where they didn't meet the ESC guideline definition of toxicity, and then 15% had actual CTRCD as described by the guidelines. When we look at the details, up on the top portion of this figure, the blue panel is the MyoHealth score, and then the gray and the red panel are the ejection fractions. The gray is the ejection fraction by CMR, and the red is echo-based ejection fraction. You can see that the MyoHealth score is much more predictive of subsequent toxicity or risk of toxicity than EF measurements. So for example, in the group that had no toxicity, their average MyoHealth score was in the 80s, whereas and this is at baseline, and then in those patients that ultimately developed some degree of cardiotoxicity, their MyoHealth score was in the 70s. And so the MyoHealth score was able to detect a subtle change in their risk. If you looked at the ejection fraction measurements, you couldn't tell any difference. And then during the course of chemotherapy, a similar pattern existed where at baseline, during the course of therapy, if they had a MyoHealth score that always remained in the 80s, then they had no evidence of toxicity. But in those patients that their MyoHealth score was reduced into the 60s or even down into the 40s, then they had clear evidence of cardiotoxicity. And the problem is that EF measurements, either by MRI or echo, were unable to detect those changes. And so this picture down at the bottom is the MyoStrain bullseye plot of all the regional measurements. And you can see that the colors begin to change in those patients that had cardiotoxicity, but it's not a global change, it's more of a regional change. And so if you don't look at the regional segments very carefully, you're not going to be able to detect that toxicity. And when we looked at the different parameters for prediction, meaning that did the tool predict those at risk for the development of toxicity, it was actually the fast sync measurements, either the global circumferential strain or MyoHealth, that was the most powerful predictor in terms of who would develop toxicity. And then during chemotherapy, MyoHealth and the fast sync strain parameters were far more likely to detect toxicity as opposed to the EF measurements, either by CMR or by echo. And I just wanted to highlight a couple of cases to kind of show you exactly how you use this in clinical practice. So this is a 40-year-old female who had diffuse B-cell lymphoma, and at baseline her mile health score was normal and the ejection fraction was also normal at 62%. After just 2 doses of doxorubicin, you can see there's a substantial change in the regional myocardial strain measurements, but the ejection fraction still remained in the normal range. And when you look at the mile health score, there was a marked reduction. And as a result of this finding, cardioprotection was instituted with candesartan and bisoprolol, and you can see a dramatic improvement in the mile health score back to normal. I would point out that the ejection fraction remained in the normal range even during all of these events. Another case kind of illustrates this point again, that this particular case was a 59-year-old female with lymphoma and had a baseline mile health score in the 70s, and again, a normal ejection fraction. And after only 1 dose of doxorubicin, had a marked change in the mile health score, and you can see many regional changes in the myocardial strain were markedly abnormal. Again, the patient was treated with cardioprotective therapy as tolerated. In this case was ramipril, but because the EF was still in the normal range, the patient was continued on their treatment with doxorubicin. And then over the subsequent weeks and months of treatment, you can see the ejection fraction basically stayed in the normal range throughout. But because the myostrain value had been so reduced and they focused on improving cardioprotection, over time, the patient continued to get their anthracycline, and actually the mile health score improved by the end of follow-up. So in the conclusions from this particular study would be that fast sync CMR does appear to have high clinical utility for risk stratification, early detection, and identification of those patients who might recover cardiac function. And certainly there's a robust identification of patients at higher risk for toxicity. And the most important thing would be that mile health score is a summary of regional measurements that accurately detects cardiac dysfunction during therapy and hopefully will enable cardioprotection, allowing them to continue on their cancer therapy course. So we actually designed a prospective study to test this hypothesis that we called the proactive evaluation of function to avoid cardiotoxicity, for short, is called the PROACT study. And the most important thing here is that we prospectively randomize patients such that half of the group we were given the strain measurements and we could act on them. And in the other half of the group, they had basic MRI measurements, and we weren't able to see the strain values, so we didn't make any difference in terms of their treatment. And when we looked at this, we presented this about a year ago at the ACC meeting, that the mile health score was actually the most powerful predictor of future cardiac events, and it was actually about 10 times more accurate in terms of detecting toxicity than LVEF. So this was a prospective testing of whether the strain actually led to improved cardioprotection and subsequent prevention of cardiotoxicity. We're working on the final data for this study, so hopefully there'll be a publication in the near future. And I would point out that just by having the strain information, we were able to reduce the adverse cardiac events in 1 year. So in the MyoHealth group, those were the patients in which we had the strain values and were able to utilize them in terms of clinical practice, versus the standard of care is that they had their EF measurements by MRI, but that was it. There was no information about the strain. But just with having the strain information, we're able to reduce serious cardiac events in a significant fashion. So having that information had a great impact in terms of cardiac status and whether the patient got full doses of their cancer therapy. So I think what are the take-home messages about myostrain in cardio-oncology? So first off is that it reclassifies this CRT cardiovascular therapy risk and or toxicity risk, and it facilitates early detection and management of CTR-CD. And there's certainly, if their MyoHealth score was greater than 70, that was a low risk category and there was no immediate action, and it certainly served as an appropriate baseline for future monitoring. In terms of if you had a MyoHealth score between 55 and 70, this was considered a moderate risk category, and you would personalize your cardiovascular care plan, including cardioprotection, based on what cancer treatment they're getting and what their cardiovascular findings may be. And then, of course, the high-risk category is people that had a MyoHealth score less than 55. And in those situations, we really need to optimize the treatment for heart failure, because that's essentially what that risk category would be showing you. So this is hopefully a new tool that will be able to be utilized very actively in cardio-oncology, and as was shown at least briefly in the PROACT study, we can actually reduce the cardiovascular adverse events as a result of this knowledge. So thank you very much, and I really appreciate being involved in such a fantastic conference, and happy to answer any questions.
Thank you, Dan, for the excellent question, for the excellent lecture. And we have the questions.
Hi, Dan. Thank you. It's Susan. So can you just comment, and you've obviously shown this new technology can be beneficial in determining those people at risk, perhaps more sensitive to existing techniques. What about access? Can you just comment about access to this technology, and where are we now and where are we going, and perhaps where do we need to go with in terms of access?
Yeah, so that's such a really great question, and I think, Susan, you know many of these answers already, so I know you're asking the question just for everybody else, really.
Correct.
But the real issue is, availability for anything. So if you, depending on your resource environment, even biomarkers may be somewhat challenging. Obviously, those are pretty simple and don't require advanced, interpretation. So biomarkers are obviously an important tool that would be in many resource environments. Advanced echo or MRI or something else like, PET imaging or whatever, those are only going to be really available at expert imaging places. Now, the real advantage to MyoStrain is that it is an automatic or automated analysis that once you have it set up on your MRI machine, it literally only takes about 2 minutes to get a report, and it's pretty much technician independent. So the patient gets their image, and then the report is printed out within a couple of minutes. And the other real advantage to MyoStrain is it doesn't require contrast. So you can do a much shorter scan, and you don't have to put in an IV, and basically you can get the patient in and out of the MRI scanner with limited time.
So just to make a comment on that, Dan, and that's correct. So currently available at specialized centers with, they have CMR availability, but as we saw at the ESC meeting, we saw the mobile van. There was a mobile van with CMR from Philips when it was doing MyoStrain, and maybe we need to think about how to take this technology to patients rather than patients coming to tertiary care centers.
Yeah, and I think that the mobile van was a great illustration. You know, Philips was really thinking ahead there, because you know they could do MyoStrain on a person, or you know, a doctor attending the meeting and go in there, and in 5 minutes they do their MyoStrain, and you get this, you know, really nice printout with regional strain. Now, I think that how can we get that type of technology to, you know, community practices or more resource-strained environments? That's a real question, and I hope that we can overcome some of those barriers, because I really do think the technology is reliable and accurate.
And I think you have to tell or inform the oncologist as to who to refer so they can have that. I mean, it gets a bit complicated. You say you do this early at baseline so you know what the MyoHealth score is, but how does a person who may not have the traditional risk factors but is at risk, how do we get them to have that type of scan? So I think there's just some logistics that, you know, obviously we still need to work out, but it's very interesting technology.
Thank you, Dan, once again.
Thank you.
Small practical question here, Sebastian. We prefer to use GLS from echocardiography at our institute, hematology and oncology. So tell me, what do you recommend us when to replace GLS assessment and use your MyoStrain by MRI?
Well, I mean, if you're just asking me my opinion, I would say yesterday. But if you're talking about how do we do that practically in the world, that's a real challenge. But GLS by echo is global longitudinal strain. There's also global circumferential strain, and you can measure that by echo. But in each of those situations, you know, to get all the regions to come up with a global number requires some technical expertise, even with echo. So I think that there are limitations to using GLS. But in the MyoStrain, GLS and GCS are both automatically calculated, and the accuracy in terms of getting each regional measurement is much higher than with echo. So I would say if you have the technology, it's more accurate and sensitive. So how do we change that parameter? I don't know. That one's hard.
Thank you. Other question? No, we have no other questions. Thank you once again for excellent talk. And I would like to repeat that we appreciate what you have done for cardio-oncology development in the world. Thank you, Dan, for everything.
Thank you all so much. And Sebastian, you've been just a tremendous international leader in this conference that you've put on. You have all the all-stars there. So thank you for inviting me to be part of it.
Thank you, Dan.
Okay, thank you. So we can now move on with the next presentation, which will be from Dr. Kukars about uro-oncology experiences, please.
I need a microphone, I guess. Okay, so thank you. First of all, I would like to thank Sebastian, who's my friend, for giving me the opportunity to be here. I'm a medical oncologist. I'm head of medical oncology unit of Department of GU Oncology at this institution. So I'm not gonna tell you about the guidelines on cardio-oncology because you are the experts. I'm gonna tell you how we manage your oncology patients with comorbidities and how we was our approach to these patients. Our population is quite specific because we have prostate cancer patients. Of course, it's very common malignancy in general population, and we need to keep in mind the risk factors for cardiovascular disorders that are present in those patients. RCC patients are specific because of the treatment we use in this group. I mean TKI and immune checkpoint inhibitors. Urothelial cancer patients, specific because of, I would say, the risk factors that are the same for GU oncology, for urothelial cancer and cardiovascular diseases, and germ cell tumor patients who are get like very intensive treatment and have very good long-term outcomes, and they have, let's say, time to develop cardiovascular complications in the future. So let's begin with prostate cancer. Something I would like to point is that over 50% of patients with prostate cancer have like cardiovascular comorbidities, at least one, and we know that the mortality from like cardiovascular diseases is higher in prostate cancer population than in general population. That's probably like reflects the some of like risk factors, the obesity, the side effects of the prostate cancer treatment. And something that we should keep in mind is that prostate cancer, the clinical course of prostate cancer is quite long, but the like backbone of the treatment for all like advanced stages is ADT. Is the castration, so it has like significant cardiovascular side effects. And once we begin the ADT in advanced prostate cancer patient, we continue that, I would say, lifelong. Choosing the treatment for prostate cancer patients is not so easy because we should like keep in mind many different factors like the stage, the symptoms, dynamics, the previous treatment, cross-resistance between the drugs, something that was mentioned before, I mean drug-to-drug interactions. So many of those patients have like polypharmacy. They get like many medications for different comorbidities. The HRR status, the presence of differentiation to neuroendocrine carcinoma, and of course the patient's preference, because some patients don't want to get chemotherapy. And of course, we still need to keep in mind something that was shown on the first slide, I mean the comorbidities. So if you take a look at the management of advanced metastatic prostate cancer in castration-sensitive stage, all patients get ADT, so all patients need castration, I mean the deprivation therapy, androgen deprivation therapy. In all patients we use ARPs, nowadays. So novel agents. I don't like to call them novel agents because they're on market since for more than 10 years. So I wouldn't call them novel agents, but hormonal agents like abiraterone and amides are used as something like on daily basis in those patients, in almost all of them. In some of them, I mean those with high volume disease, that is like primary metastatic, we add chemotherapy with docetaxel to intensify the treatment. But the RP selection is based on the comorbidities, the toxicity profile, and the drug-to-drug interaction profile. Because if you take a look at the efficacy of, in terms of oncological outcomes, all the RPs are quite the same, but the toxicity profile is very different. So there are two groups: the abiraterone, that is androgen synthesis inhibitor, that requires like concomitant use of prednisone, and the amides, namely apalutamide, enzalutamide, and darolutamide, and it's all combined with ADT with very known profile of side effects. It's not only a cardiovascular. These are not only cardiovascular side effects, but also like lipid profile change, insulin resistance, metabolic syndrome. So there's lots of factors that co-occur. As I mentioned, the side effects of particular agents are quite well known, and we should choosing the treatment for those patients. When we choose the treatment for this patient, we should like very deeply assess the additional risk factors. For example, in abiraterone, it's quite typical to see electrolyte abnormalities, to see arrhythmias, to see what the fluid retention. So it's not a very good idea to use them in patients with heart failure. While enzalutamide gives use of enzalutamide may result in hypertension and ischemic heart disease. And high-grade cardiac disorders occur more frequently in abiraterone. It has been shown, and also the risk of death and hospitalization in patients receiving abiraterone or enzalutamide is correlated to number of pre-existing cardiovascular diseases. So we should assess those patients quite deeply before we choose. And something that is very important from my point of view is the results of stop kappa meta-analysis that has been was shown during the ASCO GU this year. And the authors wanted to assess what's the benefit of use of particular RPs in different subgroups. And please notice those patients who are over 75. If you take a look at the prostate cancer specific survival, we see benefit in abiraterone trials. We see overall survival benefit in abiraterone and amide trials in younger patients, but in patients over 75, we see prostate cancer specific survival benefit, but we see no benefit in overall survival, which probably means that those patients die because of cardiovascular complications. Okay, let's move to docetaxel. That is also commonly used on those patients in combination with ARPs or a single agent. And it's very old drug that is well known, but in some patients we see impaired ejection fraction. So patients who with pre-existing heart failure are not very good candidates to docetaxel. So in those patients, we probably skip docetaxel and use cabazitaxel at some later in the course of disease. RCC, I mentioned it's specific because of drugs we used, and also the risk factor for RCC. Typical risk factor is hypertension, so many of those patients have like pre-existing heart disease and cardiovascular disease. And here are the guidelines of Polish Society of Clinical Oncology. So we use TKI in favorable risk patients, but in patients in intermediate or poor risk, we can use TKI, we can use IO-TKI combination or Ipi/Nivo. Non-clear cell RCC, there's no so much data on for non-clear cell RCC, but there are still some recommendations. TKIs are very commonly used in those patients. And what's the problem is that VEGF inhibitors, they have some on-target and off-target toxicity. On-target toxicity, very typical, is hypertension, impaired wound healing, proteinuria. But we also see some off-target toxicities that differ between the agents. Hypertension is very common. It's something we should keep in mind because we can see significant hypertension in up to 70% of patients who receive TKI. So once you have patients with pre-existing or not well-controlled hypertension and you want to put them on TKI, you probably see some problems in terms of blood pressure control. On the other hand, we know that the hypertension induced by TKIs, they are somehow predictive for the outcome. It's the field we are still investigating at our department. And immune-based combinations, you've probably seen this slide many times. You can expect anything in those patients. Anything can happen. And you've seen it many times, so I'm not going to discuss that. But if you decide to use IO-TKI, you can expect to see some overlapping toxicities. You can see some scenarios when it may be quite hard to distinguish which drug is responsible for toxicity. In patients with significant pre-existing cardiovascular disorders, we prefer to use IO the because the cardiotoxicity is not so common as in case of use of TKI. So the factor of the presence of cardiovascular disorder in significant cardiovascular disorder and medical history leads us more to use IO than IO-TKI combination. So I mentioned IO combination. Combination. So Ipi/Nivo, we know that it's the complications occur earlier and are more severe. And of course, we are afraid of myocarditis. That it's not very common, but the mortality rate is quite high. It usually occurs in the beginning, at the beginning of the treatment, but the question is why the mortality rate is higher than in other adverse events. Maybe because it's hard to diagnose, because maybe the diagnosis is delayed, maybe the severity as itself, or maybe our treatment is not so very efficacious. We know that using early initiation of high-dose steroids in those patients is crucial for the outcome. our practice is to assess the biomarkers prior to every infusion for the first 3 months. I mean, NT-proBNP, CKMB, creatine kinase, and troponin prior to every infusion for first 3 months. And something we should keep in mind regarding the toxicity, cardiovascular toxicity in RCC is thromboembolism. We know that the incidence of thromboembolism in those patients with RCC who are treated with IO is higher than other patients with other malignancies receiving IO, and also higher than patients with RCC getting other agents, I mean anti-angiogenic TKIs. So patients who are treated for RCC with IO-based combination are at very higher risk of these complications. Just one case. 64-year-old patient, female patient who underwent right nephrectomy in 2020. She had clear cell RCC, grade 2. It was primary metastatic disease with metastasis in lymph nodes, pancreas, and bones. It was IMDC intermediate risk patient. She had quite significant medical history in terms of cardiac cardiovascular disorders. So my decision was to give her ipi/nivo and radiation to bone metastasis, and she had partial response. But just after 4 cycles, she presented the orders. The sequence should be different. She presented with atrial fibrillation to community hospital. We were called by a cardiologist. They asked for consultation, and my first idea was to check the thyroid function, and of course she had thyroid toxicosis, and the atrial fibrillation was probably secondary to thyroid toxicosis. And I told them not to give her thyroostatics, just propranolol and wait, or other, I would say, cardiologic agents, but no thyrostatic. But she was consulted by community hospital endocrinologist, and she was given temazole, and that resulted in granulocytosis, that is known side effect of thyroostatics. And she developed febrile neutropenia. She was admitted to our institution. Fortunately, she recovered. And she had nivolumab recent, and the treatment is ongoing. I'm just trying to show that the presentation of, I would say, cardiovascular side effects, there might be something else underlying. I mean, in this case, it was probably the thyroid dysfunction. Urothelial carcinoma, the treatment paradigm has changed, but what are the main concerns? The comorbidities, because most of those patients are heavy smokers, so they have cardiac common risk factors for urothelial cancer, and urothelial cancer, cisplatin toxicity, and in those patients who receive immune checkpoint inhibitors, of course, the immune-related adverse events. Cisplatin cardiotoxicity is something we observe, we know, and the part of assessment for cisplatin eligibility is also assessment of the cardiovascular fitness, I would say. And last but not least, our germ cell tumors. The concerns are quite the same because we use cisplatin in young patients, but something we should keep in mind are the thromboembolism risk in those patients. There are some studies reflecting the indications for prophylaxis, for primary prophylaxis, and also the long-term toxicities. I mean, the endocrine, metabolic, cardiovascular, hematologic, and others. So most of those patients, around 90%, are cured with chemotherapy, but they develop like long-term toxicities and complications. Thank you very much.
Thank you.
Thank you very much. Do we have a question? Yeah. First of all, are there questions from the audience? No? Okay, so I would like to ask a question if I can. Thank you. Very comprehensive talk. You showed us that the patients with the urogenital cancers are often patients with an important cardiovascular background. So in your local experience, how often do you interact with cardiologists? Do you discuss the cases together ahead? Do you refer the patients only when there's a problem? What's your local experience?
Those patients with urothelial cancer are urothelial cancer, right? They're very problematic because, for example, in terms of neoadjuvant treatment, that is like standard of care, and it's cisplatin-based. If you want to go with neoadjuvant, you need to use cisplatin. So, around half of these patients are ineligible. So we refer, I would say, 20 to 30% of those patients, sometimes to cardiologists, sometimes to their GPs, because in Poland, many of GPs are specialists in internal medicine, so they are good in like management of those, let's say, not very complicated cardiovascular disorders. In case of metastatic disease, we have other options than cisplatin. We can use carbo, but still we like to have all comorbidities well controlled. So quite interesting case is with RCC, because cardiovascular complications are very common, I mean, in terms of hypertension. So my own practice, because I see lots of patients with RCC, is to, for example, in case of hypertension, is to put them on 1 or 2 agents, and refer them, but in the meantime, I begin the antihypertensive treatment. And of course, in cases of resistant hypertension, it's like my quite common pathways to call Sebastian.
And does he come?
Pardon?
Does he come?
Yeah, he comes, but we very often discuss those patients by the phone, but we have like consensus.
Okay. I think
Thank you, Kuba.
Thank you so much. We have 2 more, all right?
Yes, I would like to thank you, Kuba, once again. Excellent talk. And the next one will be my colleague, good colleague from my institute. Patrycja Ozdowska is one of the leaders from Echo. Please show your experience in the echocardiography laboratory at our cancer center.
Good afternoon, ladies and gentlemen. My name is Patrycja Ozdowska, and I am cardiologist at National Institute of Oncology in Warsaw. It's a pleasure to be here today. Thank you for the invitation. I would like to share 2 clinical cases that were for us both a learning experience and a challenge. The first case study is a 51-year-old female patient who was diagnosed with left-sided breast cancer, a status post-surgical patch closure of atrial septal defect at the age of 36, with paroxysmal atrial tachycardia with 2-to-1 atrioventricular conduction with hyperlipidemia. The patient presented to our outpatient clinic for the cardiology evaluation prior to the initiation of oncologic therapy. The patient denies presence of any disease-related symptoms, and the general condition of the patient was good. No significant abnormalities was found in laboratory tests. And the transthoracic echocardiography demonstrated normal systolic function for both the right and left ventricles, intact surgical atrial septal patch, and no abnormal masses within cardiac chambers. Multidisciplinary team decided that patient would undergo new adjuvant treatment with paclitaxel, carboplatin, trastuzumab, and pertuzumab, followed by surgery, and subsequently trastuzumab adjuvantly. Before starting chemotherapy, the patient already had central venous catheter inserted into the superior vena cava. And in February, the first dose of chemotherapy was administered. After 3 months of oncological treatment, a follow-up visit with transthoracic echocardiography was performed. Patient referred fatigue, and laboratory results revealed a low hemoglobin level. Follow-up transthoracic echocardiography demonstrated an additional mass in the right atrium with limited mobility, measuring approximately 26 times 18 millimeters. The intra-atrial thrombus was suspected. Thrombus is the most common intracardiac mass, and it can occur within any cardiac chamber. Right atrial thrombi are often related to a venous catheter where the line is appropriately advanced into the right atrium. There are 3 types of right atrial thrombus. In the presented patient, the thrombus showed mass characteristics of type B thrombus. Are there any guidelines for the management of right atrial thrombus? No dedicated guidelines recommendation exists in ESC or American Heart Association official documents. The management of variety should be individualized based on thrombus size and mobility, risk of pulmonary embolism, presence of intravascular devices, and patient clinical status. We decided to initiate the anticoagulant therapy with enoxaparin at the dose of 1 milligram per kilogram every 12 hours under hospital supervision. Follow-up blood morphology after 1 and 2 weeks revealed no significant decrease in hemoglobin level. After 2 weeks of therapeutic dose heparin, anticoagulation therapy was switched to an oral anticoagulant apixaban under supervision of GP. The central venous port was removed after 3 weeks. The follow-up transthoracic echocardiography demonstrated that the size of the right atrial thrombus is comparable to that found in the baseline study. It was after more or less 4 weeks of anticoagulant treatment. The patient was switched again from NOAC to enoxaparin at the dose increased by 20% compared to the previously used dose. The follow-up echocardiography performed after 3 weeks demonstrated that the size of the right atrial thrombus is comparable to that was seen in the previous study. We decided to perform cardiovascular resonance magnetic to exclude the thrombus coexisting with tumor. Specialized guidelines identify cardiovascular magnetic resonance imaging as an essential diagnostic method for assessing patients suspected of having a cardiac tumor. SSFP sign imaging demonstrated an additional mass into the right atrial cavity. I marked it with red arrows. In the movie, okay. The thrombus was diagnosed based on its location in right atrial cavity. Tissue characteristic consisted with avascular homogeneous mass, and this determination was made on first pass perfusion imaging during the administration of gadolinium contrast and late gadolinium enhancement imaging, showing a homogeneous dark mass with no contrast uptake. To exclude pulmonary embolism, the patient underwent computed tomography pulmonary angiography. CTPA demonstrated right atrial thrombus and no evidence of thrombosis in pulmonary arteries. The multidisciplinary team decided that patient would undergo BCT. Anticoagulant therapy with enoxaparin was withheld for 24 hours before the breast-conserving therapy. On August 14th, the patient underwent the surgery. 5 days later, the patient was reoperated to evacuate a hematoma in the surgical bed following the BCT. Follow-up echocardiography performed after the surgery demonstrated that the size of the right atrial thrombus is only slightly, maybe slightly smaller than that described in the previous imaging. We were considering what further treatment should be applied in this patient. According to the ESC Cardio-Oncology guidelines, anticoagulant therapy is recommended for at least 3 months in patients with cancer and catheter-associated VTE, or until follow-up cardiac imaging confirms resolution of thrombus. We decided to continue anticoagulant therapy with apixaban for the next 3 months, followed by echocardiography studies. But are there any other treatment option for RAT? Maybe surgical or percutaneous thrombectomy, or maybe catheter-directed thrombolysis. In conclusion, patients with cancer are at an increased risk of thrombus formation. The incidence of CRAT is estimated at 8 to 13%, but it increases up to 25% in case of malposition of the catheter tip within the right atrium. Echocardiogram may initially identify the right atrial mass, but it cannot definitely distinguish between tumor and thrombus. Cardiovascular magnetic resonance is a gold standard for thrombus identification. The increasing number of patients, more frequent use of central venous ports, and advanced imaging have increased detection rate of right atrial thrombi. No dedicated guideline recommendation exists. It was the first case study. For the second case study, I would like to present a 62-year-old female patient who was diagnosed with leiomyosarcoma originating from uterus with metastatic spread to the pulmonary parenchyma, to the left adrenal gland, and subcutaneous tissue of the left upper extremity. Oncological treatment consisted of the following: total hysterectomy with bilateral salpingo-oophorectomy with subsequent pelvic radiotherapy. Patient underwent 3 lines of chemotherapy, currently on gemcitabine and docetaxel. And radiotherapy targeted to the left lung, left adrenal gland, and left upper extremity. The last course of radiotherapy targeted to the left lung was delivered in 2020. The patient presented to the outpatient clinic for cardiology assessment in the course of ongoing oncological treatment. She referred dyspnea on exertion and lower extremity edema, but the patient's general condition was good. Baseline transthoracic echocardiography demonstrated pericardial effusion with separation of the pericardial layers without hemodynamic significance. In short axis view, we can observe mild thickening of the basal inferolateral wall of the left ventricle, measuring up to 11 millimeters. We observe thickened visceral pericardium adherent to the basal segments of inferolateral inferior wall of the left ventricle. And the global ventricle systolic function was preserved. We recommended follow-up examination. The patient returned to our clinic for cardiology assessment for nearly 2 years. She referred dyspnea on exertion, lower extremity edema, but there has been no significant progression of symptoms since the last visit. And the general condition of patient was good. The follow-up transthoracic echocardiography demonstrated asymmetric thickening of the basal inferolateral ventricle wall, separation of pericardial layers by fluid up to 10 millimeters, and thickened pericardium adherent to the left inferolateral left ventricle wall. Parastellar long axis demonstrated heterogeneous myocardial enhancement of basal segment of inferolateral wall. And one more time, symmetric thickening of the basal segment of the inferolateral and left and the lateral left ventricle wall up to 60 millimeters with hypokinesia. Global left ventricular systolic function was preserved. Subcostal view demonstrated progressive pericardial effusion compared to the baseline study and marked collapse of right ventricle free wall. Neoplastic infiltration of the left ventricular myocardium and pericardium was suspected. We recommended cardiovascular magnetic resonance. Stir imaging demonstrated increased signal in the left lateral ventricle wall with associated asymmetric thickening of wall. MyoMaps sequences were used for evaluation of the left ventricle infiltration. MyoMaps offers the possibility of acquiring pixel-based quantitative myocardial tissue characteristic without contrast agent. Early and late gadolinium enhancement imaging demonstrated heterogeneous mass with contrast uptake in both early and late phases. Cardiovascular magnetic resonance confirmed the infiltration of the left ventricular myocardium. During the course of oncological treatment for assessment of progression, of neoplastic progression, the computed tomography of chest was performed and revealed progression of neoplastic changes in lungs and increase of pericardial involvement. Chemotherapy was terminated because of marked decline in the patient's overall status and ongoing progression of neoplastic disease. In conclusion, at the early stage, metastatic involvement may present with only subtle findings on transthoracic echocardiography. Cardiovascular magnetic resonance imaging is recommended as a key diagnostic tool in evaluation of patients with suspected cardiac tumors. Thank you for your attention.
Great pleasure to hear your talk, very valuable talk. Would you like to tell us your comment when to use MRI for the special selected cases from based on your daily practice? Because you are expert in echo, please refer when do you would like refer patients for MRI?
Maybe we don't have possibility to perform exam in MRI exam study in every patient. So we have to choose patient. We perform cardiomagnetic resonance in patient with really insufficient visualization in echocardiography, transthoracic echocardiography, or in patient with additional mass with suspected thrombus, but without any resolution after 2 or 3 weeks of anticoagulant therapy when we suspected, for example, tumor. It's the one of the use. Mm-hmm.
Thank you. The next one was explained by Dan Lenihan previously in the talk. Thank you once again.
Thank you. And now it's time for Professor Blamek. radiation oncologist, is director of the Gliwice branch of the Marie Skłodowska-Curie National Research Institute on Oncology, and he will focus on radiotherapeutics, please.
Thank you very much. Thank you for the invitation. It's a great honor for me. Well, I really appreciate that, because most talks today were given by clinical oncologists. I'm a radiation oncologist, so I especially appreciate that. But on the other hand, I'm quite nervous, because talking after the ASTRO president is a big challenge for me. We don't have. Well, I hope you can see me, because I'm in the background color, but. Sorry for that. It's late. We don't have much time, but I have a lot of slides, so maybe I skip the introduction and the problems of clinical oncologists, because we heard about that a lot today. And maybe I can skip also something about the radiotherapy, because it was already discussed by Barbara today. Radiotherapy is generally considered a toxic treatment, but on the other hand, we have to keep in mind that our knowledge about the toxicity of radiotherapy is based on the evidence coming from very old studies and articles discussing the radiotherapy techniques that are no longer used, actually. We don't use such big fields, open fields in hematologic malignancies. We don't use open tangential fields like this in case of breast cancer therapy. We learned how to avoid the hard and large vessels and limit the toxicity of the radiation treatment. We know currently the dose limits for even special certain substructures of the heart. So we know how to avoid this toxicity as much as we can. In our recent review, it was quite elegantly discussed, and at the end you can find some bullet points which can be summarized in actually two statements. One, the effect is dose dependent. So no dose, no effect, and no toxicity, and it's modified by concurrent therapies. And the other one is that the prevention of atherosclerotic disease and the management of radiation-induced cardiac toxicity generally follows the rules for patients that were not irradiated. So you can say, well, we know everything, we know what to do. I realize that it's not so simple. But in fact, I would like to tell you something else, something totally different, and related to the use of radiation therapy in patients with heart problems. So a novel trend in cardio-oncology is something called reverse cardio-oncology, and it refers to the situation when cardiologic treatments affects or influences the development of neoplastic disease. And in this context, I would like to say something about the not so obvious action of radiation treatment, which can act in an opposite way that we usually think. And this part of the broad field of cardio-oncology is called radiocardiology. Well, and in this topic refers mainly to star treatment, and this is the irradiation of the heart for ventricular tachycardia. I would like to tell you about something totally different that you heard today. Well, we as a National Institute of Oncology in Gliwice are involved in a large international study called STAPSTOR. It's an international initiative which got funds from EU program Horizon 2020.
and it's aiming at the evaluation of the value of stereotactic irradiation of the heart for ventricular tachycardia, at standardizing of this kind of treatment, and formulating guidelines for the practitioners. As in every big project like this, we have several work packages. One is evaluating the retrospective data, the other prospective, and the other is aiming at quality assurance and so on. I will not go into detail, but we have done already a lot, and we, for example, reviewed the current practices in Europe, and for example, the most important, one may think, point of inclusion criterion for patients for this kind of treatment, like at least one previous failed catheter ablation, is not present in 100% of national trials currently running in Europe. We are only in total agreement, 100% agreement in one thing, that we do not irradiate pregnant women. So the practice is very, very difficult in all the countries. Also, for example, the way of controlling and managing respiratory motion is very different across studies, and this is, I am showing this to show you just the number of studies that are currently running and the number of ways that the cardiac motion and respiratory motion is managed. We have also reviewed and analyzed the way the cardiac substructures are contoured during the treatment planning, and there are also many differences. In case of vessels, it's much easier for radiation oncologists, but in case of, for example, valves, it sometimes can make some problems for the team that prepares that kind of treatment. We have also developed a tool that aids auto-contouring of cardiac substructures. It of course requires evaluation in controlled clinical trials. We were also able to publish a meta-analysis of already finished trials, and it shows that the adverse effects are in general rare, so the toxicity of this treatment is rather low. The 1 year overall survival is in line with overall survival for these patients without irradiation. You have to keep in mind that there are very sick patients with cardiac failure. They are often on the waiting list for a heart transplant. So it seems that star treatment does not affect negatively the survival of these patients. And 1 year recurrence-free survival. And these results are not very optimistic because, this problem recurs in this patient, in most of these patients that were subject to star treatment, but the severity of the disease, the VT burden, is much, much lower than before irradiation. This is the summary of the trials included in the meta-analysis, and as you can see, after 3 or 6 months after treatment, the results are very, very optimistic, very good, but later the results are a bit worse. So this is the summary of this meta-analysis, and you can also summarize it in actually 2 statements that star treatment is a temporary solution and not for every patient, and it still requires confirmation in clinical trials. And this is not a cure, this is not a solution of the VT problem, because the tachycardia can recur after this treatment. And going back to STOPSTORM and our achievement, we have also verified the quality of the treatment plans across the clinical trials in members of the consortium, and we
we prepared some recommendations, some guidelines for treatment planning. These guidelines are, of course, preliminary because the final guidelines will be published after concluding of the study and analyzing of all the data we can gather from national studies. Every case that is included in our database is going through rigorous quality check. We have a special credentialing audit committee which verifies the quality of the data entered to the database, and it is an example of the report. We have also some other recommendations, like, for example, standardized processing of explanted heart after a start, because, as I mentioned, these patients are often transplanted, so we have the tissue for examinations, and if we would like to see how the irradiation affects the heart on the cellular level, we need to have material prepared in a proper way. We still analyze the left ventricular motion for the purposes of the treatment planning process. And well, we do a lot, and it's so interesting for many centers that apart from the 31 centers initially involved in the STAPSTORM study, this is the list on the left. On the right, you have the list of associated centers that joined us during the study, and these are external partners that are also involved in collection of the data. And we started preliminary analysis of the material that is stored in our databases. As you can see, after irradiation, the VT burden is much lower than before the treatment. And even in cases the arrhythmia recurs, usually it does not require so aggressive treatment like ICD shock. It's more often an ATP or even no treatment at all, which is also important for that patients. And we are going to publish this interim analysis soon, so this is only a draft. We are not sure about the mechanism that stands behind the irradiation. It was postulated that we want to induce fibrosis and homogenization of the scar that is the source of the arrhythmia. But there is some evidence that the action of the irradiation can be based on change of the expression of sodium channels and connexin. So we are running in Gliwice a study that is evaluating the effectiveness of lower doses than usually used, 25 gray in one fraction in most studies. We are also involved in another study that is aiming at dose escalation, so we still don't know which way is better. This study is conducted with colleagues from Switzerland. There is also some evidence that radiation can have some beneficial effect on the heart, especially in patients with heart failure. And on the mouse model, it was demonstrated that irradiation with low dose stops the process of cardiac remodeling. And well, there is also some evidence from the clinics, from human studies, that patients with heart failure can benefit from low doses given to the heart. So it's another field of maybe interesting studies involving radiotherapy in cardiology. I will go maybe on because we don't have so much time to discuss it in detail. What we also do, we are involved in the studies on the susceptibility of cardiac implantable electronic devices to radiation, because, well, we have more and more patients referred to radiotherapy with cardiac problems, and they often come to us with cardiac devices. And we evaluated in many clinical scenarios, like, for example, in case of proton therapy, which is commonly thought that should be contraindicated in patients with implanted devices. We started our research in this field with our friends from Germany in 2016. Soon after that, after our studies, we were able to present and publish a position paper with recommendations for radiation oncologists and cardiologists for the management of patients with implanted devices. We also tried to evaluate the influence of neutron radiation on the devices and production of neutrons related to the energy of photons used for radiotherapy. We also have done research on leadless devices and subcutaneous implantable cardioverters defibrillators. So a wide spectrum of devices were tested in our center. And well, most evidence concerning the effect of radiation on implantable devices is referring to data short term after irradiation. So we have an early effect. We have evaluated and we have data, we have evidence on early acute effect of irradiation on implantable devices, but there is no data on long-term effect of the irradiation for the functioning of the implantable devices. And we were able to collect such data, and we are preparing a big, beautiful paper to be published soon. And I think it will be the first evidence ever from showing the long-term observations after radiation in patients with implantable devices, and I hope it will be published soon. And one remark at the end, we all know that in case of clinical studies involving cancer patients, we don't really like patients with some other comorbidities and heart problems. And on the other hand, in case of clinical studies in cardiology, well, patients with oncologic problems after irradiation are not very welcome, but we cannot avoid this, and well, we should go into planning clinical studies that are combining both populations of patients, because well, the society is older, growing older, and we cannot just limit our clinical studies to just one population, because almost every patient in oncologic centers have some heart or cardiovascular problems, and vice versa. More and more patients with cardiac problems have also a history of oncologic disease. So now in Poland, there's running a national oncologic network. There's also a cardiologic network, and I was very glad to hear that National Institute of Oncology in Warsaw was qualified as a center, also as a part of National Cardiologic Network, because I think that this is the way we should follow. I think the cooperation of those two networks should facilitate establishing cardio-oncology units, departments in large oncologic centers, and they should be a part of such cardiologic network too, apart from being part of oncologic network, and this is the way we should go. We collect a lot of data during our clinical studies. We use the same tools we collected in databases. Collecting this and joining this data together can bring some more knowledge and more data referring to both populations of these patients. So this is a short summary of my talk, and I thank you very much for your attention.
Thank you so much. Any questions from the audience? I'm very interested in your study about the long-term effects of radiation therapy on cardiac implantable devices. So can you expand a little bit more?
Well, we have a median observation in this group of about 1.5 years. So it's not a very long-term observation, but still much longer than in the case of most papers that were published until now. And actually, we do not see any significant problems with the devices. One more thing we would like to do about that is to compare the data from interrogation in these patients with data stored from interrogations from other patients that were not treated with radiation, because we observe some minor changes in, for example, lead resistance or some minor changes with voltages, but they are without clinical relevance, and maybe there are some natural fluctuations that naturally occur also in patients that were never irradiated. So we are still checking that with the data we have in our databases, but I can disclose now that we do not see any significant problems even after a few years of after irradiation.
Well, that's reassuring. Thank you. I think we have to move on because of the sake of time. Thank you so much.
Thank you, Sławek. We appreciate your effort for radiation therapy and cardio-oncology. And now is the time for the lecture of Alex Lyon. Alex Lyon is traveling, so maybe attend only online. So please hear the lecture of Alex from the Bromsno Hospital.
Thank you for the kind invitation to speak at your meeting, and a big thanks to Sebastian Smith, and congratulations to Sebastian on putting together such a fantastic program and for leading cardio-oncology both in Poland and Europe-wide and internationally. You really are a tribute to your country and what you've been doing. So today I have the pleasure to talk about research and think about the background of the ESC guidelines. These are my conflicts, and I highlight two companies, Actea and Myocardial Solutions, where I'll be showing some of their products. So of course we live in a world where a lot of people are getting cancer, hopefully getting cured, but have cardiac problems as a result, or they develop heart disease, but now we're keeping them alive to develop cancers in later life and arrive at the oncology clinic already with pre-existing heart disease. And we know that there is a large cancer epidemic. It's reflecting the aging population as well as increasing obesity and other risk factors. But we also know there's a success story. Here we see on the right that over 30 years there's been a doubling in cancer survival. This number of people living more than 10 years from their diagnosis of cancer has gone from a quarter to a half. So a real success based on a number of factors. If you think about fundamental biology, generally you can think that heart disease and cancer disease are opposites, and therefore on the left are all the molecular and cellular processes driving cancer. And it's not surprising that if a pharmaceutical company or an oncology research team develop a drug or treatment that targets these processes, the knock-on effects is that they may cause problems in the cardiovascular system. When I was at medical school in the 1990s, we probably had 1 or 2 minutes of one lecture over a 6-year course saying, oh, there are these cancer treatments that cause heart problems, the red chemotherapies, high-dose radiation to the chest, and the emergence of the fluoropyrimidines and chest pain. But this is what modern cardio-oncology looks like. Every drug on this slide has led to a cardiac or vascular complication in the patient being referred to our cardio-oncology service at the Royal Brompton Hospital. And every few months, I have to put on a new drug because the oncology and hematology world are very productive, producing new effective therapies. These are all licensed drugs for different cancers. And so this is complex, and it needs a lot of research to understand how these new drugs are affecting the heart, how we can pick it up early, and then how we can ideally protect people's hearts. And we started with heart failure because the focus was on heart failure, but it spread to all aspects of cardiovascular disease as shown on this slide. And therefore, we have to learn the different drugs and what they're doing. Here's a figure from a paper published in 2022 just showing the number of cardio-oncology papers as reported in PubMed. And you can see before the year 2000, the numbers were relatively low, and then there's been this big inflection since 2000 for a whole range of reasons, including checkpoint inhibitors and all the targeted therapies. And this reflects in clinical activity. This is an audit we published in JACC Cardio-Oncology, just showing the number of consultations between 2016 and 2021. And if you take the period from 2016 to 2020, there was a doubling in that time. And we've now extended this out to 2024. And you can see that from 2020 to 2024, there's another doubling. So in the last 8 years, it's doubled twice, and it's not slowing down. This is an exponential growth. And this is one of the reasons why the ESC put together a task force, and Sebastian was involved, and I had the pleasure of co-chairing the task force on the ESC guidelines with Teresa. And we've had over 600,000 people visit the webpage and over 200,000 downloads. And we hope this is oncologists, hematologists, and cardiologists, as this guideline is for all three. And Sebastian led one of the chapters and contributed to this important document. So at the end of the guideline, we talk about the research needs, the unmet needs in cardio-oncology. So back in 2022, what did we say? We said we needed trials focusing on the at-risk cancer populations. We needed to validate the risk assessment tools that we'd published previously with the HFA and International Cardio-Oncology Society, and that has been done. Several papers have subsequently shown they are very effective at predicting the high-risk patients and also discriminating low-risk patients. We talked about new technologies for detection of early cancer therapy related to cardiac dysfunction, whether this is with imaging or biomarkers or both. We've got lots of risk scores in modern cardiology, but many have not been validated in cancer patients, and so we needed that. We talked about checkpoint inhibitor myocarditis. If they respond to steroids, that's reassuring, but what happens if they don't? We need trials to understand which is the best second-line immunosuppressive strategy and whether we should bring them in early. And then what about the late effects of checkpoint inhibitors? We have a whole range of interventional procedures we perform in modern cardiology, TAVI, MitraClip, left atrial appendage occluders, complex EP ablations, and so understanding which cancer patients might benefit from these. And in the arrhythmia field, there's a lot of concern about QT prolongation and how we can predict it and then how we can manage it safely. We also talked about genetics and the need, its role for genetics in cardio-oncology, and then how we might identify patients who, having been treated with heart medication to protect the heart, who then can be weaned off that medication in the cancer survivor group, and conversely, who may need to stay on long-term. And then what are the modes for long-term surveillance to pick up the late effects? We know a lot about radiation and anthracycline chemotherapy and late effects, much less about a lot of the modern treatments because they've only emerged in the last 5, 10 or 15 years. And this requires collection of data in large populations with registries, and then we could apply artificial intelligence and other technologies to really understand who's at risk, how we can pick them up early and how we can prevent them. So this was the context to what the guidelines said. I just wanted to say that randomized controlled trials are rare birds of paradise in cardio-oncology. We've had a few. They're always important. They teach us lessons even when they're neutral. But the real sort of drive is to increase the number of RCTs in the field. So now we're going to look at our research, and the first topic was immune checkpoint inhibitors and the range of cardiotoxicities that these treatments, which are very effective for many more cancers, can cause. And one interesting technology is modern nuclear imaging, and we're lucky enough to have a new whole body PET CT scanner with our university KCL, and in collaboration, Sohaib Nazir is now doing research looking at PD-L1 expression, both simultaneously in the heart and the tumour, and seeing what happens during the course of immune checkpoint inhibitor treatment, and in those patients who do develop myocarditis, can we predict them from their PDL expression at baseline, and what happens after treatment and in the acute phase. And we can then use modern CT to look at coronary health, and now we're doing this in patients during their immune checkpoint inhibitor with a new 2-photon counting CT scanner, which gives the highest resolution to assess for new plaque. As we know, there's a story that suggests that new soft plaque might develop in cancer patients receiving immune checkpoint inhibitor therapy, which makes sense because they're activating the inflammatory system. And then we can also use other technologies such as the Carry Heart Fat Attenuation Index to look at perivascular fat and inflammation, as this may be playing a pathophysiological role. We're also looking at patients during their immunotherapy. This is our Cardio-CT study, and then looking at survivors. And in collaboration with the Oxford group, we're also going to take blood to be able to do proteomics and plasma immunoassays to understand the cellular mechanisms driving the cardiovascular complications of immunotherapy. We've got a big program on research in cardiac MRI, and I'm sure you're all familiar that cardiac MRI is the best way to measure heart function with the lowest variability, but it now adds so much more in terms of tissue characterization, and we have this new technology called MyoStrain for the highest sensitivity of picking up early problems. And we're just starting a study applying MyoStrain in a large cohort of oncology patients coming through our service to use it both for baseline risk assessment, for monitoring during HER2-targeted therapies in the breast cancer patients, and then also in follow-ups and survivors to see whose heart is healthy and whose may be impaired and need long-term cardiac monitoring. And there's studies already performed in cancer cohorts with a prospect trial showing this is a very sensitive technology. It sort of precedes the fall in ejection fraction and even the fall in regular strain when measured on cardiac MRI. Hypertension is an important problem in cancer patients, and in particular cancer therapy-induced hypertension, and so the guidelines recommend starting a home blood pressure diary, and we're now exploring a new cuffless wearable, a bit like a Fitbit on the wrist, to monitor people's heart, their blood pressure using pulses of
I'm so sorry. Alex had the unstable internet access, so we lost the connections and we can not hear the next part of the lecture. I'm so sorry. Alex wrote me to and promised to be next year, enjoy our meeting, and sent to me apologize that he couldn't attend this year in person. I'm so sorry.
Okay, so I think it's time for the last but not least speaker. And I think that this is really appropriate, right? Isn't it? So, well, it's... I don't know which is the best way I could introduce you, Sebastian. I could,
as a friend.
You know,
as a friend.
As a friend, of course, and that's one of the most important points to me. Well, we all know Sebastian Smith, and we all know his commitment to cardio-oncology. There are a number of titles that document it, including the fact that he leads the Education and Training Advisory Committee for the International Cardio-Oncology Society, and he leads the thrombosis study group for the ESC Council of Cardio-Oncology. But I think that today, the best proof of Sebastian's commitment to cardio-oncology is this summit. I think it's great. You put together really an outstanding program, and you were able to gather people from really all around the world and all around Poland. And this is, I think, the best demonstration of the amount of work you do for cardio-oncology. So thank you for that, and thank you for everything. And please, stage is yours.
Thank you, Pietro. You are my friend too. And please believe me, I couldn't imagine that it will be a day that such amazing people, such amazing speakers, my friends, will come to Warsaw and speak during the congress, which I can organize together with my colleagues, Beata Biel from Oncotransfer, amazing team, and of course together with my director, Professor Beata Jagielska. So believe me, I'm very happy, and I would like to take only a few minutes to show my part, my activity in the ESC exactly, and I'm included to the International Cardio-Oncology Society. I'm responsible for education and training, so I have the contact with the younger population of our society, so I feel to be helpful for the development of cardio-oncology. And in the ESC, I had the honor to lead the special group, study group dedicated to thrombosis, because as you know, by reading of my CV, I cooperated with Professor Adam Torbicki for many years, and I can be called as an expert for thrombosis treatment. I'm very proud because in this way I can cooperate with amazing hematologists. I work for Institute of Hematology here. This is the neighbor of this institute. We can work together. And my pleasure is to cooperate with the young generations of cardio-oncologists and my young colleague, Jarosław Kępski in English, Jarosław Kępski in Polish. I'm so sorry, Jarek. We can enjoy this study group, and I believe that we can prepare some interesting papers together. Why thrombosis is very important? We have enough data to conclude that thrombosis is related to high risk of premature mortality in oncology and hematology, independently of the stage of cancer disease. And many types of cancer therapies may provoke, induce the thrombosis, exactly chemotherapy, based on cisplatin, but not only. Of course, immunotherapy, the modern immunotherapy may lead to thromboembolism, and some targeted therapies may provoke thromboembolic diseases. And my questions for this short presentation: how to treat, how long, which dose to use of anticoagulants, and which population with high risk of bleeding should have the individual approach when we should reduce or discontinue the anticoagulation. And the next question, how to protect, how to make a risk stratification, and how to make the personalized decision when and how long to use primary prophylaxis. And of course, I would like to start my discussion from this document. I know that is the huge moment for cardio-oncology. Writing this document was an excellent moment in my life. And as you can see, as you can read, we have the good resolution because we have two options of anticoagulation. We can use oral drugs, new oral drugs, apixaban, edoxaban, or rivaroxaban for selected patients. And sometimes we should prefer low molecular weight heparin because it may be the better option for some selected patients, especially in palliative care or patients with high risk of bleeding. We know that the new oral anticoagulants may be more effective during treatment of thromboembolism in comparison to low molecular weight heparin, in comparison to dalteparin. But the problem may be associated with bleeding. Some patients should be understood at the risk, and the guidelines showed us the examples of the patients who should be understood at risk. High risk is dedicated for patients with GI, GU cancers, the patients with renal dysfunction or liver metastasis, liver dysfunction, and of course patients with thrombocytopenia. And very shortly, as you can see, conclude from the clinical trials, randomized clinical trials, especially edoxaban may provoke a significantly higher risk of bleeding in cancer population, and sometimes rivaroxaban could lead to the bleeding. Caravaggio study confirmed only that the risk of bleeding may be the same when we use apixaban and dalteparin. The special population, in my understanding, are the patients with thrombocytopenia, hematological and oncological patients, and we should prefer low molecular weight heparin in reduced dose. And this is the good question how to reduce the dose, because we have no enough data. We can, based on expert opinion, we can read the guidelines proposed by European Hematology Association. I was proud because I could write these guidelines together with my hematological colleagues, and we can, based on the guidelines proposed by ESMO, European Society for Medical Oncology, Anna Falanga, my colleague from Italy, proposed together with other co-authors, proposed very clearly decision-making algorithm when we have the patients with low risk of thrombosis complications. We can stop anticoagulation and or reduce the prophylactic dose or intermediate dose, half dose of therapeutic low molecular weight heparin dosing. And when we treat patients with high risk of complications related to thrombotic disease, we should try to use optimal dose of anticoagulation and sometimes to consider platelet transfusion. So this is the population with thrombocytopenia is very problematic, and personalized approach is necessary. And the last questions, how to see the patients during long-term anticoagulations when we consider the anticoagulation to the end of the life. And we know from ESMO guidelines that patients with active cancer disease should continue anticoagulation. And ESMO guidelines suggested 2 years ago the optimal dose of dalteparin, enoxaparin, or rivaroxaban, or apixaban, but I feel that now in this year it should be changed because we have new data from this trial. A few years ago we proposed the APICAT study. This is the very well construction of the study. We compared the reduced and optimal dose of apixaban during long-term anticoagulation, and this year we published the data. New England Journal of Medicine approved this data, and 2 Polish co-authors were included. And we had the very specific oncological populations, mainly with metastatic disease, mainly with breast, prostate, colon, or lung cancer. And the design of the study was non-inferiority. So we can conclude that the reduced dose may be the same efficacy in comparison to optimal dose. This is very promising data. But the secondary point was the risk of bleeding. And we revealed that the risk of bleeding is significantly lower when we use reduced dose of anticoagulation. So after the publication of this data, we should prefer to reduce the dose of anticoagulation, especially apixaban, when we use long-term anticoagulation. And the problem may be seen in patients with hematological malignancies, with metastatic and advanced cancer diseases, and with low performance status, exactly as defined 2 or more points. So patients with wrong prognosis and with not beneficial response to anticoagulation, as was confirmed by this data from Hokusai study. And my last study, which is possible to continue thanks to the grant from European Union, thanks to cooperation with the colleagues from UK, we try to define the moment how to stop anticoagulation. We try to define the moment when the risk of bleeding in advanced cancer disease is so high that the benefit from anticoagulation is lower in comparison to risk of bleeding. Very interesting design of the study, multidisciplinary study, because I was included as cardio-oncologist. We have the great team from Netherlands as oncologists, hematologists, from palliative medicine specialists, geriatrics specialists, and I hope that in a few next year we will be able to define a moment to stop, discontinue anticoagulation, because the problem is bleeding. We have many reasons in oncology when we should expect the bleeding instead of benefit from anticoagulation. And last problem, very quickly, primary prophylaxis. The huge problem and not explained in current oncology. We know from the ESC guidelines that we may consider primary prophylaxis when the benefit is higher in comparison to the risk of bleeding. We have very old coronary score based on the type of cancer disease that results from morphology and body mass index. Everyone knows in the world that this algorithm is not enough for our daily practice, but we still use that algorithm. Very important study came from Canada and other colleagues, published in New England Journal of Medicine. We can conclude that the using of prophylactic dose of apixaban may be very effective because we can expect significantly reduce the risk of thromboembolic disease, the first episode, but the problem may be associated with bleeding because the risk of bleeding is maybe significantly important. And very interesting study, we still try to find the most optimal tool for evaluation the risk of or indication for primary prophylaxis. As you can see, by adopting new tools, we can conclude which patients with low risk may not be treated, may not be under anticoagulation, under primary prophylaxis. And other side, we can conclude which patients should receive primary prophylaxis independently of the risk of bleeding. And my conclusion, we should reduce the dose of anticoagulation during long-term therapy management. We should modify or discontinue anticoagulation in selected patients, and we still need more data, more algorithm, more risk stratification for the definition how to use primary prophylaxis. Thank you once again. I'm not sure. Okay. I would like to thank everyone who decided to come here. I see in the room many friends from different centers. I appreciate that you decided to take your time, to dedicate your time to visit our center and discuss with us, follow us, my friend, during discussions during that day. Special thanks for our international guests. I believe that this is not the end. I would like to see you next year, and please be invited. Thank you. And our proposal for the future, of course, we will try to organize the next meeting next year, but as my colleagues mentioned, we have the special national network for oncology. We have 16 cancer centers in Poland. Of course, our center is the oldest, built by Marie Skłodowska-Curie, but we have another 15 centers. We will try to combine our activity. Cardiologists from different sites from Polish centers sent me approval to be included in our activity. So I believe we will build our cardio-oncology on the background of medical cancer centers. I think that is the good decision and good resolution for cancer patients in Poland. And I believe that next year we will discuss about our achievement, our data collected together. Thank you once again, and see you next year.